Thank you very much for being here. We appreciate your time and your efforts on, I think, one of our most important things, which is our Medicaid programs and all that. So with that, we're going to go ahead and start with Q1 responses. Oh, they're written only? Okay. So you can look at these quarterly responses in your deal, and my computer, I forgot my password, so I'm a little bit dead there. So next we'll have, and there's a presentation here from Suzanne, and that's written only. And next, Stephen, you're up very quickly. So Stephen, welcome to committee.
Thank you, Chair Carpenter, members of the committee. I am Steve Anderson, Inspector General. I appreciate the opportunity to come in today and talk about the Office of Inspector General. I just want to say that our operating budget was supplemented in the last session that allowed for us to hire 6 additional staff members. Appreciate that very much. This allows us to start undertaking audit investigative work involving Kansas cash and food assistance programs as outlined or as approved last year in House Bill 2217. I do appreciate the support of this committee and other members of the legislature in getting that done. It was really important. To further assist in our efforts, Senate substitute for House Bill 2004 requires the Department for Children and Families, DCF, and the OIG to cooperate in the facilitation of detection, investigation, and prosecution of public assistance fraud and waste and abuse. And by exchanging information, that basically means that documents, records, EBT information, other information involving child care will be shared between our 2 offices. We anticipate there will be an MOU that will be created for that. And I think that's an important step forward for cooperation. I talk about this every time, but the majority of our complaints that we get, it's continued to grow, and the majority of them continue to involve beneficiary eligibility fraud. We are also starting to get referrals involving cash and food assistance frauds as well as part of that process because they're intertwined. People that commit Medicaid fraud oftentimes commit other types of fraud, including cash and food assistance. In 2025, we processed 1,557 complaints, with 1,352 of those complaints involving eligibility fraud. So far this year, we have processed 524 complaints, with 78 complaints ahead of last year's pace, so the number continues to grow. Every year it's been more and more. Part of it is because of our expanded authority, but also because people are starting to realize we exist. Because as a reminder, we didn't exist prior to 2021 in any really shape, form, and fashion. And we've done a lot of outreach efforts. We go out and do presentations. We put information out. We got informational brochures we put out in different places. So we are becoming a point of reference for people to contact us and report fraud. And we appreciate that. It allows us to see what's going on. And as pointed on here, sometimes we get things that don't belong to our office, and we refer them to the correct office, oftentimes within the AG's office. But we send referrals over to the KBI, some federal agencies, those sort of things. I've included a chart of our every audit and interim report we've done since 2021. You've seen that before, but also want to point out, if you're interested, every audit, every issue brief, every annual report we've ever done is available on our website, and that link is in the presentation materials. I want to talk about some of our ongoing audits. We currently have an audit going on involving DCF and KDHE sharing data. That audit is basically look to see how DCF and KDHE can share data on eligibility. That information is housed within the KEY system, so they have access to it, they can see it, and we just want them to work out processes where they can look at each other's data, because we know that some people tell a different story to the Medicaid people that they tell to the SNAP people, and it has to do with household composition, income, who's in the house, who's related to who. Those all have a bearing on eligibility. And we know that people tell different stories because we see it ourselves, because we can see that data. Our analysts can look at that and say, this person says that they're getting child care subsidies because they have a job over on the DCF side of things, but when we look on the Medicaid side, they say they don't have a job and they have no income. So why are they getting child care subsidies? So we're just seeing things like that. We're also looking at the Pregnant Women Program and looking to see if there are women who are on the Pregnant Women Program who, because of self-attestation, where they say if you're pregnant, you're pregnant. There's no question about it. We do know that there's some effort on the part of KDHE to get better clarification from CMS about what exactly does self-attestation mean, because it is said if there's information to the contrary that they can actually ask additional questions. Right now, they don't do that. They just basically take a person's word for it. So we're looking at the program in its entirety. We focused on 45 and older, and I've talked about this before, but we found that quite a few of the 45 and older have no pregnancy-related claims at all, never saw a doctor. And, you know, if you're a 55-year-old woman and you show up pregnant, probably ought to go see the doctor. That's a high-risk pregnancy. But we found a lot of these people had zero claims, they'd never seen a doctor, that would maybe indicate that maybe they're not telling the truth about it. But what it does do is it gets you on Medicaid for the term of your pregnancy as well as the 1 year postpartum coverage. So it gets you almost 2 years of Medicaid coverage. It also increases your eligibility for other programs like SNAP and WIC, and we've seen people do that. We've been looking at the 62 people of the 45 plus group who had zero claims that would indicate that, and it seems to indicate that maybe they fraudulently got on Medicaid. And then we're doing an analysis of what other benefits did they get as far as the SNAP and everything. And right now, we've been able to, because it's very time consuming, and trying to go through the KEYS system and looking in as well as in the KIM system. And unfortunately, like yesterday, the KEYS system crashed and nobody could do anything for the whole day yesterday. But we've been able to look at 28 of the 62 people, and so far we're already up, there's over $230,000 worth of benefits that have been given to these potential false pregnancy claims for other benefits, the light bill and WIC and SNAP and things like that they've gotten. And that's just 28 of the 62 we looked at, and we're already up to over $230,000 in potential fraudulent claims there as well. We had published an interim report in February on this issue about the 45 and older, and we found that the capitation payments for them were added up to almost $800,000. And so we're going to continue to look at, we will be opening criminal investigations on some of those depending on the amount of loss and the circumstances surrounding that. Staffing wise, it's just not realistic for us to open cases on all 62, but we are definitely going to look at that. The next audit we're working on is the Home and Community-Based Services Audit. We call it Audit 2 because we did one and published it in 2022 where we found significant issues involving the Home and Community-Based Services program. There were a lot of people that weren't getting services at all. Some of them had gone for years and got no services, but yet they were on the program because they get a Medicaid. And if you're on a waiver, when they do the evaluation for financial, they look at the person's income only, then look at the household income. They only look at the person's on the waiver, so that makes people eligible for the program, but they don't want the services because they don't want somebody coming in their house. So we said, well, we'll take another look at it, and we were asked to take a look at that program. And what we're looking at now is whether assessments for things done. In that interim report that we published in January, we found there were an awful lot of people who had not had the required functional assessments. And we determined that the state could save a lot of money if they had those functional assessments done properly, because if they didn't have the functional assessment for various reasons, they shouldn't be on the program. And we estimated that the state could save about $36 million per year if they would move people off the functional, because the functional assessments, move them off of the waiver and into, maybe they're eligible for other Medicaid, maybe not, because the financial part of it would really matter. And part of the reason is if somebody's on regular Medicaid, the average capitation cost is around $500 or $600 a month. But if you're on a waiver, it's usually over $5,000 a month. That's why there's such a disparity in the cost. So if a person's on Medicaid and are on the waiver and they're getting really high capitation, but they're not using services, maybe they shouldn't be on the waiver at all, because that would indicate they don't actually need somebody to come and help them with their activities of daily living. We also found during that audit that there were a lot of overdue beneficiaries again. The average was 814 days being overdue. They're supposed to have annual assessments. So going 800 days over is ridiculous. And we found that there were 721 people who had went for more than 4 years without having an assessment, which shouldn't happen. Absolutely should not happen. So we're questioning that. We're currently, after looking at the brain injury, the frail and elderly, and the PD waiver, where we found all those problems, we're now looking at the IDD and other waivers, and we're finding problems with that as well. We have found that it appears that there's 42% of the people that are on the IDD wait list, not on the waiver, but on the wait list, should have never been put on the wait list at all for various reasons. Some of them are already on another waiver. Some of them don't meet the basic criteria. Some of them haven't had functional assessments. And we also found that 4.5% of them are dead. So maybe they shouldn't be on the wait list at all either. So we have dead people on the wait list. So we're trying to get some of that cleaned up, and we're looking at that very carefully. We are also looking at an audit on the pharmacy dispensing fees. We talked about that before. Doctors write scripts for people to get over-the-counter medications. It seems harmless. You help somebody out by writing a script, and they get fill their script for Tylenol or whatever their medication that they need, but it's over the counter, and it gets approved. And the issue is, though, is we pay a $10.50 dispensing fee to the pharmacy for doing that, and that's an extra cost to Medicaid, and it gets passed through to the MCOs. And it's actually been very tricky going through there because the MCO records are hard to follow, and there's disparities between how the MCOs operate and then looking at our own programs. But what we've been able to determine so far is the state of Kansas has spent about $16 million in dispensing fees over the past 3 years. And that's just an added cost to the Medicaid program because of giving over-the-counter scripts to Medicaid recipients. And I get, obviously, for prescription level drugs, you should get scripts and those should be paid for, but sometimes something as innocent as getting a $2 or $3 bottle of aspirin ends up resulting in costing the state far more than that. So we just need to evaluate. I mean, obviously, we're just putting that information forward. The legislature can figure out what they want to do with that, but that's just some of our preliminary findings. That report will be out pretty shortly. As far as investigations go, we currently have 314 cases that are under review or investigation. 7 involve state-level frauds or crimes, and 2 are federal-level cases that have been accepted for prosecution. We have far more that are in the hopper, waiting for prosecutors to accept them for prosecution. The case mix involves providers, state of Kansas employees, and child care centers that we're looking at. And I want to talk to you just about a couple of cases. We had one that just went through the process on April the 13th. Barbara Bennett was providing false information on her KanCare applications. The court found probable cause to believe that she did that, and she'll be bound over for trial. But the investigation showed that we had paid over $17,000 in capitation payments for her for lying about who she was in her household. Essentially what it boiled down to is her and her husband had divorced. The kids and the husband were in Colorado. She was in Kansas. She wanted to get on Medicaid, so she claimed that the kids were her. The court had ordered that the husband had exclusive custody of the kids. There's no way she had them. We interviewed her. She admitted that she lied on her KanCare application, resulting in that because she wouldn't have been eligible for Medicaid, period, given her circumstances, and we had KanCare back that up. She also received almost $2,500 in food assistance benefits as well, based on that false information of having the custody of the kids. Trial date has not been set, but I do also want to point out that defendants are presumed innocent unless proven guilty, so it hasn't been through court, but the preliminary hearing did find probable cause that she had committed this crime. That's why it's going to be bound over for trial. The second case was a federal one. Tamara Powers pled guilty in the District of Kansas to one violation of wire fraud, which is a typical thing that U.S. attorneys do. They will take all these other fraud schemes and turn it into a mail or wire fraud count, but you still have the same result. A joint investigation with SSAOIG and DCF and our office found that Powers had executed a scheme to defraud the United States and the state of Kansas by obtaining benefits through false statements where she received information or benefits under 2 separate identities. She had used the stolen identity of a deceased relative that died in 1977 in Texas to obtain supplemental Social Security information. She also got low energy income assistance and SNAP, as well as Medicaid benefits. Based upon what she had done, the United States suffered a loss of $137,000 in SSI funds, and the state of Kansas suffered a loss in amounting over $13,000 for LEAP, $27,000 for SNAP, and $273,000 plus in Medicaid capitation payments were paid on her behalf under the 2 identities. And she wasn't eligible for any of that based upon her circumstance. So her sentencing is set for June the 2nd of this year. And with that, I'd be happy to stand for questions at the appropriate time.
Committee questions? Representative Bryce. Thank you. I've been out of this business a little while. It'll take me a little
Thank you,
bit
Mr.
to
Chairman.
remember.
It's an honor to be the first called on. I had a couple questions real quickly. One is, you mentioned the IDD wait list might be inaccurate because of people who are ineligible that are on the wait list, and there's a certain percentage that could be culled from that. Do you have any idea how much the wait list could be, if this is extrapolated, how much reduction in wait list are we looking at?
Well, we know that the wait list, we have a tremendous high error rate, approaching 80% on the error rate for people that are on the wait list right now. That's an extraordinarily large number. We're verifying all that, but it does, and when you consider the wait list for IDD is over 4,000 people, if we're able to cull 80% of the people off the wait list, it would be a substantial savings.
So if I may, you're talking about a tremendous reduction in wait list.
That's right.
From 4,000 to 500 or something.
Potentially.
Okay, just one other quick question, if I may, Mr. Chairman. Yeah, I have personal experience in my earlier life of seeing people use other people's Medicaid cards to seek medical care. And being a busy physician, working 14 hours a day, I didn't really look into it. I just blew it off, but I didn't even know where to go to report this. But as you're speaking, I'm thinking about biometrics and different things that could, I guess you don't call that eligibility fraud, it's some other category of fraud, but, or maybe it's lumped into
Identity theft is
eligibility.
what that's called. It's called medical identity theft when you use somebody else's like Medicaid card to receive services.
So if other states are putting photographs of the beneficiary on the card to help with that, do you see, I know there would be a cost associated with that. Do you have any opinion on how much of that we could potentially cut out if we did have something, maybe not biometrics like a fingerprint, or maybe so, but maybe just a photograph like other states are doing?
I don't know exactly what the cost savings would be, but I do believe it would help because of identifying patients. And I know we see situations, my own doctor has a photo of me when I come in, they know it's me, but I also know that there's some doctor's offices that don't. One of the offices I visit, my brother could walk in and easily get services under my insurance, and it would be nothing to it. Having identifying information, better identifying information on the Medicaid cards would be useful in helping to stop some of the medical identity theft that goes on. It would absolutely, it'd have to help to stop that from people using other benefits. We hear a lot of, and it's conferences I go to and people I talk to from other states that are dealing with this, and where you see it a lot is with people who bring in children and not their children. And they say, well, this is my daughter, and it's actually the neighbor's kid who needs to be seen for various, like a broken arm or something, and they don't have insurance at all, but they're like, oh, this is my kid, so they get them on and they get services under that guise. It would be helpful in that arena, cut that out.
Makes sense. Thank you, Mr. Chairman.
Representative Ballard.
Thank you, Mr. Chairman. I want to talk about the pregnancy one. I think you indicated the person was on it for 2 years.
You could be, by the time you report that you're pregnant, so you get 9 months of coverage based upon the pregnancy report, give or take. And then you're automatically moved on into postpartum care, which is now a year. So a person could be on for almost 2 years based upon that alone.
My question would be, all right, we can't question if they say they're pregnant or not. But at one point, because I think I asked that question last time we met about it, and someone indicated that they don't have to verify it. But at some point when you're paying the bills, if a person is on for a year or longer, do you not look for maybe a hospital bill or something from a midwife or something along the line in that respect? Or if it's an older pregnancy, you can't treat that any differently, I don't think, than a young pregnancy, I guess. But if it just went on for 2 years, was anyone not checking anything on the payments?
Well, no, they weren't. We did, and that's when we found our problem. So, if you're looking for a job later, I might could use you because you're thinking the right way, Representative Ballard, of doing that.
Fine, but thank you for the offer.
You're good? Okay. I appreciate that. But yes, I mean, that's exactly the thing is we know that the eligibility office at one point actually did pull the claims data and then stopped doing it. We're not sure why, but they did actually used to get that data and they stopped pulling it. But yes, it reveals that the person's not had any claims. The self-attestation piece where they do that, and the way CMS rules come down and says you have to accept self-attestation unless there's information to the contrary or different. And that's why we were making the point, if somebody's 50 years old, maybe that's enough information to the contrary. Now, I do know that KDHE is communicating with CMS, trying to get clarification of that rule to get better, like, hey, can we actually push that? Because that would be one of those things that I think we could all agree, if somebody's that old, we've had a few people up to 60 years old, and there's 0 questions asked. It's like, well, you're pregnant, fine. And then they stay on there. And then what is further confounding about this is the person says, well, my projected due date, let's say, is March. Comes March, they have a report that they look at saying, well, this person should be delivering or reporting a live birth or something's going on. They attempt to get a hold of them. If they can't get a hold of them, then they just say, okay, well, we'll just go off of that date, and then they continue with the continuous eligibility for a year after that. Even if they couldn't get a hold of them, they leave them in the system. That's a finding for us, is that needs to be done differently. If you can't get a hold of the person through whatever means, they should be kicked off the program, not kept on the program because we just couldn't find them. And again, they're not getting claims, they're not doing anything, but what's happening is we are continuing to pay that higher capitation to the MCOs, and that's money the state shouldn't just be paying out.
Okay, Mr. Chairman, just one follow-up. All right, I understand, and then you have the one about Barbara Bennett, which seems that hers is probably 22,000, and then the last one is the 273 or 93 or whatever you said. What's the frequency of this? What would you say would be the percentage of someone who's faking a pregnancy in order to get money or any of those other things? So is this rarely happens, or does it happen all the time since you just reported it? Because in all the years I've been here, I have never heard it being a large number. Not that you shouldn't be looking at the small number or the one person or the two, but what would you say this happens often?
Well, it falls into the category, sometimes you don't know what you don't know. And I would want, there's for a little bit of a history here. Prior to fiscal year 2024, my office did not have investigators to even look at this type of fraud. And prior to that, nobody was investigating eligibility fraud in the state of Kansas, period. There was nobody doing it. So I've said this before, if you don't look for something, you're not going to find it. We're looking for it now, we're seeing it. And the more we do, the more we find. And as I get additional staff, we're able to look at things. Like I said, we've got over 300 matters open right now where we're looking at fraud. And if I had the staff, I could have another 400 or 500 cases open easily. We see so much coming through. These 1,500 complaints we processed last year, I'd say 20% of them are legitimate cases that should be investigated, but we just don't have the personnel to do it. So we have to push them on over to the clearinghouse and say, hey, you guys see if you can figure it out, and if there's some way you can remove the person. But we just don't have the investigative resources to go out and actually make contact and do the subject interviews, pull the paperwork, and do the various things to verify information. It's a staffing issue. And I also want to point this out. DCF has 14 investigators that are doing nothing but, it's like SNAP fraud investigations. I have 4 doing eligibility investigations for Medicaid right now. Medicaid's a $5.5 billion program. SNAP is about 500 or 600 million. So a far bigger program with a lot less resources. So to give you a percentage of how much of this is actually going on, don't know for sure. I wish I could tell you, give you a hard number, but it is a fairly common occurrence. Now, there's a lot of good people out there on the program. They should be on the program, and they're doing everything right. But the fraudsters out there, the conservative estimate we see a lot is like 10% of programs like Medicaid are lost due to fraud on a scale. So that's a nationwide number that gets thrown out there.
You don't really have a number, whether it's 25, 50, 150.
Well,
we don't have a number of how many people actually do this.
On the over 45 pregnancy thing, over half of the ones that we looked at that were 45 and older were apparently committing fraud. That's over half.
Thank you, Mr. Chairman.
Representative Sutton.
Thank you, Mr. Chair. I just wanted to clarify, you talked about 16.5 million being paid by Medicaid for dispensing fees. Was that only for over-the-counter medication? Okay, very good. Thank you very much.
Representative Bueller.
Thank you, Mr. Chair. I'd like to go back to the HCBS waiver audits that you're working on, and I don't see the information that Representative Bryce was talking about in this document in your submitted testimony. Is there a way we can get, even if it's kind of a point-in-time analysis of what you're looking at in the IDD world? And the reason I'm asking is if I play back the last 4 years, the legislature has put tremendous resources in play to reduce not only the slots that are on that wait list, but also the money that it's taken to get people to provide those services. So I'm a little troubled that while we've put that much energy into fixing that issue at the state, that there's a part of it that we may not be seeing from a legislative standpoint. So is the report available? Are your findings available? Or is there a way we can get a look and interpret that so when we come back in January and we assess what we need to do for the 7 categories, I'd really like some more fidelity on the IDD and specifically.
No, sir, I appreciate that. Our intention is to publish another interim report with some of that information in it, probably within the next month, month and a half. The full report of the entire program will be available well before that, before the legislature comes back in session in January. I assure you of that.
Okay, all right. Thank you. Thank you, Mr. Chair.
Senator Gorsuch.
Thank you, Mr. Chair. Thank you, Steve, for being here. When I reached out to HHS, what they shared with me regarding pregnancy and self-attestation is precisely what you said, only in a little bit more detail, in that if we have reason to believe, like you said, if you're over 50, we would have reason to believe to question if you're expecting a baby. And so they said that you can definitely ask questions, and they encourage you to ask questions if you have any reason to believe that this may not be true, and also encourage that we keep an eye out for doctor's appointments with a gynecologist or, you know, something of that nature, because of course one could greatly benefit from saying, hey, I'm pregnant, so therefore I want housing and I want food stamps and I want all of these other things. I'm glad that we are looking into, you know, specifically, may we do this, may we do that, may we do this? And I think we could do a lot more than we think we can.
Sure, yeah, and like I said, I know KDHE is looking at that, trying to
Yes.
get clarification from CMS. It's going to be one of the findings in our report and recommendations that they change that process so that they actually question things like that. And we're also going to recommend that they pull those usage reports to look for people who are not getting, examinations, certainly for people that are above a certain age, but, 35 and older is considered a geriatric pregnancy. And it just seems like it would be common sense. And then also, where's the MCO at on this too? You know, they have people that are supposed to be managing people's cases. And I think the MCOs bear a little bit of responsibility in looking at that and saying, if you have somebody that you're paying, they're on the pregnant woman program, and if your case manager is looking at them, I'm pre-diabetic. My insurance company aggravates the tar out of me about, am I getting am I testing my blood sugar? Do I need supplies? Because Blue Cross is following me and making sure that I'm being compliant with the program to control my diabetes. I don't understand why we wouldn't expect our MCOs to do the same thing with people who are on the pregnant women program, particularly somebody who's in a geriatric pregnancy realm, that we should be following them carefully to ensure that they're actually attending the programs. We know that some women do not want to go see the doctor, particularly if they have problems. Let's face it, there's some drug use and things that goes on. And if you're a woman who's abusing drugs and pregnant, you don't want to go to the doctor and be chastised by the doctor for, hey, you need to get off of the drugs if you're going to be carrying this pregnancy. And we know that that's one of the issues that goes on. Some people just don't want to go to the doctor. I also get that, but if you're pregnant, you should. You know, Kansas has a higher infant mortality rate than we should have. And part of that could be solved by having proper prenatal care. And it's there, it's free, go.
And my second question and last question, Mr. Chair, is we do not want to, or I guess, do no harm, very important. As we're doing these investigations, extremely important. All of us at this table want to make sure that the people's dollars are being spent the right way, and that's why you're there. But we do hear from the IDD community. I'm asked to be reevaluated every year. My child's situation has not and will not change. And, again, we want to make sure that eligibility is there. But do you know from your department, if not, I could ask the department here, what, if anything, has changed with the IDD community? And I know that we had looked at a bill that said they would be exempt from the 3 months or the 6 months of looking at their eligibility. Do you have anything to say about that?
In some of our interviews we've had with MCOs and with the people who do the functional assessments and with certain people, I think it's an interesting thing is the state has to do these functional assessments. They do the functional assessment to say, hey, look, this person appears to be functionally eligible to be on a waiver. It goes over to KDHE. They do the financial assessment. Yes, that goes then to the MCO. Then the MCO does a more in-depth functional assessment. And it's like, so the person ends up sometimes being assessed twice within a couple of week period. And I get it, that's frustrating. And also for somebody who has a condition, let's say just somebody who's autistic. And it's a burden for the family to make that their child or this adult who has autism available for all these functional assessments that have to be done, because the MCOs are also doing annual functional assessments. So can we find a way, and that's going to be one of our recommendations, is to look for a way to eliminate one of those functional assessments so that people don't have to go through multiple annual assessments per year to avoid that. I think that would be help.
For a member whose condition does not and will not change, for them to go through this, and the family worrying, are we going to lose services, is extremely stressful. I'm pleased to hear that. Thank you, Mr. Chair.
Senator Petty.
Thank you, Mr. Chairman. On the pregnancy, I was just, our pregnant women, you have that chart on page 3, and you mentioned, and so I'm trying to reconcile that chart that shows 3 potential cases.
No, ma'am, that was findings.
Okay, findings, and 4 for recommendations, but I assume that's for further review, referred to other offices. 4, is that correct?
I want to make sure we're talking
I'm
about.
looking at page 3, the chart right above. Is at the top of page 3?
Sure.
Interim?
Yes,
and
for pregnant woman.
women. So when you mention 62 in your presentation, but here I see it's 3. Which is that?
Well, that's 3 recommendations were in our report for changing policies and procedures. It has nothing to do with the number of people who may have committed fraud.
So this table has nothing to do with fraud?
Well, it shows to do with our audit report, the interim report that we did, and it shows that we made 3 recommendations to KDHE for how they could improve the processes, and then we had, 3 findings, and then 4 recommendations, but it has nothing to do with the number that we referred for fraud, or we have 62 cases, as we put on our narrative portion, that we think that are fraud, and we're going to do further investigation on.
Okay, but I'm still not reconciling this 62 with the 4.
Four's
4 that are
recommendations.
Recommendations for
Changing policies, like for example, getting with CMS to confirm what they can do under self-attestation.
for only 4 cases, not
No, no.
62.
That was how many were in the interim report. It has nothing to do, it does not tie back to individual cases at all.
Oh, 4 recommendations. What were the 3? What does the 3 stand for then?
Findings, like policies that weren't being
Findings of-
followed and that sort of thing.
Okay, so this table then actually has no number of people.
Correct.
Okay. And then you were talking, and there was Senator Gossage just, or I think it was, mentioned about the functional assessments. But there's also this issue that continually comes up about staffing and having enough staff to be able to do the assessments. Has that ever been part of anything that you've looked at?
We hear that there is a problem with finding this number of assessors to be done, but the assessments do not fail because of that. The MCOs that we interviewed were able to do their functional assessments as required when they were presented with them or aware that they needed to do them. We also know that the state apparently had a problem. That's one reason I think they changed contractors. The client said they changed contractors because of that. The new contractor is catching up on the assessments. But a lot of the assessments that we found that weren't being done is because of tracking in the KMIS system, which we identified in 2022 was flawed and did a very poor job of identifying people for assessments. And that's where we're finding a lot of the issues now is the KMIS system data is not very accurate and has led to people slipping through the cracks, like those 700 plus people that went for more than 4 years without an assessment. That was because the KMIS system didn't identify them. What we identified in 2022 is that KMIS would send out a single notification this person was due for an assessment. There was no tickler saying, hey, 30 minutes down the road, we still don't have that assessment. It just, one notification, that was it.
And then you mentioned about dead people on the wait list. Was that referring to the frail and elderly wait list?
IDD. There were over 4% of the people that we were looking at on the IDD wait list are deceased.
4%?
4%.
And then you mentioned a figure which I'd never heard before, and I think Representative Bueller referred to this as well, that about the IDD wait list, an 80% error rate. I've never heard that number before.
It's because it's new information.
From?
Based upon our audit work that we're doing, that's an interim, that's preliminary work. I want to stress that that's preliminary. We're verifying it, but that's preliminary. It will be in our final report that we put out. Well, the exact number will be in there.
Okay, thank you.
You're welcome.
Senator Erickson.
Thank you, Mr. Chair. Thank you, Steve, for being here and for this report. Just a couple of quick questions to follow up on Senator Petty's question. 4% deceased is what you found on that. Have they been removed?
We're in the process of identifying to the state. Yes, we're working on that.
Okay.
I can't say for certain they've been removed as we're speaking, but we have identified them.
Okay, thank you. On the chart on page 2 and 3, I just want to verify, I understand school FFS, is that fee for service that we're paying through Medicaid versus MCO coverage? Is that what that refers to?
Yes.
Okay, and if we look at the bottom where it says totals, so 89.2 million, that's the total just for fraud, correct?
Yes.
And then, well, if I can, so in each of those totals, that's just for that column. If you add up all of those, the total for fraud, savings, waste, abuse, do you know what that total comes to?
No, I didn't add it up before I came here today.
I thought so, I did. And sometimes we look at a chart and we look at so many numbers in the legislature. I really want this to sink in because I'm on Ways and Means and we look for ways to cut. We celebrate and think we're doing great work when we cut on paper, $200 million off the budget. You add all of this up, waste, savings we could capture, the abuse, $713 million. $713 million that's going out the door that shouldn't be. We need to let that sink in. What could we do, legislature, with $713 million? I propose giving it back to people in property tax and other tax relief. But I digress. These are just the audits that you've conducted and the reports you've done. How many more areas could you examine if you had the staff and resources to do so, to identify more of these types of opportunities to be good stewards of our taxpayer money?
A lot more. We have over 40 audits that we like to perform on our audit queued up list. And we haven't even scratched the surface over with some of the things going on in the DCF world with childcare and other programs that need to be looked at that have not been well vetted. I'll just put it that way. So there's money out there that could be looked at. We find that there's a lot of programs, and oftentimes we hear, well, the federal government does audits. They do. They do a perm audit with KDHE, but they do the same reliable audit. KDHE knows that that audit's coming. They know exactly how to prepare for it. We are auditing areas that typically don't get looked at by the federal government, and that's why we find issues with some of the things we're looking at. Or there are audits that were done by the federal government 15, 20 years ago. I was doing some research the other day, and I pulled up an audit that was done by the federal government involving DCF's childcare operations. It was done in 2014. They had substantial findings in there of how the childcare program was being poorly administered and run, and they haven't done anything since involving that program. So I think that is an area that would be ripe for a very comprehensive audit, performance audit like we conduct, to find out what's going on with the child care program.
Thank you. And I just want to thank you for all of your hard work. Please relay my thanks to your staff. And I am going to challenge the legislature. We know these areas. You're doing your job in identifying them. It's our turn to do something about actually taking steps to stop the loopholes that's allowing this to occur. So thank you, and thank you, Mr. Chair.
Committee, further questions? Senator Petty.
I just kind of want to follow up on the question that, or something that Senator Erickson just said. So she had added up these totals and said there was 713 million savings on the charts on page 2 and 3. Of that 713 million that she's mentioned, what are those are federal dollars?
Part of it is federal dollars. There's no question about it. When you
How
consider
much of that is federal
Well,
dollars?
currently, rough figure, 60% of it's federal money, 40% of it's state money, but not all of it is. Like the CCRC thing, that's 100% state money. There's no federal money involved in that at all. So it varies on the mix. But yes, on a lot of these issues, when we see waste involving like the HCBS program, 60% federal, 40% state. But it's still, as a taxpayer, I pay a tremendous, as I was reminded on April the 15th, I pay an awful lot of federal taxes.
Right, but we can't talk about that being savings for state property, for property taxes in the state of
Well,
Kansas.
I tell you
if
what
it's
it is.
federal dollars.
If we stop the hemorrhaging of money, we don't have to pay that money back, because the federal government, when they do these audits, they come in and say, state, you owe that money back, please.
What have we been asked to pay back?
It's happened. We've had other audits where that's
What have we
exactly-
been asked to pay back this year?
I don't know about this year. I don't
Okay,
track
that's
the
the
federal
question.
audits.
You brought that up, so if it's not this year, let's not refer to it then. I would just mention that when we talk about staffing, in our last year and this year's budgets, it's now a total of a 3% cut for both KDHE and DCF. So that does affect staffing and the ability to do the work. So if we're looking at spending more money for staffing, we might want to think about how we are actually funding the programs that the departments we already have, and that would be KDHE and DCF. In order to work with you and together, they have to have proper staff as well.
Committee, further questions? You're not off the hook yet. So when you're talking about going back to the wait list and the testing, MEFI and BASIS and all that, so the MCOs still do their annual tests.
Yes, sir.
So, I mean, I'm not saying that it's not KDAD's responsibility to do those tests, but those folks are being tested annually by the MCOs. Is that correct?
I'm going to give you a yes or no, sir. We understand that when they were identified as needing to be tested, they were tested. But there's problems with that. We have found a lot of discrepancies in people who still slip through the cracks because they didn't come up on a list saying, hey, this person needs the assessment. And then with the changes of MCOs, some people fell through the cracks. So no, there's not definitively that 100% of the people got tested by the MCOs either.
Okay, and,
Wish I could tell you that was the case, but it's not.
okay, and so going back to the wait list, how did you identify the 4%?
That were deceased? By just going through and doing, pulling a valid sample, statistical sample. We went through and just actually ran them, and we found by looking in the system that they were deceased in the key system, they were deceased, had been registered deceased, but they were still on the wait list the KDADs had. Because, see, KDADs doesn't have access to keys.
Yeah, that's been an ongoing problem that we've talked about. You know, one of the things, when we did the wait list study a few years ago, we found that only, and my numbers may be a little bit off, but less than 30% of the folks responded to the study, which is alarming to me, that we have 5,000 people on there and only 30% of them that we've heard many, many times about. They've been on the wait list for 8 years at a time, and they still wouldn't respond to a
That's because they were dead.
to a survey or to a questionnaire. So that in itself has been very alarming, and I've been working with KDHE because we know that 67% of these folks are on Medicaid. So it seems to me like if they had Medicaid claims, you could cross-reference those claims and at least get an address or a contact or something. So I think there is certainly some room for improvement on that wait list. So I just want, but so the 4% that you identified, you just did that off your own. You didn't use the wait list, the study or any of that.
We have the wait list. We looked at the people on the wait list. We pulled a sample. We ran them in keys because we were looking for other issues with them. And we found, oh, that person's deceased. Oh, that person's deceased. And that's how we identified them.
Okay. Committee, further questions?
Just a comment.
You may.
That's really not surprising because we know that people are on that list 8 years or more. And we have been saying in the legislature that people are on that list so long that they're going to die at some point because they just stay on and on and on. But I guess I would agree on one part that we should be able to know how active they are by the services they receive. And because there's so many services that they can, that's why the community support would help out in many ways. But I guess the issue of if we send people to self-report that they are still there, if we're paying for them, we know they're still on. But the question might be, is that person the one who was receiving the benefits, or is someone else receiving the benefits for them? And that's what we need to find out. But I still think we overemphasize how much fraud is going on. Because it sounds good and we need to. And often we refer to it as the people's tax money. You know what? My money is in there too. So it's really our money that we are talking about, because I don't know if any legislator was exempt from paying taxes because they were elected. So I think we have to look at it in terms of our money, and I know it's their money, but in my community, I say to people, our money is what we're talking about. So I'm just as protective about what I'm putting in and how I would like it to be spent as they would. And that's where we have to kind of realize, how do we balance that out as well? But thank you, Mr. Chair.
Representative Reeves.
Thank you, Mr. Chair. Good morning, Inspector General. Um, I was listening, and as I was driving in, and there were some things that I heard about the IDD wait list that just blew my mind. One, that 4% is projected, that 4% of the people on that wait list are deceased, correct? There was another stat that you gave about, I can't remember everything that you said, but it was something about, if you look at that, then it would bring the wait list down to 500?
Correct. That was,
What was it that would bring it down to that?
that was the number of people who,
Error
because of the
rate?
error rate.
Yeah.
That we were seeing, people not having the assessments done, or just various issues, a lot of it not timely removal. One of the other stats I think I threw out there was that 42% should not have been on the wait list at all because they didn't meet the basic qualifications, but yet they were on the wait list. So that would cut the wait list almost in half if we did that. And the wait list now for IDD is well over 4,000.
Oh, yeah. Okay, thank you.
You're welcome.
Committee, further questions? Well, just from my point of view, any fraud is actually taking away from the people that actually deserve and have earned the services. So I'm certainly not afraid, or nor do I believe that anybody should be afraid of accounting and making sure that the people that are receiving the services are eligible. And so I don't know why we would have an issue with folks that are fraudulently gaming the system or not entitled to those services. So that's just my own soapbox, and I'll get off of that now. Committee, further questions? All right, thank you very much, Stephen.
Thank you, committee.
Okay, next we have an update from Madam Secretary Stanek. Welcome to committee.
Good morning. Good to see you all. I'm going to cover most of this presentation and then turn it over to Yvonne Case. Just to acknowledge Christine. She was selected, I think you might know, for the prestigious Medicaid Leadership Institute. She was one of 6 in the country, and she's finishing, I think, her last week. So she's been doing that for a year, so that's why she's not here. We have quite the packet of information. You have a follow-up packet and then some other things, and then I have an army of our leadership team here who are awesome that I might have to refer to if I get stumped on some of these more technical questions. But on the agenda on page 2, you can see what we'll be covering per your request: pharmacy dispensing fee, the drug rebate program, fraud, waste, and abuse, and what we're doing proactively, DME and that work group that was created, the durable medical equipment, and federal changes. And then Yvonne will cover the eligibility, the pilot project for Gainwell, which is our intermediary, Center for CMS Hub, which we transitioned to this year, and quarterly updates, again, have been written updates only that you have in your packet. So we have quite a bit of information to cover. So on page 3, we start with the pharmacy dispensing fees. These are meant to offset cost to dispensing medications. So those costs include labor, equipment, building, and delivery services. State Medicaid programs, oh, I thought you were raising your hand, sorry, can set their own fees and policies within federal guidelines. So again, we are always within federal guideline requirements. Currently in Kansas, that is $10.50. It's been that way since 2017. Federally requires, the federal government requires that state use cost-based data to establish those. So the most common approach for fulfilling this requirement is to do a survey, dispensing fee survey about what's being dispensed. In Kansas, in our Medicaid program, we have a third-party expert that conducted the most recent survey in August of last year. And that is available on the website, published, and it's a rate with a rate study under the data and policy section. So this survey, done in August of 2025, found that overall, the dispensing fee of $10.50 was lower than average and medium for all pharmacies. So the average weighted by Medicaid volume cost was $13.15, and the median weighted cost was $11.65. The survey also evaluated the difference in operating costs as well as costs between independent and chain pharmacies. So on page 4, you'll see that survey, based on that survey, that KDHE is recommending a tiered approach to the dispensing fees to make more efficient use of our funding, back to the concerns about funding, and why, while we still ensure that independent pharmacies, especially those in rural areas, get paid appropriately to cover their costs. So through the tiered approach, there'd be 2 categories. Professional dispensing fees would cover the actual cost and dispensing medications based on the survey. So we would have a global fee of $11.38 that would be increased from the $10.50 that's been in place since 2017. And for non-chain independent pharmacies, that would be increased to $15.85. So the impact to making this change is that all funds be a little over $8 million, and then SGF would be 3.279, and then the FFP, or the federal portion, would be $5.1 million. So I'll stop there and see if there's any questions, unless you want me to continue.
Committee questions? Seeing none? Oh. Representative Ruiz.
Good morning, Secretary. Can you say more about how doing this tiered approach is going to help the independent pharmacies, especially those in the rural areas?
Well, they're going to get more. If you see, they're going to go up about $5, and this
Okay.
would help cover their limited resources a little bit more. Okay.
And who pays the fees?
Well, it's split out, but let me turn to my team. Does anyone know who pays the fees? We pay the fees? We pay the state. The state pays the fees out of the plan.
Okay.
Want to make sure I was answering it accurately. Okay?
Thank you.
Uh-huh.
Committee further questions? Senator Petty.
So, Secretary, that's why, I mean, if this would be approved, that's why we'd see that you've in that chart, there's that increase, state general fund of over 3 million.
Yes.
And then that would also bring in over 5 million from the
Yes.
feds.
5 million from the feds. Yes.
Thank
Yes, they'd pay more, back to the balance of the 60-40. Usually. All right?
Committee further questions? Seeing none,
All
continue
right,
on.
we'll continue on page 5 with the Medicaid drug rebate program. Federally, states are mandated to pay and cover outpatient drugs from drug manufacturers in the federal Medicaid drug rebate program, known as MDRP, in order to receive those matching funds that we rely on from the governors, or the federal government, sorry. So those manufacturers, or drug manufacturers that participate in the rebate program, must pay a base rate of 23.1% of the average manufacturer's price and rebates to the Medicaid agency. And there's the federal law that refers to that. And in addition to the base rebate, there can also be an inflationary rebate if the manufacturer increases the price beyond inflation. So the base rebate is shared by the state Medicaid agency and the federal government. And so any inflationary rebate goes only to the federal government, so the state does not have to pay that. So the trade-off is that Medicaid will get the best price of most payers for coverage of pharmaceuticals. And the caveat there is that Medicaid must pay for nearly all pharmaceuticals regardless of cost. So there's not a way around this. Usage may be managed by requiring prior auth criteria as established by the Drug Utilization Review Board, which we have here. It's a program and a committee. And that committee, the DUR, is responsible for implementing and operating the program and making recommendations to the Kansas Medicaid program overall regarding drug therapy issues, including whether prior auth is needed. That's a pretty typical thing for any kind of insurance program. This helps to ensure medical necessity is met and pharmaceuticals are used appropriately. So separately from the drug rebate program, the Medicaid agencies also may negotiate individual supplemental rebates in agreements with drug manufacturers. These agreements pay additional rebates beyond what is required by federal law and regulations, and they're also shared with the federal government. Again, they have to cover some of that cost. So in exchange, we receive preferred placement on the preferred drug list. The preferred drug list is common also in programs, and it promotes clinically appropriate utilization of pharmaceuticals in a cost-effective manner without compromising quality. So the three-legged stool of patient care. The preferred drug list is developed on safety, effectiveness, and clinical outcomes of drugs. Medicaid here considers this the net economic impact, the lowest net cost to the state of such drugs when recommending drugs for inclusion on the list. So that list is reviewed regularly, and drugs are added and taken off, just like the state health employee plan. So Kansas Medicaid ensures drugs across classes are available, different drug classes, and clinically appropriate, while using increased rebates to make the program most cost-effective. So the drugs which do not have a significant clinical meaningful impact therapeutically in terms of safety, effectiveness, or clinical outcomes may be excluded from the preferred drug formulary and be subject to prior auth in accordance with state and federal laws. And so that is how the drug program basically is covered, and the drug rebates are covered in our Medicaid program. And I'll stop there and see if there are any questions. And again, I may have to turn to my team. So,
Thank you for that. Senator Gossage.
Thank you, Mr. Chair. I'm going to go back to the dispensing fee.
okay.
One of the things that troubles me about this is I would like to see a breakdown. The cost of the reimbursement for the drug is the reimbursement for the drug. And the concern that I have is that, we often hear complaints from providers that, why is the hospital getting paid more than I would be paid for a doctor's visit, let's say, or something that I can do in-house? And they're just asking for parity. When I see here, non-chain independent pharmacies that they have to figure out a way to make their business viable, I understand that. But for us to say, we're going to give you over $4 more per drug for these, and then we don't have a breakdown as to if everybody was paid $11.38, how much more would that cost the state, or how much more would that cost the federal government? Could you get that for me?
Yeah, we'll have to follow up on that one, and we're noting that, and we will get you that. Okay?
Thank you. Thank you, Mr.
Thanks
Chair.
for your question.
Committee, further questions?
Clarification on,
Representative Ballard.
ask for a clarification. There's a discrepancy in what independent pharmacies are reimbursed as opposed to large chain. Am I correct?
Correct, and some of the advantages
So
that the
is-
large chains have.
That discrepancy because of that, because independent pharmacies are getting less, even though they're dispensing some of the same
And
kind
they're
of.
providing a service in rural areas, and that's kind of the quid, but we will get that breakdown. You're accurate.
Committee, further questions? Representative Sutton.
Thank you, Mr. Chair. Just a couple of questions here. First out, again, clarification here on the Medicaid drug rebate program. I'm assuming that this program is not inclusive of over-the-counter drugs, first off.
No.
Okay. That was an assumption, but I wanted to make sure that I was correct on
Over-the-counter's
that.
over-the-counter. So,
Also, on the dispensing fee issue, and this is one that I may have stepped in once or twice, do we have a definition of chain?
well, I have my own definition. I suppose I could.
Everybody has their own definition, but is that 3 pharmacies? Is that 10? Is that 100?
Be like CVS, Walgreens, those.
I know the examples, but I also know of pharmacies that own 35 pharmacies.
Okay.
Does that count as a chain?
Okay, I'd have to verify that. I cannot answer that right now, but I'll get that answer.
And I think that's definitely one of those devil in the details sort of things.
Yeah, it is.
And believe me, I stepped in this one, so
Okay.
that's why I'm asking.
No, good question, and we'll get that for you, okay?
All right, thank you.
Thank you.
Committee, further questions? Representative Bryce.
Thank you, Mr. Chair. Thank you, Madam Secretary. Had a quick question about the process question about preferred drug lists. And the preferred drug list is developed based on safety, efficacy, or effectiveness and clinical outcomes talk about factors indicating no therapeutic advantage. Some of those can be pretty subjective. I was just wondering about process. Who is it that determines what's more effective and not? Is there a committee? Is there a person? Just for my own.
There's a committee, and it's comprised of medical personnel, including our medical staff, medical MDs, as well as a number of pharmacists that are independently appointed. They apply, or we recruit them to the committee, and then there's our internal team as well.
Great. Thank you very much. Thank you.
Representative Ruiz. That was it. Well, while we're on that, Senator Petty.
So one question, it kind of generates another question. So earlier we heard with Mr. Anderson that there's as much as that we've been spending like up to $16 million through fraud on dispensing fees. So how would this have any impact on that, or do you have any comments on that particular fee?
I think it's a little different. I mean, this is about what we pay, but I'd have to see exactly or hear back what that was in reference to, related to paying for things that was the wrong cost or was the wrong drug or whatever. I'm not sure. You can follow up. I'll need to follow up.
Yeah, that'd be great if you
Okay.
could provide that information.
And I think where the senator was going with that, which the Inspector General was talking about, was dispensing fees for over-the-counter Advil or Tylenol or stuff like that. So is that a federal regulation, or I'm just concerned about how that happens. Would they not have the money if they had to go down to the pharmacy and purchase that for $3 versus another $10? I'm just trying to find out how that works.
I mean, if Advil was sold or an over-the-counter drug, are you saying that they would get the dispensing fee? How does that work?
If a physician prescribed it, but it was something that was available over the counter.
That's a good question. I'd need to verify that. I would not think so, but I will have to verify that, okay?
I would like I think
we
the
will
committee
follow up
would
on
like
that.
answers for that, so. Seems like a common sense deal that we wouldn't do
Yes,
that.
yes, we
But
have to have that for you.
But I can see situations where potentially the person, lower income folks may not have the ability to purchase the Advil or something like, that was over the counter. So, but I am curious if we wouldn't save money if we just gave them
Okay.
$3 and how that would work, so.
Okay, we will follow up on that.
All right, thank you. Committee, further questions? Seeing none, continue on, please.
Okay. Well, fraud, waste, and abuse, again, continuing to be a big national as well as a state concern. And Steve had just mentioned some of the work that he's doing, and I would just say that we are continuing to work collaboratively with the Inspector General's office on a number of things. Christine and her team have really focused in the last couple of years on trying to get ahead of some of the audits and keeping an eye on what's coming down federally that we might be vulnerable for an audit, or that we might be not focused on as much as we are able to. Some of that is staffing, some of that's just, as you know, Medicaid just is continuous. The things that pop up that we need to address never end. And so I just wanted to touch base on page 7 and talk about some of the focus areas. And so we are looking at new paths to address through policy, oversight strategies, utilization management, and eventually, hopefully, more technology to help us find some of the things that we might not find as readily as maybe we could be. So our current focus areas starts with the applied behavioral analysis, or ABA therapies, which has been referred to here for autism spectrum disorder. The Federal Office of Inspector General has been actively engaged in this area. auditing states around ASD or that disorder. The primary focus has been on what's known as these ABA therapies, and those are therapies, as you know, that help people with autism and other developmental disorders to help them build essential life skills back. Some states have had to pay back millions of dollars to the feds due to audit findings. And in our Medicaid program, some of the proactive steps that we're taking to address current policy in this area are aligning provider types that can evaluate and diagnose that disorder with current federal guidance in audit findings. This would be positive for members in reducing wait times. We're also clarifying physician approvals and documentation requirements in patient files, and we're reviewing MCO processes for auditing, how they're auditing ABA providers to ensure that their auditing aligns with federal auditing, and that would ensure medical necessity and medically necessary services are being delivered. We also are creating a work group with the MCOs to enhance oversight of ABA therapies and engage ABA therapy providers in policy changes. So we won't just make a change without engaging those that are closest to it. Some other areas on page 8 that we are focusing on fraud, waste, and abuse includes our program integrity areas, one being strengthening hospice utilization management to ensure the long-term payment of those services include the requirements for the physician validation. And the initial review that we've done so far indicates there are some opportunities for cost savings there. We're also improving alignment with our contractor to ensure all emergency services around labor and delivery claims are consistent with federal law. These actions created a cost savings of just about 150. There's a correction on that number, I think. The 300 was written ahead of, I think, roughly half of that number is really where we found so far. But again, an opportunity. The EPSTD, which is early periodic screening and diagnosis and treatment, monthly reporting, monitoring report, and you know this is a hot topic, and it's been very difficult to get our arms around, not just us with EPSTD, that we found a code through monitoring that was being incorrectly requested for coverage in the benefit program, and it was not aligned with CMS requirements and not covered in the CMS Medicaid program. So KDHE leaders met with MCOs to remove that code and train MCO staff on the current state clinical policy that exists. And in 1 month, that was a savings of $40,000, just to give you an example of some of the things they're doing. ILOS, in lieu of services, is a monthly report we run for MCOs monitoring the identified gaps in reporting. The most recent reporting showed that the Medicaid teams are working collaboratively to bring further auditing and tighter processes to ILOS reporting to ensure appropriate allowable services are billed under the ILOS criteria in alignment with CMS. And then partnering with KDADS, which we do on a regular basis, and that's a lot going on there too as well. We're working on a policy enhancement for waiver services and conducting utilization management to ensure claims are paid in alignment with state policy. So again, a lot of that cross-referencing of existing state policy with what's actually happening in reality. So again, a lot of work and workforce requirements there to keep ahead of this, but I wanted to assure you that we are taking steps. So I'll stop with that, with the fraud, waste, and abuse, and see if there's any other questions.
Any questions? Representative Sutton.
Thank you, Mr. Chair. I have two, actually. Mr. Anderson brought up some interesting and alarming statements regarding functional assessments. I didn't see in the waste, fraud, and abuse section here an addressing of functional assessments and them being done in a timely manner. Could you give us some information on what's being done to get those caught up?
I think I'm going to defer that to KDADS when they report.
Oh, good, good. I have some questions for them, too. That'll be fine.
Because I think that would be more appropriate.
Okay.
If you could get that, but because I do not have that specifically. Okay.
Very good. While we're on the topic, because they're listed as the final bullet point here, Could you go into a little bit more detail on, you said there was a lot there, but it was the smallest bullet point regarding working with them to make policy match reality. I'm curious, first off, when did reality split from policy, and what are we doing to get it back on track?
Well, I think it probably, there's always a potential. So maybe my choice of wording was, I didn't mean to alarm anybody like there was a big red flag, but I just mean in general, we have a lot of waivers. We have,
There are
we
red
have a lot of
flags.
waivers, we have a lot of policies. I just was trying to emphasize that KDADS and KDHE work together on trying to make sure that we are aligned. It's easy, unfortunately, to get away from or to recall what a policy might be or how, with turnover in staff, not just our staff, the MCOs and whatnot, how we're administering certain policies the states has. So we've tightened that process, is my point, in it related to fraud, waste, and abuse. So I don't have a specific big list to show you, but I can just meant we're collaborating more on identifying those things on the waivers and other things with the policy group.
Okay, I would like, and if you're
I
not
can be more
prepared for it right
examples. I
now,
can give you more
I'd love,
examples.
yeah, I'd love more information on that.
Okay,
Thank you.
will do. Okay, will do. Thank you.
Senator Gossage.
Thank you, Mr. Chair. Could you tell us who has authority to take action on any fraud that is found? I know that we've heard from Steve Anderson that he doesn't have that authority. Who does?
Well, we certainly do at the Medicaid program, but it would depend how large the fraud, we'd have to report it to the CMS and so forth. And let me ask Yvonne Case if she has any information on our specific process when that occurs. Thank you.
Good morning. Yvonne Case, Director of Operations, Medicaid, KDHE. So Mafuku has authority to declare fraud for certain things. So we make referrals, and so do the MCOs to them, and they do that. Now, if we find something wrong in a member's case, we can question that, send them a notice, and resolve that, if they don't respond, and take care of that immediately.
So if there is suspicion that's reported from the Inspector General's office to KDHE, that we suspect that this person is fraudulently doing XYZ.
We would send notice and follow the federal guidelines. That it doesn't always allow us to close, but if they don't respond to that notice, or if we have a question, we can close the case. Wouldn't necessarily be for fraud, but it would be for not reporting or not providing the accurate information that we have.
Okay, so there's a member. We've heard that they are fraudulently receiving services to the tune of, I'm making this up, $100,000. Now, who goes after this $100,000? What happens with this person? Who takes this person to court? Can you tell me?
We would send that over to Mafuku.
And I don't know what Mafuku is, I'm sorry.
Oh, Steve used to work for Mafuku. What does that stand for? Steve, the Medicaid? Can Steve help me out?
Yeah.
Steve, can we be friends right now? Okay, we're going to be friends.
A little clarification, MFUCU stands for Medicaid Fraud Control Unit.
Okay.
However, they can't do eligibility fraud. Their federal grant prevents them from doing eligibility fraud. They can do provider frauds, but they cannot touch eligibility.
Okay.
We make refers to the county. If we identify like some of the cases I talked about, we can refer them to the county attorney. We also refer them to a unit within the Attorney General's office for prosecution, or sometimes the United States Attorney's office.
Okay, thank you. That's what I needed. Thank you very much. Thank you, Madam Secretary.
I'm glad for the clarification on that acronym. I probably know,
A new word.
I probably know 1,000 acronyms, and that's a new one for me. So anyway. Senator Peck.
Thank you, Mr. Chairman. You mentioned in your testimony that in your presentation, Kansas Medicaid is taking proactive steps to address current policy based on audit findings in other states. Even if we do make adjustments based on audits from other states, the feds come and look at us and say, well, okay, you have fixed it, but prior you were out of compliance, there was fraud, waste, abuse, whatever. Do they still generally impose a fine or reimbursement, or do they kind of say, okay, you've fixed the problem, we'll look the other way this time? Do you have a feel or any knowledge of how that would play out?
If they came in and audited us, even if we fixed a process or had a process, and they found that we were erroneous 5 years later, we'd repay.
Okay.
Normally.
That would be an additional reason from my perspective for Mr. Anderson's group to find the errors, fraud, waste, and abuse sooner rather than later. So the penalty would be a reduced amount.
Yes, yes. And we are regularly, like I said, working with his office, regular meetings, trying to identify these areas in many cases and directing him maybe some things that he could help us with to audit and whatnot, because you can't possibly keep up with everything. And so I just want to assure you we are taking fraud, waste, and abuse seriously and trying to get ahead. In many cases, I'm pretty pleased about the processes that Kansas has in place and has had in place, not due to any recent changes, that to address some of these things and to get ahead of. And our policies are sometimes even more stringent than the feds require on some of the reviews and whatnot that's done. So.
Final question, Mr. Chairman. So these repayments, are they generally in full? In other words, you received, I'll pick a number, $20 million in excess of what you should have because of the fraud, waste, or abuse. Is it the full $20 million that the feds are going to ask for, or do they sometimes prorate that?
I don't believe they prorate it. I'd have to find that out for sure, but normally if you owe, you owe. Okay.
Senator Erickson.
Thank you, Mr. Chair. Thank you, Secretary, for being here today. Just a couple of follow-up questions along the same lines. How many people do you have in your department that investigate fraud, waste, and abuse, or look at these cases that come from the Inspector General?
It depends on what area. It depends on what area of the Medicaid program we're talking about, where that would go. If it's, for example, the pharmaceutical, area, it would go to a clinical team that's what, 3 to 5? We have 7 nurses and 4. So, thank you. That's our Director of Clinical Services. And so it would depend. If it's something in KDADS, then it would go to the specific unit over there. So we don't have, I think what you might be asking, is there a whole unit that just does this stuff? And there's not. It goes pieces and parts to whatever unit the fraud and abuse identified would be, or suspected would be focused on.
May I follow up, Mr. Chair? So that's if an issue has been reported to you. Then you have a team that investigates an issue that's been brought to your attention. On the proactive side, how many people do you have? Is it just the people who are processing the paperwork if they see something suspicious? How many people, how many eyes do you have on that?
Well, with the, let's take the example of the ABA therapy. We would have our clinical team looking at that, for example. So that's the autism spectrum disorder reimbursement type of thing. That would be a collaborative. And Shalay, you're welcome to come up and add to that. I'll have Shalay introduce herself.
I think what I'm trying to get at is what systemic measures are there for the proactive prevention of making sure that we minimize what the Inspector General is finding?
Good question, Senator Erickson. Good morning. I'm Shalay Harris. I am the Deputy Director for the Medical Bureau here at Kansas Medicaid. As a result of, and I think Christine mentioned this to you in the fall, as a result of the clinical team moving from policy and to oversight of utilization management, we have been doing a proactive oversight of all our programs. Actually, Senator Erickson, it's one nurse currently that is overlooking proactively the ABA therapy program. She is assigned to that with a backup nurse, working collectively with our MCOs on all those steps that the Secretary has mentioned here. Every nurse is assigned a program. Some of them carry 5 to 6 to 7 programs apiece. And that they are responsible to bring oversight to not only program, but they do a clean and thorough assessment of all policies, federal regulations, anything that they find in claims data, working with our data team, and on and on. So they're very busy amongst all the other Medicaid activities that pop up as well. So that's our proactive activities that we do.
Mr. Chair, and do you keep data on that, on how much they find? Do you keep any data on the numbers on that?
Yes, we try to. Currently, I've been asking them to keep data on the cost efficiencies that they're finding, so we can bring that to leadership. And we're working with our new finance director, Monica Hunter. I'm hoping that we can bring some of that to this committee.
That would be wonderful. And so this is fairly new. This hasn't been in place for years.
It's a bigger emphasis on this area, absolutely. And I think, and Christine would tell you too, we don't always want to bring the bad news. We do want to bring good news, so you can return some of that money to programs or reinvest that money, our money, to your point, back into programs and make sure people are getting the services that they need. So yes, and this was a major step forward for the clinical program. We're stronger in that area than we've been in many, many years, and are redirected to Shalea's point, and change that from not just a policy review, but to a utilization review, which is much needed in any insurance program.
Very good, thank you. Senator Petty.
Thank you, Mr. Chairman. So you have on page 8 there, under fraud, waste, and abuse, the cost savings that have been created, and the question, the implication has come up on several questions about penalties that the department has received through audits or from CMS. So has KDHE had to pay any money back to the federal government?
I would have to get you that number. Based on this stuff, I'd have to get you that number, okay?
I appreciate that, thank you.
Senator Gossage.
Thank you, Mr. Chair. I've been doing just a little bit of research here to try to find a time when we've been notified of an increase in rate that's going to be paid. We balance the budget for the department, or we approve the budget for the department, and now you're saying we need to spend another $3.3 million of state funds by increasing this dispensing fee. And part of the reason why I asked the differentiation between paying everybody the same, which makes a lot more sense to me than it would be because of your situation, we're going to pay you more. And it seems that in the past, this has required legislation to be able to increase a rate or something. Am I right about that?
I don't think in this case it has. Now, this could make its way over to caseloads, but I'm going to find that out for you, okay?
Thank you, Mr. Chair.
Representative Ruiz.
Thank you, Mr. Chair. Secretary, looking at the ABA therapy, is, for some reason, I thought that in Kansas, we raised the age that the therapy would continue. This has been, I don't know, 3-4 years ago, maybe.
I'm not sure, but.
So I didn't know with the auditing, whether there's an issue there of how long a person with autism could receive the ABA therapies. I think we also, in the Social Services Budget Committee, added some additional funding for ABA therapies, but with the intention of it continuing on past a certain age, and I can't remember now what that age is.
Yeah, we have to find it out. Whatever our policy is, which is what they'd be auditing on. Let me just start there. And, the intent is just to make sure that it's appropriate, that we're doing it appropriately. So that would all be considered in our audit. But I'll make sure that we get that answer for you, okay?
Great, thank you.
Any further questions? Well, committee, I think these are great questions, and I think our staff is also flagging these questions so that, I think sometimes we get a little carried away. We ask questions and we never find the answers, and we need those answers to be addressed. And so keep those in mind. Elizabeth is working on and flagging those questions, and we'll get with KDHE or whoever as we go throughout the day. But I think it's important just not to ask the questions, but to get the answers. at the next session.
I'd just say, we try to come into these meetings so prepared, so you don't have to do that. And, you know, it's just a big program. And so it's inevitable that you're going to have more. Our intent is to answer every question, though, and I think we do that for you. So I just wanted to make sure we're committed to quick turnaround on all of these answers for you all. Okay?
Oh, I think that 100%, but I think that you could never anticipate all the questions.
No,
from
I
this
know.
committee.
I know.
So, very good.
All right. Well, I'll move on to page 9, unless you have something else. You ready?
Let me see if there's any more questions here. Any more questions on the, okay, move on to
Right,
page
so-
9. Thank you.
DME, Durable Medical Equipment Work Group. So you know that we've created this work group. A lot of that was based on discussions in here and findings and whatnot. So we've met 3 times, with the last meeting being March 6th of this year. There are several policy clarifications that have been issued due to the work of this group. We've removed absolute language in policy for the power seat elevation. We've clarified what the term alter prescription language in the DME manual means, and we've issued a provider bulletin for CD systems effective April 1 of this year. There are a number of new policies moving through the policy process as we speak that are outlined there. There will be an upcoming policy bulletin that will allow providers to bill 2 units up to 30 minutes for DME, for example. There will be a policy to address concerns related to pediatric mobility, some new DME codes that require prior auth and the cost of these codes to determine whether or not prior auth is necessary. And we're researching a request regarding headrests for tilt lifts. So just to give you some examples, if you don't want me to read everything, I won't, but I just want to tell you this. Some policies discussed in the work group that would require an appropriation by you all to implement would be coverage of a power standing system, manual standing wheelchairs, non-covered adaptive protective beds, payment of travel times, including compensable work when traveling between job sites, et cetera. We are continuing to work through policies and communicating with the group before another formal meeting in a few months to allow policies to move through the process. So I'd say the DME committee is working as the message there, and we're committed to making things better. So before I move on to the federal updates, I'd like to see if there's any questions on DME we can help you with.
Committee, questions on durable medical equipment. Representative Sutton.
Thank you, Mr. Chair. You mentioned the determining whether or not prior auth affected the expenses on codes. Do we have any numbers on that yet, or is this still?
The committee probably does, so I'll have to get through that detail. We'll put that on the follow-up list, okay?
Yeah, that would be,
Okay,
that would be fantastic.
I'll get that for you.
Thank you.
All right, thank you.
Further questions? Seeing none.
Okay, so on page 10 is the federal updates, the CMS concurrent review, concurrent enrollment file. So we received the multiple state, this is something feds are doing now, Medicaid enrollment file, or what's known as the concurrent enrollment file from CMS in November of '25. This is people that are showing up in more than one state. It's created by the Team MIS system, which is the Transformed Medicaid Statistical Information System. Again, our acronyms here. That's reported by each state Medicaid agency. Prior to that file, the only report that provided residency information was the PARIS, which is the Public Assistance Reporting Information System file, as reported in previous committees. You've heard about the PARIS system before, and from the Inspector General. And the PARIS report contains outdated data and has other limitations. So we had an updated file. On page 11 is a breakdown of, after the results from the November file were received, of those that we continued to cover and those that we continued to discontinued to cover. We had that breakdown and say, prior to receiving that file, staff had already reviewed through their normal process, and so 4,800 plus of those we had already discontinued, is my point, 4,300 prior to receiving that file. Those that were identified as Kansas residents are listed there, 4,800 plus that were continued. And then the rest go on where the residency was not met, there were 315. There were those that didn't respond. There was some that were over income and resources that weren't residents, so all of those were taken off. So basically, out of a total of 10,757, we discontinued after the file another 1,500. So we are now going to be, I think, on an ongoing basis doing that because of the federal government providing that data. Any questions on that before I move to the immigration file?
Committee questions? Seeing none?
It'll be page 12. We are continuing the process related to those files on immigration that CMS is providing, and as of April 7th of this year, the vast majority have been verified as eligible, either because they are a citizen or have an approved immigration status. So you can see there that those that were discontinued based on the file we received from CMS were 18, and the rest is a breakdown of what I just said, 43. They were qualified already. There's 11 pending, and then none were discontinued for returning documents or no longer meeting the status. So Kansas is in good shape on that. On page 13 is the federal update on the HR 1 related to immigration provisions. So that guidance came out on immigration from CMS on April 8th of this year. Currently, there's 12,887 immigrants eligible for Medicaid, and they are qualified and do qualify for Medicaid per federal requirements. Based on CMS guidance, Kansas' current estimate for the members who will retain eligibility in that group are 9,543, based on HR 1 now, new requirements, and 3,344 are likely or may lose their eligibility. States and the new requirements under HR 1 are to redetermine immigration status on all potentially impacted recipients prior to taking adverse action, which may reduce the overall number. So we need to do more homework, basically. All states do. These individuals are typically refugees, asylees, special immigrants, parolees, or victims of trafficking. And a communication plan about the change is in development to inform members who fall in this category about the upcoming changes. So as we work through the new requirements of HR 1, that's a snapshot of the immigration requirement. So I'll stop there.
Senator Petty.
Thank you, Mr. Chairman. Looking at page 13 here, when you have that current number of 12,887, and I'm just focusing that we're currently, that's not now, because you're saying that, is that 12,887, and of that, now there's 9,500 of them will retain their eligibility?
They absolutely meet it. The 3,000 plus don't appear to meet it, so we're validating that under the new requirements.
So this was a number prior to the new requirements, the 12,000.
Yes.
And
Yes,
now you're talking
that's where
about
we
the new
stand.
requirements. And then when you on down on the last bulletin, when it refers to these individuals, so those are the individuals that are going off, primarily refugees?
No, these are the ones that, I'm going to ask Yvonne, these are the ones that potentially would stay on if we validate. Is that correct? No, those are, so I apologize. These would potentially come off.
Potentially, it's a mix. So the federal government gives us, Yvonne Case, KDHE, Director of Operations, sorry. The federal government gives us a list of immigrants and refugee groups, okay? It's been broader. HB1 narrows it, all right? So there are certain folks, if they have a green card, they'll stay on. There's 3 small groups that will stay on, okay? But some of these people are refugees and asylees that will be removed. We expect that they will not have insurance in Kansas. About 1,900 of them are children. And so we're really working hard on that communication plan to make sure that, and our advocacy groups to make sure that needs are addressed there. But this is a federal CMS requirement. It's legislation. Yeah, it's tough.
So of that 3,344 that may lose their eligibility. You're saying 1,900 of those.
Yes, I believe that's right at that number. I can't, that's not the exact number. We're also identifying any HCBS folks, and there are a few on there. So we're really trying to do our analysis of this to help folks transition and figure something out.
And what about the parolees? I mean, we've, in the past, we've had this big push to have about someone, if they had Medicaid and they, you know, are convicted and they go in and then being able to come off on, and onto Medicaid right away. But does this parolee then kind of, on that list, you've got parolees there. I'm just wondering what exactly.
I don't know. I would have to take that question back.
That'd be great. I'd appreciate that. Thank you.
That's what I believe it is, but I don't.
Okay, okay. Thanks.
Representative Ruiz.
Thank you, Mr. Chair. Secretary Stanek, on, it says states are required to redetermine immigration status of all potentially impacted recipients. Do you know if, I have two questions, they're related. One is, if anyone is going to help the recipient financially to maybe get records that would prove their immigration status.
I don't think we've crossed that yet, and what our role would be versus what help might be available for these patients, but we could, that could surely be part of our discussion. I'm sure the staff's been discussing that, or the federal government, of what their options would be, so we'll find out.
Okay, because it's like $550.
Okay, so to supplement that.
It's a lot.
Funding,
Yeah.
okay.
Yeah.
Yeah.
And the reason I even know that is because I'm trying to help a person who is receiving IDD services and is in a residential facility right now. And all of his property was trashed. I mean, literally put in the trash. And then there was his birth certificate, his ID, and his paperwork that would verify his immigration status. He was adopted as a baby. He's 50 years old now, but he was adopted as a baby from Korea, and it was an American family that adopted him. But now, in order to get his real ID, he has to have the birth certificate, but that also means he's got to get his original birth certificate to, and his naturalization papers. And so we're running into this cost of $550 for that. And then I think they're going to have to hire a lawyer to help them with that. So I don't know what that's going to cost. And so I don't know how he's going to pay it. I mean, you know, he's
All right, well,
on
that's
Medicaid.
noted, and I'm not sure that we considered that yet, but we will, I'll make sure the team talks about it if they haven't already.
Okay, thank you.
Any further questions? Seeing none?
I have one more add-on. Oh, go ahead, you had a question, sorry.
Senator Gossage.
Yes, thank you. And Representative Ruiz, I know some organizations that might be able to help this individual in this situation. We'll talk. I think some of correct me if I'm wrong, but I think some of the confusion about is one an immigrant or not, are they legally in this country, is that the previous administration allowed, in fact, welcomed all these people into the country that were never really legal.
Okay.
And so trying to decide, we want the people who are receiving, we all in this country want people who are receiving services to be people who are eligible for the services and not taking funds away from people who truly are eligible. Have you found that to be a stumbling block to determine how did they come into this country? Because anybody can say a refugee. How do we have any idea how you're looking into that? What, in other words, what are you seeking to be able to find? Or is the federal government telling you these people are illegal, should not be receiving services?
Now, we have to validate it. I can't specifically speak to the validation. Yvonne, would you have any more specifics on what we've done to date?
Yvonne Case again. Yes, we use the SAVE system, okay? It's called SAVE. I don't Another acronym, but it's a federal system, okay? And we check their credentials there, all right? They turn them into us. We validate them through that system. If they don't match for any reason, we require additional documentation. We're also using this immigration file that the feds have been sending us that Secretary Stanek referred to, and there's some documentation about how many of those we're still finding. You know, statuses change, right? You get a temporary legal status, right? And it may end and those kind of things. So we do validate all of that. And again, this goes back to certain categories. So the Fed said sometimes if they come from X place during this, you know, and they were an asylee, right? They were having violence there in the past. There have been laws. We allowed this group in. And what this is doing now is changing those groups. The federal government has gone through and said some of these groups are no longer allowed. Whether they're legally here or not is a different issue, right? This is, can they get on Medicaid? Can we use tax dollars to cover their health care? All right, thanks.
Very good.
May I follow up?
Yes, Representative Ballard.
All right. Because these categories have changed, at the time they came in under the previous administration, these things were in order. So they were assigned to those particular groups. Now that this administration has changed those rules, now they're in like a no person land. Am I correct?
Well, their legal or illegal status is separate again. This is who we can cover for Medicaid, yes. And we won't be able to cover these if they're from certain areas. I don't know how the federal, you know, how this legislation was decided, HR 1, but it's very specific. We had a list of about, I don't know, maybe 15 to 20 different groups, okay? Now it's narrowed to about 3. And for Kansas, that's, you know, these 3,300 folks.
Add more about that conversation, but I just wanted to do that clarification. Thank you very much.
Committee, further questions? Seeing none. One more, Representative Ruiz.
Thank you, Mr. Chair. The children that are out of that 3,000, you said there was like 1,900
Estimated,
kids?
Yes.
They're not going to be eligible for CHIP either, correct? No? Okay. Thank you.
Committee, further questions? Seeing none.
We'll have more
Continue on.
updates as this gets going. As you know, I had one more add-on. There were some letters you were given that were addressed to Dr. Oz. And I wanted to explain, one was from the governor and one was from our Medicaid program. There was a letter that was sent from Dr. Oz, he is the CMS administrator, as you know, to all state Medicaid programs. Provide within 10 business days, all states were required to outline their commitment to swiftly revalidating providers, high-risk providers, and those are defined in the letter. Those are providers of home health and DME prescribers, for example, and so forth. We also have to, within 30 days, create a strategy for how we are validating revalidation of providers that are on the Medicaid program. I just wanted to say those letters are related to that. It was a quick turnaround. We've met the requirements of the letter, and we are drafting what our strategy is, but I wanted to tell you that Kansas exceeds the requirements for what the federal government has on revalidation. In fact, we just had an audit or a visit from CMS, and we are in very good shape related to that. But just want you to know if you hear about provider revalidation, because it will be a little bit of a disruptor for providers, and we're trying to get communication out about that. But our process was more stringent than's required to begin with. So you have those letters, and if there are any questions later, let me know.
So for my clarification, that's the providers, so that MCOs that would be through the MCO process?
Yeah, the validation, yes.
Okay, through their credentialing, through the MCOs credentialing this process?
Gainwell, our system would trigger that, and then we would work with the MCOs, yes.
Okay.
Okay?
Any further questions?
And we will follow up on everything. I'm going to turn it over to Yvonne to finish our presentation, if that's okay.
Very good.
Thank you, everyone.
Thank you. Welcome, Yvonne.
Thank you, Chairman. Is this like an encore? Not really. Okay. I'm going to talk to you about the Medicaid eligibility application status, still in very good shape. Really pleased with our contractors' work and our staff's work. So we're at 3.3% of total that are over the 45 days, various reasons sometimes for that. And then we have a separate group that are PMDT applications, and they're tracking well as well. So those are folks that have declared a disability without receiving something approved from Social Security, so they require additional processing. Next page, call center metrics, still excellent, and you'll see our volume went up by a little, about 1,800, and so still excellent. Really pleased. I want to talk a little bit about a new pilot project that we've entered into with our Gainwell Technologies partner and some other states. And again, this is another proactive kind of measure. They ask us, hey, do you want to participate? And we checked with legal, of course, to make sure everything's, that we can share data. And so right now, Arkansas, Kansas, and Missouri have entered into this. We expect more states to enter in, and it's an out-of-state residency pilot. So today, you've heard, and you heard Secretary Stanek mention it, that we get a Paris report. It runs a little bit behind, like a lot, okay, 90 days or so. And so that's not as that, and that says, what that Paris report comes from the feds, and it says to us, hey, these people are getting Medicaid in 2 states. Do something about it, right? And well, 3 or 4 months is too late. Steve will tell you about capitations and how much that's costing us So we've started this pilot project. And Gainwell is able to flag for us cases that are potentially enrolled in 2 states, Kansas and another state, right? They're sharing data. We get a monthly file. We've gotten, on the next page, we'll talk about that monthly file that we've already gotten. They're also, so that's the people currently on, they're also able to pull in new members and do a file to match daily. So it's more current information for us, right? Now, my Medicaid members move around, right? The family ones do a lot. But anyway. All right, so the first file we got, if you'll turn to page 18, there were 2,134 records on there, okay? Secretary Stanek mentioned that concurrent report that we're getting from the feds. Now everybody's reporting, all right? So we looked at that, because they already said this is 2 states, the feds did, all right? And we found that 957, not quite half, were on that federal report also. That tells me this might be good data that Gainwell is able to do for us and more current. So then they're doing the analysis and the individual here through it. But again, we're still reviewing those to see the data. Just because they're on that file, we still have to, the feds still require us to validate their residency, still to check. We still have to send them a notice, those kind of things. But we think it's very good to be able to check and to get ahead of this, not to wait till 3 months to find out. So, are there questions? Yes, about that?
Representative Sutton.
Thank you, Mr. Chair. Just trying to balance the numbers here. Gainwell provided you a number of 2134. Then those were compared to the CMS concurrent report, which was 957, and only the 957 that were 3 months out of date were investigated. Am I understanding that?
The 957 are not the 3 months out of date. That's the Paris report. This concurrent report is that's a fairly new federal report that we're getting.
And that one's more up to date.
It is more up to date. And then Gainwell's even more. So that's about half of it. Okay. So the feds are tracking at about half with this new report.
Okay.
Right.
So the new report showed 957, about half, give or take. But those were the only ones that were investigated, not the 2134 on the Gainwell report.
Well, this is, so the breakdown that you see here under the 9057, Representative Sutton, those are the ones we had already addressed on that concurrent report. So we already had that data.
Gotcha.
So this Gainwell report's fairly new. And that last line there, that 1177, where we're going to take a sample to see the validity of the data, we don't want this to be a situation where it creates more work for our caseworkers, which is more cost, right? And more use of FTE, as opposed to the cost offset that we're going to be doing it. So they're going to start with a sample and look at those. And that's a newer file that we've gotten.
Okay, so you haven't had time to investigate
No, we haven't
those
finished
yet.
that work.
Okay.
So
very
we'll
good.
have that for you next time, I'm sure.
Excellent. Look
Especially
forward
now
to
that I
it.
said it out loud, right?
Exactly. Now it's in my head.
Fair enough.
Thank you, Mr. Chair.
Senator Peck.
Thank you, Mr. Chairman. Two quick questions. Gainwell is strictly residency, no other eligibility, just residency?
That they're checking here, the state residency, yes. And they're also tracking a little bit of additional information about claims. And this is a pilot to see where we're also working with them on what else is out there. What else could we be looking at? But yes, right now it's residency.
Are we paying a fee for this?
We are not. It's a pilot project.
That's even better. Thank you, Mr. Chairman.
Back to those efficiencies.
Committee questions. Representative Reeves.
Thank you, Mr. Chair. One of the complaints I sometimes get from constituents is when they receive a letter saying that their Medicaid's been discontinued. And when they read it to me, I'm like, I don't even understand what that means. So how plain of language is sent to people that are being discontinued from the Medicaid? And what's the letter? What's the wording for the letter? Is it very clear? You're being discontinued from Medicaid because of the following.
So, yeah, so they are required, we do have notices that we send out. Now, clarity is one thing, and I believe all of that is tested for, is it a 6th grade reading level? Yeah, they're all shaking their head, all right. A 6th grade reading level. The clarity is a challenge. Let me tell you that the federal government requires many, 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 many things be included. Sometimes notices have pages extra in them, so they're tough for the average citizen to interpret. I will acknowledge that. Yeah. So,
yeah. Yes.
and I think on our future radar, we're looking at those things. Those are expensive changes. I will tell you that. Yeah. So, but they're mindful. We have really taken recently in the past few years at KDHE a lens toward our members, our providers, and our taxpayers. Who are we serving out there? How are we doing that? And that's something we talk about on a daily basis at KDHE. So we understand that very much. I think our applications are tough. I think that's something that future is on the future too. To make it easier for our eligible members to get the service. We don't want to be a barrier if they're eligible, right? And if they're not eligible, we don't want to create an opportunity for fraud.
Okay.
So balancing.
I wanted to point that out, that it's often that I receive these calls.
Oh yeah, I'm sure. I received some of those myself, so I understand. All right, we ready for the next area?
Not yet.
Okay.
Committee questions. I want to back up to slide 15. I think sometimes we tend to gloss over how important these eligibility applications are, and the numbers look very good. I've seen, over the years that I've been here, I've seen horrible numbers. I've seen the long-term care applications in the 7,000 range. So I'm very pleased to see these numbers here, and I would hope that the committee would continue to keep an eye on those. It means our eligibility folks are doing a good job. So
we appreciate that. They're doing a fantastic job. They really are. I've seen those numbers too, and we never want to go back there. Just because we're low doesn't mean we can't go lower. Those folks will tell you, Yvonne's pushing us all the time. Secretary Stanik's pushing us, Christine, get better, get more efficient. What can we do? So thank you for acknowledging that.
thank you. Okay, moving on.
Okay, now we're going to talk about our data matching hub. As you know, this has been a topic of this committee in the past, that we had been using Equifax for data matching, okay? That's historically who we've used. So we had a problem because the rate for Equifax had significantly increased over the years. And I don't mean 1 or 2%. I don't mean, I mean significant. So we had to look for other opportunities. So CMS offers their own data hub, all right? They use Equifax also. All right, but it's a discounted rate because multiple states are using it, and it's a much bigger volume. Kansas isn't a giant state. You guys know that. So the contract with Equifax ended at the end of January of 2026 of this year. Okay, we moved to the hub. So here's why we moved, and I think we talked about this before, but I'm going to say it again. It's still CMS approved data with the same vendor. It's lower cost. It went from 708 or to 708. It was 1154. It would have been 1154 had we paid Equifax in February. So we were saving $4 per transaction. All right. It's avoiding fees for going over the allotted, which we were required to pay if we went over. We avoid being required to pay for a set amount up front, regardless of our actual usage. We don't have to do that anymore. And we've avoided those rate increases over the term of the agreement. So now we want to know what happened, right? We've got cost savings, but is this hub working for us, all right? So we didn't anticipate having to do any additional verification that we didn't prior to the hub. The only limitation is they asked for a tax ID for that, for the hub, okay? So Equifax does not have income information for 100% of the members anyway, so Kansas Medicaid has always used secondary sources, all right? So we were prepared for that issue. So the tax ID may increase those secondary sources by a very small percentage, but those matches with those sources were already in place and operating today. They're there, okay? So in the first month of using the federal hub in place of our traditional Equifax contract, Kansas saw almost the exact same data return rate from Equifax, again with that savings. $4 savings. The hub service returned data for 16.9% of the requests in the first month versus 17.4% from Equifax. So if Equifax, if they didn't have a response, we can use KDOL, yeah, the Kansas Department of Labor, and they have up-to-date information. If the income verification cannot be verified through these sources, then we ask for the member to provide it, all right? No eligibility is ever given or renewed without verified income from a CMS-approved source. All right, we don't anticipate any data accuracy issues because we've changed this. And on the last page there, on page 21, you'll see total savings here. It's estimated to be $7.5 million over 3 years. All right, the cost to move to the hub was just under $1 million in all funds. CMS paid 75% of that, or about $250,000. We paid the other $747,000. Okay, $747,000. I mean, we paid the $249, I'm sorry, and the federal funds were $747. Correct that, please. So the cost savings just for 2 months, $802,913, which is $424,000 more in savings than we thought it was going to be, 112% more than projected. Those are numbers we like to see. I hope the committee likes to see that. And before, I don't know if you have questions?
I'm sure we do.
Of course you do. Okay. No, you're not going to give it. You're not going to give it to me. Can I introduce you to somebody? Super important.
You may.
All right, thank you. Her name is Elizabeth Wolf. Elizabeth has been promoted as my counterpart, and she is really responsible for this genius around the Equifax changes in this cost savings. All right, questions?
Committee questions. Representative Sutton.
Thank you, Mr. Chair. I love the results. Don't take this the wrong way. I'm just trying to figure out the nuts and bolts of the program itself. Equifax is still the data source, and that's fantastic. But when the state was utilizing Equifax, a tax ID was necessary, but for the CMS application, it's not necessary?
The other way.
The other way around. So Equifax requires a tax ID, and the state did not.
I don't know. You want to help me out? All right. Calling our resident genius. She knows these details.
You can phone a friend here.
All right, thank you.
Hello, Elizabeth Wolf, Director of Systems and Compliance. Thanks for the question. So what happened before is we were allowed to submit data in our direct contract to Equifax, and they did not require us to have a tax ID present on the record in order to return that information. On the CMS hub, CMS requires that the tax ID be present on the record. Gotcha. So the data that we're getting now does include the tax ID all the time.
Perfect. All right. Thank you. And now, and the next question, this one may be for you too. If Equifax doesn't have a response, then we get the information for free from KDOL?
That's correct. And actually, we try to, we inquire from KDOL first because we don't want to pay for it if we don't have
That
to.
was going to be my
Yes,
follow-up.
we go to
Perfect.
KDOL first, and then if KDOL doesn't have the information, then we pay to receive that from the hub.
Perfect. All right. Thank you very much. Thank you, Mr. Chair.
Committee questions? Seeing none, thank you very much for being here.
Thank you.
And committee, your chairman has kind of been a little bit derelict in his duty. Senator Owens is on WebEx and has been since the beginning, so I failed to, yeah, well, I think so. Anyway, so thank you, Senator, for being here and being a part of this, and I apologize for being halfway through the meeting before I announced that you were on WebEx. So with that, we're going to move on to the managed care organizations. First one we have is Terry Weathers. Terry, welcome to committee.
Beyond the specific sunflower information, we wanted to provide an overview of the rate-setting processes and some of the outputs of the rate-setting processes. So each year, the managed care organizations submit to Optimus an MCO reporting template. And this template breaks out the premium and medical costs in detailed categories in 4 specific regions. And using this information, Optimus develops the rates, and those are on a per member per month basis. And there's about 40 rate cells and 20 plus medical cost categories that are included. The 2025 MCO reporting templates were just submitted a couple of weeks ago on April 24th, and they will serve as the starting point for the 2027 rates. So we are always 2 years in arrears looking at the data. And one of the outputs of that rate setting process is the statewide data book. In this data book, Optimus aggregates the 3 incumbent MCO submissions to summarize program-wide medical costs. And just for example, the 2021 data book was provided to bidders as part of the most recent KanCare 3.0 RFP. So we determined it might be helpful for you to see the aggregated data from the data book showing the actual results for the last 4 years and then projections for 2025. And you might ask, why is 2025 projections? And that is because that will still be audited by Optimus Reviewed as part of that submission that we just prepared in April. So with that, we will look at the total Medicaid program spend from 2021 through 2025. This was prepared by the actuaries, and we highlighted 10 of the 20 medical cost categories. So for each of those, you see the total dollars, the percent of the $4 billion medical spend that that particular cost category includes, and a per member per month amount. And per member per month is important because it basically takes out volatility created by membership going up or down. And if you think about it, it represents the average monthly cost for every member if they were all using this particular service. So that kind of takes that volatility out. So we listed these in descending order, and we ended up with an all other category that was a residual that wasn't in the particular ones we're going to talk about. And that all other is less than 10% of total program spend. One thing that you'll note here, which is actually quite unique, is in Kansas, as you well know, we have our 7 waivers, and we also have nursing facility services. In many states, those are fee-for-service, so they're not part of KanCare Medicaid program like we have here. And ultimately, if you look at this distribution, 3 categories together make up 50% of the total program. So home and community-based services for the 7 waivers, nursing facilities, and behavioral health spend combined represent more than 50% of the total KanCare program spent. And again, in some states, the majority of that would not be in managed care. So now let's look at some of the particular larger categories that we've identified. So on slide number 4, you're going to see the trend of the entire program over this period of time. And you're going to see that that was an 11.9% average year-over-year increase over the cost of that time period. And if you think about it, what are some of the things that create some of that increase? There's going to be new programs that were previously not in Medicaid, and in those cases, an estimate must be used to try and determine how much that'll cost. It's also going to reflect policy changes. The legislature takes actions on particular fee schedules and program elements. It can also reflect changes in utilization, members using more services or using a higher mix of services that are more expensive. So those are all the types of things that cause overall increase over time. If we drill down into home and community-based services and nursing facilities, you're going to see both of those have an average increase year over year of 14.7%. And again, those are being impacted by the annual fee increases from the legislature, policy changes, or the nursing facilities actually file an annual cost report, and that develops their individual customized rates. So HCBS and the following nursing facility slide look very similar. If we go to the next category of behavioral health services, you're going to see that that particular category has the highest year-over-year increase of 25.9% average per year. That includes behavioral health inpatient, CCBHC, PRTF, ABA, any kind of category related to behavioral health will be in that trend line. And we'll look at a few of those elements just to see some of the specifics that are creating some of that trend over time. So our next slide will be the CCBHCs. And just a refresher, the CMHCs began converting to CCBHCs or began billing as CMHCs to CCBHCs in May of '22. And that process continued through June of '24. So 9 CMHCs began billing CCBH services in '22, 12 in '23, and 5 in '24. So at this point in '26, we have 25 CMHCs billing CCBHC services because 2 of them actually merged at the beginning of the year. So this is an example of a program for which there was no historical cost at inception. So the rates were built using estimates. And those estimates have consistently been lower than the actual trend has ultimately resulted in, which is, you can see on this particular slide. Another specific element of the behavioral health program is the psychiatric residential treatment services. This is a type of behavioral health spend specific to children and shows a 10.4% increase year over year. And this is an example of another area where we see fluctuations in the number of beds and the capacity. And it makes it difficult to estimate because at times we have more demand than we have supply. So we ultimately get some built-up demand. So when new beds open, they very quickly fill. So just trying to share some examples of some of the nuances of particular categories and why they, excuse me, change differently than others. The next slide is the non-behavioral inpatient. So this is physical health. And this is the only category today that we're showing that has actually showed a slight decline over the five-year period in its annual change. Now, inpatient is very complex in that it is reimbursed under diagnosis-related groups, which are the same theory of DRGs that are used with Medicare payment for inpatient, if you're familiar with those. These DRG rates are reviewed annually and changes are presented from the state. What is interesting about DRGs is they include hospital-specific base rates. So each hospital can have quite different reimbursement based on their underlying cost structure. And especially in the state of Kansas, we have significant differences in reimbursement for in-state and out-of-state hospitals, because as you imagine, being on a border state, we do have that crossover element. The next category is pharmacy. And actually, I think pharmacy is a really good success story for Kansas. 8.2%. Average year-over-year increase is actually very moderate compared to other states. And there's 2 things that the state did that were very proactive. Kansas adopted the National Average Drug Acquisition Cost, NADAC pricing, back in 2015. And Angie Yu on our pharmacy team will talk a little bit more about some of that. But that really put us on a basis of using publicly available national pricing that we pay for drugs that are available on the NADAC listing. Kansas also implemented a high-dollar Medicaid drug carve-out. And the reason that is very helpful is we reimburse these drugs based on a paid invoice. There is therefore no markup from the provider, which saves KanCare money. The state also reimburses the MCOs at invoice price. So there is no spread. And these emerging treatments can cost millions of dollars. And these are all of the curative treatments that you hear about for CAR-T, cancer drugs. There's new sickle cell treatment drugs. So I believe that action taken by the state has definitely resulted in a fairly moderate pharmacy trend. And then the final slide we wanted to show was dental services. And this particular 4.4% increase reflects dental services paid only to dentists that are not part of federally qualified health centers. These FQHCs also provide dental services, but they're trended separately. And you can see here direct impact of legislative expansion of dental to adults back in 2024. So with that, I will stand for any questions you may have on this statewide data on medical.
Thank you very much for that, committee. This is something that I think we need to get up to speed on. We have not dealt with these, the overall costs and how this looks and all that kind of stuff. So you'll kind of see that throughout the rest of the year, that we're going to go into these, the actual nuts and bolts of how the MCOs and the profit and how the spending is increased. So with that, questions? Representative Sutton.
Thank you, Mr. Chair. I see that you tried to pick anybody but me. That was great. I appreciate the heck out of that. I love getting this trend data. This is fantastic stuff. Two of them jumped out at me that I wanted to ask about. The first one, 36.5% year over year on CCBHCs. How does that compare to what was budgeted? And I'm guessing we didn't budget for that. So where's the money coming from?
Yes, that is significantly more than was originally budgeted. And I think that where the money is coming from would be a KDHE question, but it is something that we have discussed with KDHE on a regular basis over pretty much every year since 2023.
Does the answer to that rhyme with caseloads?
Again, I think you'll want to ask KDHE, but the MCOs have also been participants in funding some of that, so it's a complex.
So it's also coming out of the MCOs?
Yes, when the rates that are based on 2 years historical data and an estimate for something that is unknown are inadequate, the MCOs are contributing.
Good to know. I definitely want to put a pin in that and come back to it with KDHE on that one. The other question I had was, if you don't mind, with regard to the pharmacy data. I agree, the 8.2 year over year, that's nice. I see everything else is 10 to 14, except for the one major outlier there. But I do see a big increase from 24 to 25, and that's more like 15%. So it's certainly outside the trend. Any color provided for that?
So Angie Yu is going to come up in just a bit and speak on pharmacy. I will say, though, in general, there's a lot of new pharmaceuticals, obviously, that are blockbuster, if you will. So GLP-1s are covered in the state of Kansas. That is not the case in many Medicaid programs. And then again, some of these new curative drugs, it's crazy to think back that we all remember when there was a curative drug for hepatitis C and how that was something that was covered and so many people were able to benefit. We actually see drugs at that magnitude of development now for many drugs that have been conditions that are lifelong conditions that now can be cured. So, but I would say GLP-1s are probably the leader.
So can we expect to see a continuation of that 15 rather than the 8.2 that we were dealing with prior?
So many states are taking a look at coverage of GLP-1s under Medicaid. And there are lots of states making changes. So there's always the opportunity for the state and the KDHE to continue to look at other states' choices and best practices. If not, I suspect the answer will be that it will continue to increase.
All right, thank you. Thank you, Mr. Chair.
And to the CCBHC discussion, is it not accurate to say that we've been bringing on, if you look at that, how many CCBHCs have we brought on through that process too? So I'm just saying, if we had a level playing field, for instance, and all the CCBHCs, we're going to have a lot better idea now that they're all on. Is that part of the increase in it?
Well, they were all on for all of 25.
Right.
Yes, and they will all be on for 2026, yes.
Right, but if you look at the whole trend going up, we were bringing on CCBHCs. And I'm certainly not trying to make any excuses here. I'm just trying to, I do think we need to take a look at our CCBHCs. We do have, and I hope a lot of the committee members on here will be part of the, there was a budget proviso in the committee to establish a oversight committee of the CCBHCs. I think that we're going to go a long ways this year to control what you're talking about, the excessive costs and that kind of stuff. But some of that also, and I and Representative Bueller spent 2 hours on a web call last year with the arbitraries, you know, to take a look at, you know, the actuaries, I'm sorry, wrong. We spent trying to understand that whole process. So it's complicated at best. So Senator Gossage.
Thank you very much, and thank you for being here. You mentioned something about action taken on pharmacy by the state. Could you verify, could you explain to us what that was?
Specifically, the state of Kansas covers GLP-1s for obesity, and some states only cover it for diabetics.
And do we know specifically the increase based on that one factor?
I don't have that specifically here. I actually think that United is going to talk about that a little bit as well.
Very good. So the thing about mental health, what we found in the state is basically if someone uses the term mental health, we say, here's my wallet. And that's not the way to go about things. We need to look at how those dollars are spent. When I ask research to look into how much does the state of Kansas or how much is spent in the state of Kansas on mental health, it was $1.2 billion. We need to look very carefully on, is Kansas healthier mentally since we've been spending all of these dollars? Are they going to the right place? We know that there is definitely an opportunity for abuse when it comes to mental health, behavioral health services. Not that they aren't necessary, of course, but they open themselves up to abuse because does anyone ever really get well? We know that in the past, Medicare and Medicaid would not continue to pay for services if they didn't see that there was progress. For example, you can't just go to physical therapy because you really like physical therapy and expect someone else to pay for it. They have to say, have they made progress? Are they continually making progress? Are they at the stage where they're not going to get any better, et cetera? So, and I know you're representing Sunflower. How do they measure the dollars that are being spent on mental health? And I realize there's no incentive to measure that whatsoever. Because when you are an MCO, unlike if you are a standalone insurance company, you're going to be watching the bottom dollar. You're going to make sure, we've got to make sure that these services are going to make a difference and help. So they're going to really track that. An MCO can just say, oh, well, if it doesn't work, we'll just tell the state. We need more money to pay for these services because as you can see, we're spending X amount of dollars. Sometimes, of course, you're going to have to eat that cost because the estimated amount, as you mentioned, was not enough. Like, well, we estimated X and it's a lot higher than that, so we kind of had to eat that this year. But next year, we can show we need to have more dollars for that. So here's my question. What, if anything, is being done to, one, make sure that these services are truly going to someone who is medically necessary for them to have the services? And two, what follow-up is being done to see if this person is actually, quote, getting better, or how are they reacting to these services?
Thank you. I think a couple points there. First of all, throughout the CCBHC program, the spend has been higher than expected every year. So this is not like a one-year fact pattern. So Sunflower specifically is doing audits. We are going with behavioral health experts to the CCBHCs. We are picking samples of members. We are reviewing their care plans. We are reviewing the treatments being provided and looking for outcomes. And we are recommending significant enhancement to that process in the CCBHC documentation. We have also provided to KDHE on several occasions sample policies that we believe would enhance accountability, would ensure there are outcomes, would ensure that the members' treatment does have an ultimate measurement of success. So we are very actively auditing the CCBHCs for exactly what you're talking about, because we can't just go to the state and say, give us more money. So we are trying to be a partner and provide solutions that we believe need to be implemented very quickly, because this has been an ongoing process, and we've been recommending some of these things for several years.
Thank you. Thank you, Mr. Chair.
Committee question. Representative Ruiz.
Thank you for your presentation. So looking at the slide 8 that looks at the CCBHCs, and that conversion from the CMHC to CCBHC, does it looks to me like the actuarials made a big mistake and did not really capture what the spending would be like once the CCBHCs all came on board. You know, CCBHCs have been in existence throughout the U.S. for many years, and so I don't know if the actuarials looked at what was the trend in other states as they all came on board versus kind of waiting to see what was going to happen in Kansas.
So the CCBHC program in its current form is actually a new program. So there were not any apples and apples to compare to. And Kansas is one of the forerunners, frankly. Other states are looking to Kansas as they begin evaluating CCBHC programs to try and avoid this disconnect that we have seen. So I would agree that there was a significant miss on the expectations. But again, this is a new program, and things are constantly being revised, and the federal government is also reviewing this demonstration project.
Follow-up, Mr. Chair? Thank you. So also, listening to you say that you're kind of doing an audit, so to speak, correct? Anyone that is doing the auditors, do they have a mental health background?
Absolutely.
Okay, like what's their background?
They are clinically certified behavioral health specialists and behavioral health physicians. We use resources that are available to us in our corporate structure, and 100% qualified to do this work.
And do they take into account the ups and downs that someone with a chronic mental illness, say schizophrenia or bipolar disorder with psychosis, anything with psychosis also in it, taking into account that, yes, you get better, but then you might not. You may get better for a short period of time and then you're not, because that is the nature of a chronic mental illness. Is that being taken into account?
So when they have completed their review and have their findings, they sit with the CCBHC personnel and they discuss the findings. And to this point, it's been primarily educational. And really requesting documentation in the file that shows the connection between the services being offered and the desired outcomes in their plan of care.
Okay, thank you.
Senator Owens.
Thank you, Mr. Chairman. I wanted to ask about the CCBHCs. I know that there has been a push from other organizations to become a CCBHC, and I want to make sure that one, the moratorium is still in place. And then I also had a question, and I'm not sure if research or staff could answer. I know there was a $4 million line item for grants for other organizations to become CCBHCs, and I was curious if that remained in the budget in the end.
Yeah, I don't think the $4 million was still in the budget to create another one, but we can check with research. And what was your first question?
I know that we had put a moratorium on new CCBHCs through 2027. I believe we did that in the 24 legislative session. I wanted to make sure that that moratorium is still in place and that we don't have any CCBHCs coming online anytime soon where we're concerned about the over budgeting that already exists.
Very good. We'll check on that. So I don't think anybody knows. I thought it ended at the end of this year is what I thought. Scott?
I'm Scott Engelmeyer from KDADS. That money was originally set for 3 years. It was taken out of both last year's budget and this year's budget. And in response to Senator Owen's other question, that moratorium remains in place.
Very good. Thank you very much, Mr. Chairman, and thank you for the answers to the questions. And by the way, just for clarification, I wasn't on when the meeting began, but I did get on a little while after that. So just wanted to be clear.
All right. Well, thank you for that. Senator Erickson?
Thank you, Mr. Chair. Thank you for being here. Just a quick question. I have read the testimony from the upcoming CCBHCs, and they have said that they provide comprehensive, timely care in the community and that it helps divert individuals from higher, more cost-intensive levels of care. When I look at your data, I'm not seeing that bear out. Is there data that would bear that out? It seems to make sense, but I'm not seeing that in the data that you've provided.
So the MCOs have not seen data that supports that. And we have provided our data to KDADS and have not seen the information on any data that they're currently speaking to. So we would have to see that data to understand how those analysis was completed, but we have not seen that in our data.
Well, I think a couple of things. One is that a new program like this is going to have issues and we need to correct those. That's why we have and to look at, don't want to say abuse, but I will, of abuse of the billing situation. And I think that CCBHCs are aware of that. And I think that through this committee, we're going to dive into that. I do think that it's hard to extrapolate the savings that we're just talking about, that Senator Erickson talked about the hospitalization and suicides. I mean, how do we put a value on a person's life if they're saved? So I think that we all need to take a deep breath, look at the facts here as we go. You know, I know over the period of the last 5 or 6 years, mental health has just became, you know, all encompassing when it comes to putting money to it and all that kind of stuff, which I'm not disagreeing with that, but I do think that it's very difficult to have accountability in that process. But I think we need to bring accountability as much as we possibly can. And so that's part of that committee, and part of this committee's job here is to take a look at those kind of things. I wish we did have more data to quantify the savings in hospitalization and suicide rates and stuff like that. So stay tuned. Committee. Yes, Senator Gossett.
Thank you. Just a quick question about the dental. I heard through constituents during the interim that there is some concern about some of the MCOs not having many providers in their network that offer anesthesiology for some Medicaid patients who have anxiety with dental work. Could you address that?
So having all of the specialties, obviously in rural parts of the state, is difficult. We do meet network adequacy, and we are continually looking to find dentists that we could add, especially in that area, and also with developmentally disabled members. That's a significant issue as well. So an ongoing journey, but in some parts of the state, there just are not dentists that have some of those specialties.
Committee, further questions? I just might add one thing, you know, talking about, and I'll get to you in a minute, talking about the GLP-1 or whatever. So I realize we're probably paying for it for other things, but it's very difficult to quantify that maybe because of health reasons that we're saving money by these folks losing weight too. So even though we're spending that much money, are we getting our benefit by those folks not having as many health problems? So it's very complicated, I think, when we look at these issues. And
Actuary, maybe she can answer that question.
I'm not an actuary, I'm a CPA.
okay, all right, but those are
Those are things we look at on occasion.
exactly. Representative Ruiz.
Thank you, Mr. Chair. That's the question I had also about the GLP-1 medications. And if it would be great if that would be looked at all the time as far as what the cost savings is on the other end. It's prevention. You know, it could be prevention for folks that do not, if they're in a pre-diabetes kind of stage, maybe a GLP-1 will keep them from having to go on insulin or take other, you know, medications. So that's a cost savings, you know, same thing with blood pressure and other things. So I think that would be fantastic if the MCOs could look at that all the time and give us that kind of a data to see, does it balance out? I think that's good for all of us to know that.
So we have looked at that a couple times so far. We have not seen that, but it's a lengthier time span. One of the other challenges with Medicaid is members don't always stay on long enough for us to really see that benefit in their entire course of life. So yes, it is definitely a complex situation.
Representative Sutton.
Thank you, Mr. Chair. On that topic, for the state employee health plan, we've been looking at exactly the same thing. And the only way we were able to, because GLP-1s for weight loss are a pretty new phenomenon, not a long track record, the closest thing that we could come up to or come to on data was comparisons to bariatric surgery and the associated reduction in health expenses later on down the road. For those, well, I would just think that would be something that the committee should look into. We did not see the kind of savings that I was expecting. I was kind of hoping for a bigger delta there, but we ran into exactly the same issue, though, with people not necessarily staying on the state employee health plan long enough to get good longitudinal data on that. So this is a tricky one, but if you want to throw bariatric surgery into that in order to track longer-term data, that might be an avenue to attempt anyway. Thank you, Mr. Chair.
I think everything we deal with up here is a tricky one. Further questions, committee? Representative Ballard.
I think there's going to be a question, but what I was looking at is often in trying to look at performance and has a person made improvement, it cannot be the same as a physical ailment versus a mental one. One you can treat with medicine and you can say in 3 weeks it'll be better, or 6 weeks it's going to be better, or we can see the progress. But for mental, it doesn't work the same way. It's a lot more complex, and it might have taken years for them to get to the stage that they might be at currently. So I think one of the things when we look at the progress being made and are they getting better, most psychologists or psychiatrists do it in terms of where they are in the stages and can they cope with this and can they do that and can they do the other. And I'm not sure that we're not equating a plan that works for physical. I can see it and it's gone. It doesn't work that way in mental. And I think that's where most of our problems have come in, is because it's a longer stage and the movement is very small in terms of what it is and the tasks that we're giving. So if we're looking at the progress being made in mental health, I think we have to realize that it can't be measured the same way as you would someone who has a physical ailment that we can take care of. Mental doesn't work that way. So I'm just adding that because we say we spend a lot of money on it, and I agree, we do spend a lot of money, but in some areas, we are not maybe spending enough on research or whatever we need to do in the process. But I just felt I just needed to make that because we can't equate it the same way. Because there's one that medicine just won't cure. There's other things we have to do with it. And maybe that person will never, ever get to the point that they can do it, but by stages, they get better to manage what's going on with them versus it's cured. Thank you, Mr. Chair.
Any further questions? Thank you very much. I really appreciate, this is exactly what I had in mind when I asked for this information to start down this road. The only thing I might add is, would it be fair to say that other states are dealing with much the same problems that you operate in the mental health world?
I would say all states are dealing with behavioral health increases. I would say not to the magnitude that we're seeing here.
Very good. Thank you very much for that.
Thank you.
Okay. The next person we have is Chris Gard, United Health. Chris, welcome to committee.
Good morning. Thank you, Mr. Chairman and members of the committee for the opportunity to walk through this financial overview. Not to get mad at Terry, but she did steal some of my thunder here. But I think to what you were saying, Mr. Chairman, it'll be good for everyone to step through a lot of the rate build process throughout this. My name is Chris Gard. I serve as the Chief Financial Officer for the United Healthcare Community Plan of Kansas. I've been in this role for 3 years, but been supporting this health plan since 2017. Does this work? No? There we go. So today I'll focus on 4 areas. First, I'll walk through how MCO capitation rates are built. Then I'll explain how both membership shifts and programmatic changes impact those rates. And finally, I'll close with our historical performance and the outlook for 2026. I don't know if I have control of this or if someone else does. Okay, perfect. I think it's someone else. The rates MCOs receive for each membership type or rate cell are built using a number of inputs. Foundationally, they are based on historical data. Each year, MCOs submit a detailed claims and financial and operational data book through the MRT, the Medicaid reporting template. Data is from the previous year, making it roughly 2 years old for the rated year. So for instance, for 2026, we submitted that rate package back in April of 2025 based on data through 2024. We could go to the next slide. Once that experience period is submitted, KDHE, along with Optimus, their actuarial team, adjusts that historical data to reflect changes in the program and to estimate what costs will look like in the future period. So at a high level, those adjustments fall into a few categories. First, overall medical trend. This includes changes in both unit cost and utilization access across inpatient, outpatient, and other services. Second, we have programmatic changes such as new benefits or fee schedule updates. For instance, the mid-year adjustment in 2025 included changes to pelvic exam add-on codes and emergency room facility rates, both having positive and negative shifts within the overall capitation rates. Third, there are targeted trend adjustments, including ongoing updates tied to programs like what we've been talking about, CCBHCs. And fourth, there are non-benefit changes, and these account for administrative cost assumptions and P4P clawback assumptions as well. All of this is intended to take in this case, the 2024 experience and project what 2026 will look like. But as you can imagine, with that number of inputs and roughly a 2-year lag, there can be temporary misalignments with actual in-year costs when conditions continue to change. Go to the next slide, please. Building on that, shifts in membership also play a big role in both the average rate per member and total capitation. Enrollment has declined by about 21% since 2023, largely driven by the post-pandemic redetermination process. And at the same time, higher acuity populations now make up a larger share of the program. These members have significantly higher costs. So even though with lower overall enrollment, the average cost per member has increased. Stepping into the next slide, we can see this a little more clearly. Long-term care, waiver, DD, and SSI populations have grown from about 16% of the total enrollment in 2022 to roughly 21% as of January 2026. Along with that shift, the share of total capitation tied to these populations has increased from 64% to 73%. These members cost anywhere from 4 to 17 times more than traditional TANF members, for instance. So even this relatively modest shift in mix can and has had a meaningful impact on the total program cost of KanCare. Speaking of program costs, if we want to step to the next slide. Thinking back to our rate build, programmatic changes are another major contributor to cost increases over time. While this isn't an all-inclusive or comprehensive list, these adjustments do account for nearly $900 million in cumulative cost increases across the program. So this is all of KanCare, and this is across all MCOs. This is total costing here. So the $900 million that I'm referencing, or $888 million, is the total increase linked directly to these programs. So at the top, we have skilled nursing facility rate updates and HCBS rate updates, which Sunflower spoke to. And then in addition to those updates, there's also been the implementation and expansion of CCBHCs. These are all important program investments, but they do add to the underlying cost structure that rates need to inherently keep up with. So stepping to our last slide here. Putting this all together, you can see that how these dynamics affect the financials of UHC's performance. From 2022 through 2025, UHC was able to perform well while serving a varying membership base, including peak enrollment of around 180,000 members for UHC, and that was during the end of the pandemic period, the PHE. As redeterminations occurred and the programs shifted under the new contract, that membership changed significantly. Through this period, UHC and KanCare were both successful in improving health outcomes while showing cost growth limitations. But now in 2026, we're seeing costs increase faster than rates, which is putting pressure on the program as a whole. This is really being driven by how the rate cycle works and how quickly costs have changed, rather than anything fundamentally different in how the plan is operating. Ultimately, these shifts in acuity, membership, trends, and programming have created a moving target that is difficult to pin in year. So to give some grace to KDHE and Optimus, this is a very tricky job that they have on their hands. And I believe that is my last slide. So with that, I'll stand for any questions.
Very good. Thank you for this. This is very informative and exactly what I was hoping that the committee could see in a snapshot. Some of us budget folks have already seen this, but so thank you. Committee questions. Senator Gossage.
Thank you, Mr. Chair. Thank you for being here, Chris. What percentage do you know of all of those receiving Medicaid get their services through United Healthcare?
We don't act as, do you mean like a proportionate of membership, or do you mean, we're actually the number one, we have the largest market share across the MCOs.
You had the largest market share, but I didn't know as to how.
It's about 36.5%.
36.5.
Yeah.
You heard me mention earlier, constituents questioning about anesthesia for those, people who are on Medicaid, yet have a lot of anxiety when it comes to any dental work. And that there are anesthesiologists that can travel from place to place. That doesn't, since you have the largest share, it seems that what I'm being told is that United has the lowest number of providers that provide this service. Can you address that?
I don't know any specifics to the
Okay.
number of sedation dentistry that we
Okay.
offer. I will say that typically, especially as we get into the rural communities,
Right.
there might be one provider that is in network for all three. I don't think there's any opportunities for one MCO to kind of cut out the others, but I'm not sure on that exact answer.
I would like to just speak to all the MCOs, if I may, Mr. Chair. It would mean a lot to me if you could get back to me on your provider network specifically to that type of dentistry, not necessarily the dentists themselves, but the dentist having access to those services without the patient having to go to the hospital to be able to receive dental work.
Absolutely.
There's the anesthesia available. And thank you again for your presentation. Thank you, Mr. Chair.
Committee questions? Senator Petty.
I'm having a little trouble reading that last slide, number 8. So the line for the net income, that would be the net income of the MCO members. Is that correct?
Sorry?
What the net income?
Yes, that's UHC's net.
Okay,
community health.
that's your net income. So your net income that you're receiving has dropped then, as that's reflected?
Yeah, so that's a forecast for 2026, and yes, that we are projecting ourselves to be in the red for 2026.
And that's in comparison to the total expenses? It appears that's, well, the total expenses have, as I look at that, is that a minus?
Yeah, so to speak to that, we're projecting our total costs, including medical claims, operational expenses, administration, to be about $2.2 billion in 2026 as compared to total capitation revenue at $2.18 million. And so that would be the kind of upper number there.
And the capitation costs are at
2.18. Yep.
Whereas your expenses are
2.214 million, or billion, excuse me.
it's got an M there instead of a B. But is that a negative that's in front of that, or is that?
It's yeah. So the negative would just imply directionality. So we're spending, $2.2 billion, and we're taking in as a positive number 2.18.
Okay.
So that delta there is where our income would be.
But you're taking in on the net income, the 8.
That's a
80.
negative number there. Yeah.
Okay, that's a negative number there. All right.
Yeah. So yeah, to be clear, in 2026, due to this kind of inherent rate cycle process, along with other factors, we are projecting to be losing money and be paying out more in claims and cost to manage the program than we are taking in capitation.
Okay, thanks.
And the way we work it is you won't get these adjustments on those rates until November.
There is going to be, so on the typical cycle, and KDHE can speak to this much more cleanly, but there is a mid-year adjustment typically coming.
Right now?
Yeah, in July is usually when those hit. Those account for programmatic changes provider rate adjustments. It's much smaller in scale. So yeah, we would anticipate most likely the kind of catch-up would come in 2027.
Yeah. And those program rates would be the adjustments that the legislature made.
Exactly. So policy type adjustments.
Increasing rates and provider rates and stuff like that.
Yes.
Very good. Senator Gossage.
Thank you for that. And that prompted another question for me. On page 7, on this graph, and I know it's kind of hard to tell graph to graph, but It looks like as of July of 2025, even prior to that, maybe January of 2025, certainly January of 2026, we are accustomed to that the seniors, of course, that are on Medicaid are the ones that have the highest expense. We usually expect that. But now we're seeing that there are more dollars going to CBHCs than there are going to the skilled nursing. Am I reading that correctly?
So the adjustments shown here are setting a base of January of 2022. So adjustments have been made on top of that. So I wouldn't say that this is an all-inclusive list of costing for instance, seniors and HCBS users. Instead, the adjustments that have been made to capitation through that time period, starting with a base of January of 2022, these are the increases in that time. So another way of reading that would be there have been more cost adjustments to account for CCBHC utilization than there have been needed for HCBS adjustments.
And could you give us a report then on percentage of costs? Because you have what, 1, 2, 3, 4, 5, 6, 7 different categories. If you could give us a percentage of cost for every dollar spent of how much goes to each of these. In other words, 10% is spent on this, 5% on that, 20% on this. And that I think that would be good for the committee to know. Thank you, Mr. Chair.
And I think it's important to realize in that CCBHC deal is frail and elderly waiver, which the legislature has been very generous in keeping our nursing homes open. So that figure is in there. Would that be accurate?
In this case, this would be a combination of overall utilization, but these are really driven by rate increases to the FE provider community.
Very good. Representative Ballard.
I was going to ask about frail elderly, but it's always been asked. Is there anything else that's has occurred unexpectedly that allowed the fact that you may be losing money?
So the health plan, United Healthcare has done traditionally extremely well with our pay-for-performance quality measures. For those, within that, there's a contractual arrangement that we have a proportion of our total capitation at risk for these measures. The number of measures has ranged over the years, but 7 to 12 or 13 measures in any given year. And currently we have 3.8% of our total revenue at risk tied to that. So historically, we've ranged in our achievement or retention of that from maybe 50 on a low end, but 60 to a little over 70% of that. The process for setting those quality numbers, those benchmarks, is unique, and in 2026, the bar has been raised significantly, and what the expectation is for all of the MCOs, but very specifically for UHC, and because of that, we've lowered our expectation of retention. We'll do better than we did last year. I know that it's a choice of ours to pursue those kind of regardless of the attainability of those measures. I know we'll do better in all of those measures because we want to, and it's important for our members. But ultimately, despite doing as well or better, our anticipated or accrued, to use an accounting word, our accrued retention of those funds has been lowered significantly.
I appreciate that answer. Is there one or two areas that are what I would call draining more than the other?
In regards to the specific measures, or considering the differences in P4P versus medical trend?
Difference in that.
It would be, I don't have the numbers in front of me to get at this exactly. I would say the misalignment right now in our anticipated medical trend versus what the capitation rates show is a larger driver, but P4P it might be a 2 to 1 ratio between them. It is significant.
Okay. Thank you very much. Thank you, Mr. Chair.
And while we're on that, of that 84 million, how much of that would be going to your pay performance?
So when we think about the total at-risk amount of just short of 4%, it's we have about 80 million, it's like $78 million at risk. While our accrual and our expectations of retainment does vary. If I were to ballpark it, we are probably going to be forfeiting or returning back to KDHE maybe 2/3 of that amount.
So of that 84 million, 60 million?
Just short of that, probably. I'd say
Okay,
closer to
so
50.
that's figured into your loss? That's figured into the $84 million loss that you're talking about
Yeah,
here.
and
So
we
if we didn't
recognize-
charge you, you'd have $60 more million. So your loss would be 24 million? Okay, just wanted to be clear about that.
Explain that to me.
Committee, further questions? Thank you so much for being here. Committee lunch is here. I apologize for Healthy Blue, for you guys. Can we take a few minutes and grab our lunches, and then we're going to work through lunch. So I've got a pretty aggressive schedule here today, and if these guys want to get out of here, they'll work through their lunch. So anyway, we're going to take 10 minutes. Grab your lunches, and then we're going to go back to work in 10 minutes. We'll be here at midnight tonight, so with that, we're going to go ahead and start. Next, we have Blue Cross and Blue Shield. Oh, yeah, and hang on just a second. So Stephen Durst over there is the person that provided our lunch today. So, and we appreciate it very much. So, welcome. Yep.
Good morning. I think it's still morning. Appreciate the time today, Mr. Chair, committee members. I am not giving the presentation today for Healthy Blue. My CFO, David Nguyen, is, so he'll be up here in a minute. But I did want to introduce myself. So my name is Siobhan Bonilla. If you look at it and you see Cyobane, that's okay. I've been dealing with
Can
it.
you say that again, just so?
Yeah, Siobhan.
Siobhan.
Yes.
Okay.
Siobhan and
I would have.
Oh, she's not in here, but it's easy for her. She said, okay, Siobhan, Yvonne. It's easy to remember that way.
I would have butchered that badly.
And we've met before. You've broken my heart. No, I'm just kidding. But I did want to just introduce myself. I am the new CEO and health plan president of Healthy Blue. I have been here a whole 8 weeks, so I'm excited to be here. I have about 27 years of experience in the industry. And I did want to share with you that over the next couple of months, as many of you are probably going to be out with your constituents in your parts of the state, talking to them, I'm going to be doing the same thing. So I really want to get to know Kansans. I'm going to be in the markets, talking to our providers, talking to our members, and really listening to them and understanding what it is they need from a product and service perspective. So I'm not going to take a lot of time. I just wanted to make sure, since I had the opportunity and I hadn't met many of you, to do so this morning. So thank you for letting Healthy Blue present. And I'll ask David, who's our CFO, to come up and give the presentation today. Thank you, guys.
Very good. Thank you.
We're bringing up the slides.
There's your.
Oh, even better. Thank you. Good afternoon, Mr. Chairman, members of the committee. My name is David Nguyen, as Show introduced me earlier, and I am the Health Plan CFO for Healthy Blue of Kansas. Today, I will be reviewing our 2025 financials. Our presentation is a little bit different than the other two MCOs, as this last year was our first year, and our experience is not as complete. But before I dive into our financials, there you go. Before I dive into our financials, I'd like to give the committee an overview of our memberships and the members we serve. For most of 2025, we averaged around 108,000 members, with a third of our members residing in the northeast portion of Kansas, a third of our members in South Central, and a third of our members in all other counties. Of the 108,000 members we averaged each month, 83,000 members consisted of Medicaid members. That includes TANF, pregnant women, foster care, and SSI populations. 16,000 members were CHIP, and 9,000 members were the LTSS population. As we like to say, we're Kansans serving Kansans, and our staffing footprint across the state allows us to serve our members in the community where they reside, providing in-person service through community affairs, community health workers, and care coordinators. Our local community staff helps ensure that our members receive the care that they need. So you heard UHC earlier break down capitation and how it's built. We receive our capitation premium per member per month based on the member's population type. The development of that capitation premium includes multiple data points, and the actuaries would actually be more knowledgeable in explaining that calculation, as the math can be very complex. To simplify it, what I've done is I've summarized the development of our capitation premium into a single dollar bill. For every dollar we receive in premium capitation, this illustration shows the makeup of what we were paid for. As I stated earlier, we receive different rates for different populations, but aggregating the various member mix into a single dollar bill, our capitation rate development for 2025 is as follows. 91.8 cents for every dollar we receive was allocated for member benefit expense. 6.1 cents for admin and other, and 2.1 cents for care management. So how did we spend that dollar in 2025? In 2025, 92.7 cents was spent on member benefit expense, 5.2 cents went to admin and other, and 2.05 cents was spent on care management. Am I doing it wrong? Okay, you mind? Yeah, next slide, please. Okay, for 2025, the 92.7 cents that we actually spent on member benefit expense equates to $1.1 billion in benefit expense. Our top 5 categories of spend were home and community-based services, nursing facilities, behavioral health services, pharmacy, and inpatient services. As 2025 was our first year, we do not have enough experience to develop medical trend, but our top 5 categories of service spend does mirror the top 5 spend shown on the 2024 KanCare Medicaid program spending distribution. Next slide, please. So the financial information I reviewed are all reported in our annual NAIC filing, summarized in the statement of revenue and expenses. High level, we reported $1.26 billion in premium income for 2025 and expensed out $1.1 billion in hospital and medical expense with total underwriting deduction of $1.28 billion. This resulted in a $23.4 million loss, $24 million net underwriting loss for 2025. And with that, thank you for your attention today. That concludes my presentation for Healthy Blue, and we'll be happy to stand for questions.
Very good. Thank you very much for that. Committee questions. Representative Sutton.
Thank you, Mr. Chair. This does not have to do with your report. 6 months ago, there was a different person testifying. We were talking about network adequacy, however, and the number came out that you had basically 3 times the providers of any other network in the state. And I had asked a question as to how that happened and what that looked like, and I still haven't heard back. So I'm just renewing my question. How does that network adequacy? How do those numbers compute with 3 times the numbers of any of the other providers?
Thank you for the question, Representative. I don't have that answer in front of me. I will take that back and provide that answer to staff.
In hopefully less than 6 months.
Yes, sir.
Thank you.
That's the goal.
Committee, further questions? Looks like you caught everyone at a good time eating lunch and everything. I do have just a very quick, so obviously just starting out, you probably anticipated, a loss at least. Is this kind of in line with what you expected with starting a new program?
Yes, for our first year, we did expect a loss, right? Implementation and startup costs will drive some of that loss. Rate setting for 2026 and 2027 will probably help bend that curve a little bit, but it's still up to us to make sure that we manage our members and manage the costs.
Very good. Thank you for that. Committee, further questions? Seeing none, thank you very much for being here.
All right, thank you.
You got off pretty easy, is what I'll tell you. Okay, next we have Angie Yu. Angie, welcome to committee.
Hello, Chairman and committee members. My name is Angie Yu. I'm the Pharmacy Director for Sunflower Health Plan. So today, I'll be presenting some overview of the pharmacy network requirements, as well as what the data show for utilization and spend across pharmacy types for Sunflower. So hopefully the slides will be showing here in a bit. But the first slide, I will cover the Kansas Medicaid Pharmacy Network requirements, and this is pretty general. All requirements are established and overseen by the KanCare 3.0 contract, as well as the state policies. The MCOs must meet time and distance requirements set by the state for network adequacy. In addition, for pharmacies, we must allow any willing pharmacy provider that meets participation standards. and the pharmacy must be enrolled with Kansas Medical Assistance Program, or KMAP. And finally, we're not allowed to do any type of specialty or mail order steerage. So all these requirements are very important because they protect patient choice, prevents exclusive networks, as well as preserve geographic access in rural areas. So next, I just want to cover briefly on the Medicaid pharmacy reimbursement, just make sure we're on the same page before we're getting into the data. So the reimbursement methodology is set by the Kansas Medicaid NADAC policy that was effective since 2017. NADAC stands for National Average Drug Acquisition Cost, and it's the primary method for payment if NADAC is available. This methodology is applied uniformly to all participating pharmacies, and the cost to the state is 100% pass-through of what is actually paid to the pharmacies. Finally, drug manufacturer rebates are paid directly to the state of Kansas. The MCOs only assist in the process by ensuring there's clean and accurate encounter data for rebate processing. Now that I covered the basis, we're going into the data. So this first slide compares chain and independent pharmacies for sunflower in 2025. And the classifications for chain versus independent is based on the National Council for Prescription Drug Program, NCPDP, for their classification. It's based on the number of locations under the same ownerships. So under NCPDP, they consider 1 to 3 locations per ownership as independent and everything above that as chain. So here we're comparing the percent of pharmacy providers in our network and claim volumes as well as pharmacy spend. So as you can see in this data, the percent of chain pharmacies is higher in our network, and that corresponds with a higher claim volume and higher spend. And this is reflective of national patterns that also show chain pharmacies are more abundant in general. All right, moving to the next slide, I do want to cover mail order, which is another type of pharmacy. So for the Sunflower Medicaid network, we do not include a mail order pharmacy network. This allows our members to retain full choice of retail pharmacy. So for mail order, these are pharmacies whose primary business model is shipping prescriptions to patients via mail rather than in-person pickup. However, I do want to note that this does exclude retail pharmacies who may occasionally ship prescriptions for patient convenience. And this also does exclude specialty pharmacies who also mail prescriptions. And this is because their business model is focused on clinical management of high-cost, highly complex medications that often have very specific FDA or drug manufacturer requirements. So for our definitions here, we are classifying these specialty pharmacies as chain or independent based on their ownership and contract rather than the delivery method. All right, now moving into the geographic classification data that was requested. So this next slide shows chain pharmacies by geographic classification. And this is based on the Kansas definitions for urban, semi-urban, densely settled rural, and frontier. And as expected, chain pharmacies have a large presence in urban and semi-urban, and really very little presence in our rural and frontier communities. Now, this story is very different when you come to the independent slide. So moving to the last slide here for independent pharmacies by geographic classification, you can see that independent pharmacies are a lot more spread out amongst our communities and really play a huge role in pharmacy access for those rural and frontier areas. And for the percentages, it's pretty consistent between the pharmacy provider percent as well as the claim percent, but there is a larger spend for the urban independent pharmacies, and this is because of the specialty medications that are dispensed in the urban locations. This concludes all my slides. Do I have any questions?
Committee questions? Representative Sutton.
Thank you, Mr. Chair. You had me up until the last sentence. I was following along just fine. Earlier, you listed all the specialty drugs as chains. But now when we get to the independent pharmacy spend, you said that the spend is higher because of specialty drugs.
No, so the independent versus chain is based on the number of locations per ownership. So the specialty pharmacies can be divided based on ownership, either as independent or chain
Okay,
in this
but
definition.
Did I misunderstand then on the previous slide, I think we're at maybe page 5, that, nope,
It's a
4.
mail order slide.
4, yeah, on 4, the independents, when we have the 2025 pharmacy spend, we had 61% were chain, and you'd said that that was because the specialties were rolled into chains.
No, I think if you look at the mail order slide, on the very last bullet, I mentioned that specialty pharmacies are classified either as chain or independent.
Very good, very good. Then I misunderstood on slide 4, and it was reconciled on slide 5. Very good, thank you.
And I think on a note that, as the committee may be considering changes to dispensing fee based on provider type, I think it is very important to make sure we're all having the same definitions and expectations for, what would happen to these pharmacies based on their type.
Very good, thank you.
Committee, further questions? Representative Bueller.
Thank you, Mr. Chair. And this might be a nit, but how do you deal with compounded medications, compounded pharmaceuticals?
So there are very specific policies and requirements under Kansas. So for certain dollar amounts, we do based on the Kansas Medicaid policy on what is allowed and what is not. Just make sure there is medical necessity for those compounds.
So what is the delivery method? Is it chain? Is it the independent retail, or is it outside of that?
It's a variety. We see a large variety of pharmacy providers that provide compounds.
Okay, all right. Thank you, Mr. Chair.
Representative Ballard.
Thank you, Mr. Chair. Your last comment said what would happen to them based on their types. What do you mean by that?
So in earlier presentation, KDHE mentioned dispensing fee changes based on chain or independent pharmacy. So I think just want to make sure that, the definition for independent versus chain is very clear with any of those changes.
So basically, independent pharmacies are treated differently than chains?
Not currently, but the proposal is potentially different.
Okay, because I know there's a difference in reimbursement, but I'm trying to think what else is different about independence versus chain.
There's no current difference.
Committee, further questions? I just have one, and I'm not even sure this involves, but we have heard, well, it's been an issue before the legislature for quite some time, especially in Chairman Bueller's committee with long-term care facilities and them designating or not allowing a person pharmacy choice in those. Now, does that come into this? Are you talking in these deals here, long-term care?
So there may be some pharmacies that serve long-term care in here, but it's not divided out separately.
But if it was Medicaid, you would be paying for it, correct?
Yes, we would.
Okay. So, but you don't have a preference about the pharmacist that they use as far as your MCO?
So there's definitely no restrictions. We definitely advocate for patient choice whenever available. But again, this is a different set of requirements, and we currently do not have oversight on that.
Very good, thank you. You said the great word, patient's choice. Representative Sutton.
Thank you, Mr. Chair. Sorry for jumping in again on this one. You mentioned patient choice, and that's fantastic, but I noticed that you specifically left out mail order as a patient choice. Is that correct?
So there are some pharmacies that do provide shipping for patient convenience, but we do not set up a separate mail order network just specifically for that reason.
Or utilize a mail order pharmacy?
So there may be pharmacies that still ship prescriptions, but we're not indicating to the member whether they should or should not.
Very good. All right, thank you.
Committee, further questions? Thank you very much for being here. That was
And do you want me to address the obesity question that was set to Terry earlier? We can definitely submit that information.
What was that?
Ad hoc as well. The anti-obesity drug question.
Oh, yeah.
Okay, I can address the spend really quickly. So in 2025, the spend for us was 15.3 million, and the previous year in 2024 is 6.3 million. So it's a 2.4% or 2.4 time increase in spend. And there's multiple factors that goes into it in terms of the state's changing policy on what is covered. So that's one of the reasons. But another factor I think that really needs to be evaluated is the state is obtaining drug manufacturer rebates for these products, and that may balance out the cost. So that's the cost that we don't necessarily see on the MCO side.
Very good. Thank you for that. Committee questions about GLP-1.
I just checked with him about a question. It's okay.
All right. Sounds good. Thank you very
Appreciate it.
much.
Thank you.
Okay, next we have Nathan. Nathan, welcome to committee.
All right. Mr. Chairman and members of the committee, good afternoon, and thank you for the opportunity to present today. My name is Nate Burrell, and I serve as the Kansas Pharmacy Plan Director for United Healthcare Community and State. In this role, I oversee the administration of the pharmacy benefit in accordance with statute, contract requirements, and state-defined policy, while ensuring member access and supporting high-value, clinically appropriate care. Today, I will focus on pharmacy access and utilization within Kansas Medicaid, specifically examining patterns across independent chain pharmacies, mail-order use, and differences among urban, rural, and frontier communities. This presentation is limited to how pharmacy services are currently accessed and used under the existing Kansas Medicaid program. It does not address eligibility, benefit design, or decisions related to program expansion, and I'll walk through what our claims data shows about how Kansas Medicaid members access pharmacy services today. So at a foundational level, Kansas Medicaid members have broad access to pharmacy services. Members may fill prescriptions at any in-network pharmacy. You can advance the slide. Any in-network pharmacy, including independent pharmacies, chain pharmacies, and through mail order. Importantly, members are not required, directed, or otherwise guided to use a specific pharmacy type. The data shows that members generally use pharmacies located near where they live, rather than patterns driven by plan design or access limitations. Clinical management tools such as prior authorization or other coverage parameters are established through state-defined clinical criteria and the KDHE prescription drug list, ensuring consistent application across pharmacy types and regions. The key takeaway is that member access is maintained with utilization oversight applied consistently and based on clinical standards, regardless of where a prescription is filled. Next, we will look at prescription utilization by county designation, urban, rural, and frontier. Please note that member utilization data referenced throughout this presentation is from complete year 2025. Approximately 65% of prescriptions are filled by members living in urban and semi-urban counties, 31% by members in densely settled rural and rural counties, and approximately 5% by members in frontier counties. This distribution closely mirrors Kansas population patterns. Importantly, it helps distinguish access considerations from population density. Lower utilization in frontier counties does not reflect restricted access. Rather, it reflects fewer residents that live in those communities. Utilization is based on members' home zip codes, ensuring the data represents where members live, not where the prescriptions are dispensed. We move forward and we look at where Kansas Medicaid members fill prescriptions. The patterns are clear. Approximately 65% of utilization occurs at chain pharmacies, while about 35% occurs at independent pharmacies. Mail-order pharmacies account for less than 1% of our total utilization. Nearly 98% of all prescriptions are filled at in-state retail pharmacies. Of the small share filled out of state, most occurred in Missouri, largely associated with Children's Mercy and other border area providers. On the right side of the slide, you'll see that chain utilization varies by geography. In frontier and rural areas, utilization is concentrated around providers with physical locations in those communities. This differs from urban areas where utilization is distributed across a broader mix of chain providers. In some, these patterns reflect availability, not access barriers. The next slide we're going to look at highlights why independent pharmacies remain essential, especially outside of urban centers. In urban counties, about 26% of prescription utilization occurs at independent pharmacies. The majority of urban utilization does occur at chain pharmacies, reflecting their physical concentration in metropolitan markets. In rural counties, independent pharmacies account for nearly half of all prescriptions filled, and in frontier counties, independent pharmacies represent over 57% of utilization. Mail-order utilization remains negligible across all geographic categories. Independent utilization is not incidental, it's structural and necessary. In many rural and frontier communities, independent pharmacies are the primary or sole local access point, an integrated part of the broader community care, and a critical resource for members who would otherwise face significant travel barriers. If plan design or reimbursement dynamics were limiting independent pharmacy participation, we would expect utilization to decline most notably in rural and frontier areas. The data shows sustained utilization in those communities, highlighting the ongoing role independent pharmacies play in supporting local access. Turning briefly to pharmacy utilization trends, overall prescription volume remains generally aligned with enrollment trends. What has changed is the clinical complexity of the member population. Following Medicaid redeterminations, a higher proportion of members with more complex health needs have remained enrolled, which naturally increases pharmacy use on a per-member basis. Additionally, a relatively small number of drug classes account for a disproportionate share of overall pharmacy spending relative to the number of members treated and prescriptions dispensed. The highest impact drug classes within the pharmacy benefit include chronic inflammatory disease therapies, atypical antipsychotics, GLP-1 anti-obesity medications, ADHD and narcolepsy treatments, and cystic fibrosis treatments. These classes vary significantly in terms of the number of members impacted, prescription frequency, and treatment complexity. In response, our pharmacy management approach emphasizes state-defined, class-specific, evidence-based criteria rather than broad or non-targeted limits on pharmacy access. GLP-1 anti-obesity medications are a topic we're frequently asked about, including several times today. Utilizations continue to grow since 2024. Importantly, this growth is occurring within established clinical parameters. Use of GLP-1s is governed by KDHE published criteria, including BMI thresholds for initiation of therapy and documentation of clinical response for continuation. Utilization has continued to increase under these existing standards. Oral GLP-1 options introduced in 2026 are subject to the same clinical standards as injectable formulations. While per-prescription pricing has begun to decrease as additional products enter the market, sustained utilization and a growing treated population mean GLP-1 therapies will remain a significant long-term consideration for the Kansas Medicaid pharmacy benefit. The next slide reflects how pharmacy policy changes can be implemented thoughtfully and in a clinically grounded manner. In October 2025, Humira was designated as non-preferred on the KDHE prescription drug list. FDA-approved biosimilars were available at that time, though utilization had been relatively limited. The change supported increased use of clinically equivalent options within the existing benefit framework. Following the PDL update, utilization shifted significantly toward biosimilars. The total number of members treated remained stable, indicating continuity of care was preserved. This illustrates how clinically equivalent therapies can be adopted seamlessly, preserving access and continuity of care while reducing overall cost to treat our members. So to summarize, based strictly on our Kansas Medicaid claims data, members may fill prescriptions at any in-network pharmacy. Independent pharmacies play their strongest role precisely where they are most critical, in rural and frontier communities. Mail order use is minimal and entirely optional. Nearly all prescriptions are filled in-state, supporting local access and providers. Pharmacy oversight is guided by state-defined clinical policy, not limitations on access. Overall, the data reflects geography-driven utilization, strong independent pharmacy participation, and clinically guided oversight, while access remains sustained across Kansas. Thank you for the opportunity to present today.
Very good, Nathan. Thank you very much. Committee questions? Representative Reeves.
Thank you so much for the presentation. Oh, I just lost the slide. Here it is. The biosimilar medications with the reduced cost. You have here that that the biosimilar utilization increased immediately and that the total treated members remain stable. Could that also be because there is no other choice? I mean, if you can't have the medication that's been prescribed, then you have to have like a generic or something like that, or they have to fail at one before they can get to the one that the physician really wants them on. They don't have any choice.
Well, when
So how does that affect the data here?
Yeah, so when KDHE moved Humira to non-preferred, the patients did need to go through a preferred biosimilar first before they could get on the branded Humira. The physician did have the opportunity to request a prior authorization to continue them on the brand name therapy if they chose. We did not see much of that, if at all. Most of our members were able to switch over seamlessly and did not have issues with the, again, FDA-approved biosimilars.
And could that be because the prior approval takes a long time? And people don't want to be out of their Humira? Or
Yeah, so for our prior approvals in Kansas, we respond within 24 hours. So, I mean, they pretty quickly get a response on if that, if that will be approved or not. So, of
Okay, thank you.
course.
Senator Petty.
I'm looking at slide 6, and thanks for being here today. I'm looking at slide 6 and the top 5 drug classes. I'm not a pharmacist or a doctor, but those all are long-term conditions, except for the obesity agents. So that would seem that I mean, I'm just asking you, I would believe that maybe that top 5 would not have changed in the last 5 years, except for the anti-obesity. Would that be correct?
I think that would be a true statement, with the exception of the GLP-1s. Most of the other conditions have been chronic treatments where patients have had, high-dollar therapies. The one with the chronic inflammatory disease, we've seen a slight decrease because of the work we've done on the biosimilars, but newer agents have come to market that have, continued to drive the cost up in that area.
Thank you.
Of course.
Representative Bryce.
Thank you, Mr. Chairman. Thank you, Mr. Burrell. Just had a quick question. I think page 5, the pie charts with chains, independent, mail order pharmacies. There's a little sliver clinic pharmacies. And I was just wondering about the nature of that. Are we talking about a clinic that has open to the public pharmacy within that facility, or are we talking about a private physician who maybe purchases prepackaged medications from a pharmacist that a pharmacist developed, and then they dispense those without a pharmacist on the premises? Or I just wondered about the nature of those.
In this instance, it's clinic pharmacies in like a hospital or a physician's office, but it is an outpatient pharmacy that's filling retail claims. Of course.
Senator Gossage.
Thank you. I'm curious, does Medicaid allow for the same rule as Medicare in that they have to do a continuation of care within 90 days, filling a prescription while they're processing the pre-auth?
Yes, we do have a continuity of care and continuation of therapy in our prior authorization processes. Yes, absolutely.
Any further questions? Representative Sutton.
Thank you, Mr. Chair. And this one, it was just a point of curiosity as I looked at the slide. I noticed that ADHD and narcolepsy medications are combined. Is that because they're generally the same medication?
I mean, the way that we look at the class and our like cost tools there together, and is because some of the ADHD medications can be used for narcolepsy.
Okay, good to know. There are committees that actually cause narcolepsy. So
Not when you.
I was just wondering why they were combined like that. That would, thank you.
Representative Sutton, I certainly hope you're not talking about this committee.
Never, never.
All right, very good. Committee, further questions? I just have one. So, and I'm a layperson, so I have no idea but I've seen the cost. Although GLP-1 usage has increased, has the cost went down on that? At least I'm seeing that from
So some
the
of the newer
advertisements I
agents that are
see
coming to market do have a lower price point than some of the existing ones. We'll see what that does with the overall cost. And then kind of like Angie said, there's the whole rebate conversation that's all with KDHE, the MCOs. We don't have any participation with the rebates.
Be curious to know, even though usage is going up, a lower cost to us. So, okay, seeing none, thank you, Nathan, very much for being here. Next, we have Lisa Todd. Lisa, welcome to committee.
Hello, Mr. Chair and committee. Thank you very much for the opportunity to speak today. My name is Lisa Todd, and I am a lifelong Kansan. I've been a Kansas licensed pharmacist for 29 years and have a lot of years in Medicaid experience. I currently serve as the pharmacy director here for Healthy Blue Kansas. I do want to begin emphasizing that Healthy Blue understands the need and the importance of supporting our Kansas pharmacists and pharmacies. They're an integral part in our care to our members, and we do value the role that they play to our members. In our next slide, in 2025, this is pharmacy paid claims. Healthy Blue paid over 1.4 million claims, pharmacy claims. 41% of those were filled at independent pharmacies. 59% were at chain pharmacies. This does reflect that the independent pharmacies are a meaningful and important part of our network. We recognize that independent pharmacies are often the most accessible providers in our rural and underserved areas, and we are committed to ensure that these independent pharmacies remain in our network. If we go to the next slide, we have a geographic breakdown. And as you can see, based on the geographic breakdown, there are very clear patterns. So our chain pharmacies are really concentrated in the in the urban areas and a few in the semi-urban, whereas our independent pharmacies are distributed more across the state in our semi-urban, frontier, and rural areas. This just further demonstrates, why it's so important to have those independent pharmacies. Because sometimes, when there's limited access to providers, they may be that healthcare provider that members can access. One thing I did want to point out on this slide is the other category. The other category could or would represent several different types of pharmacy claims. Some may be our border state pharmacies that are in our network. They're located within 50 miles border of Kansas. And then also there are a few medications that are highly specialized that are called limited distribution drugs or LDD drugs. And these are for very rare conditions, highly specialized, and therefore only like 1 or 2 pharmacies in the entire nation can supply these medications. The other instances of other, which are rare, would be maybe some emergency fills for a member if they're visiting a loved one out of state and something urgently comes up that they would need a medication. We would provide, that medication to that member to make sure that they're safe and get their health care. But like I said, that would be rare. So I do want to point out also that all of the pharmacies in our network are enrolled with the state Medicaid program. I believe Angie mentioned that too from Sunflower, that they're all enrolled with KMAP. And then also Healthy Blue Pharmacy Network. We do meet all of the state geo-access guidelines, and so that will allow our members to receive pharmaceuticals no matter where they live in Kansas. If we go to the next slide, I was going to focus on our top 5 drug class by spend. And no surprise here, feels like this is a recurring theme we've been talking about. the top is the anti-obesity agents. Then the next we have is the anti-hemophilic agents. These are drugs that are used to treat rare blood disorders such as anti-hemophilia. Then our others is the incretin mimetics, and these are typically used to treat diabetes, and some of the weight loss medications are in there also. Then we have growth hormones, and our last one, the class is anti-psoriatics, which those medications are for a lot of different autoimmune diseases such as psoriatic, like psoriasis, Crohn's disease, and such. But all of these medications are high cost, and they are complex clinically. So it's really important that, you know, we partner with our providers and with our Kansas pharmacies to ensure these members get the right med at the right time. And I guess to conclude, I just wanted to state that Healthy Blue is committed to ensuring our members have access to their medications and support our local Kansas pharmacies and pharmacists and manage these high-cost drugs. Thank you for your time today. I'm open to any questions.
Very good. Thank you, Lisa.
Welcome.
Senator Gossage.
I'm curious that the fourth most expensive drugs are growth hormones. And these are considered medically necessary? And how many people are we talking about here?
Oh, I'd have to get the actual number. I don't have the actual number of those at this time, but we do follow the state PA criteria. All of those drugs do require prior authorization. It's around, most of the time the criteria is around members that have a deficiency in that growth hormone. It's very detailed and very complex. Sometimes there are other disease states that a member may have that the growth hormone would be needed as a secondary treatment.
So I would think it'd be few people considering the entire Medicaid population, yet, so therefore it must be extremely expensive.
They are very expensive.
Thank you. Thank you,
You're
Mr.
welcome.
Chair.
Committee, further questions? I do have one for you. So this is just a 3-month snapshot here of the last 3 months of the year.
Of the top 5, yes.
The top 5. Would it look, how much different would it look if you did an annual?
It's really not much different.
Okay, and that would be going back to my question about the GLP-1.
Right.
If the
No, it's
price
still
is
at the
coming down,
top.
it's still, okay.
Yeah.
All right, very good, thank you.
You're welcome.
All right, seeing none, thank you. You're
Okay,
off the
thank
hook.
you.
All right, committee, we'll break for lunch. Oh, that's over.
Maybe dessert, right?
That just goes to show you how far we are behind on the agenda. So with that, we will have Secretary Howard. Madam Secretary, welcome to committee.
Great. Thank you, Mr. Chairman. Thanks for the chance to be here today and to kick off the KDAD's presentation. I just have a couple slides, and then I think there's a couple things that came up in your conversation this morning I might also address at the end of my comments, just to get a couple of those things on the table. You know, we're very busy as an agency, you know, implementing many of the things that you did during the legislative session, whether those are budget items or provisos or legislation. We are very grateful for the increased funding that was provided for the HCBS waivers. You certainly added funding to all of the waivers. We'll talk a little bit more throughout this presentation about what that means in terms of weight lists. I'll get to that in just a minute. As well as, grateful for the added funding around senior nutrition programs, as well as the new funding for the clubhouse model and crisis stabilization centers coming out of the Attracting Professional Sports to Kansas Fund. Again, we would just really thank you for those. We're obviously in the process of working on those, as well as some of the rate adjustments that you made, on the waivers as well. Michelle will get into more details about the waivers and the estimated spending, but kind of the bottom line piece in terms of waivers, based on your appropriations, we will not need to start a waiver for a wait list for the TA waiver. We will still need to start a wait list on the FE waiver. You appropriate a significant amount of resources. We're still about 12 million all funds over budget as we look into the out year. So we will be starting that wait list in the coming months. On the brain injury waiver, we still show a little bit of an overage, about 400,000 general fund, but I want to watch those trends for a few months. I mean, I think we can get into the fall before we make any assessment about that. We're also doing some work with our partners, with our brain injury providers and the MCOs, around sort of the rehab aspect of that waiver and making sure we're getting people moved off that waiver. We had some barriers to doing that. While we were receiving the ARPA funds, where the federal government had some restrictions on changes we could make in waivers. But as we move away from that, I really believe that with some of those adjustments and just monitoring that I'm hopeful that we'll be able to avert a wait list on the BI waiver. And again, not imminent in terms of a wait list there. I wanted to mention one federal piece that I think we've talked to you about a couple times in this committee that we had applied a couple years ago to kind of get back into what's called the Federal Money Follows the Person program, which is the ability to get some added resources when people leave institutional care. We'd been part of that program a number of years ago, and we have a really strong institutional transition program in place. CMS really, they very much encouraged states to apply for this. They weren't getting a lot of uptake. We finally said yes. And honestly, we've now decided to withdraw from that. A couple reasons. One, CMS has told us that they expect funding for that not to be continued. And we've spent a lot of time, trying to get that into place. When we applied, we really wanted to have a pretty simple program where we were looking at kind of the non-Medicaid aspects of institutional transition, being able to maybe pay that first month rent, some of the things you need for, housing supports if a person is moving back into an apartment, doesn't have furniture, those things. And CMS really pushed us to go through a lot of Medicaid processes. That's taken a long time. And honestly, with the program ending, it's honestly not kind of worth the bang for the buck with all the other things we're working on in Medicaid right now, like trying to get the community support waiver going. So I wanted to just let you all know about that. And we communicate with our stakeholders about that. Our commitment to institutional transitions won't change, but we decided not to continue to kind of spend time, I think, almost trying to put a round ball into a square box. So, and then the other thing I wanted to just talk about is we did submit the community support waiver to CMS on April 3rd. So we are awaiting any questions and comments from them. Continue to focus on an October 1 implementation date. And Michelle will talk more about all the things we're doing, to get ready for that and all the work with our MCOs and our partners. So those are a couple things just from updates kind of from the session and where we are right now. But I did have the chance to hear some of the conversations this morning, and I did want to just say a couple things. Maybe first, when I was listening to Mr. Anderson talk about some of the fraud-related pieces. First, I would just say I'm thankful for the partnership we have with Steve Anderson's office and the great work that they do. We've worked closely with them for a long time on the DCF side because, of course, we have our own fraud investigators and food assistants. And as he referenced today, we're often involved kind of in the same case that might have come up through Medicaid, had maybe a SNAP piece, or vice versa. And we've often worked together on prosecutions. And I look forward with my DCF hat, as he's gotten some additional resources to be able to, dig more into the cash, food, and childcare areas to work more closely with him. He talked this morning about some issues to do with IDD and the IDD wait list. And that was the first I'd heard some of those pieces. And again, I've not had a chance to talk with him, and I'll look forward to seeing his report. But, I think he mentioned a number of maybe thinking that like 80% of the people on the wait list don't belong there. Let me just say a couple things about that. Before folks are put on the wait list, they are assessed in terms of their qualification for the waiver. But while they're on the wait list, we don't do an annual assessment. That's $210 a pop. That'd be about $1 million a year for people sitting and waiting for a population that functionally really doesn't change. I mean, as you'll recall during this session, you talked about that in the context of other legislation, not having, more frequent eligibility reviews and actually asking KDHE and us to look at a waiver for people who were on the IDD waiver for continuous eligibility. So again, we don't do those assessments while they're on there. So I don't know if that was his basis, that there wasn't a current assessment. But we do know that before we then bring them into services, when the slots do become available, a full reassessment is done. And we certainly don't see 80% not being qualified for those services. Again, there may be other things beyond, that interpretation, and we'll look forward as an agency to working with him and communicating more with you as that report comes out. But again, that was a little bit of a surprise. That's maybe a little bit of my interpretation. That may or may not be correct, but I did want to just clarify how we do approach the wait list on the IDD waiver. So. The other piece I think I heard this morning, I just wanted to talk about a little bit, came up, I think, in your financial conversations related to CCBHCs. Obviously, new program, costly program, important program. And so a couple things. We are looking forward to the CCBHC Sustainability Group that I think we were charged to stand up in the proviso that I hope many of you will be a part of. That will let us look at things like, what should trigger the payment rate, what should be in cost reports, but also, what are the outcomes, what's the bang for the buck for that? And I would say just internally, within KDH and within KDADS, we've been doing a lot of review and analysis, as have the MCOs. I mean, they brought forth a lot of, examples and ideas, and our team has been working on, what may be some policy ideas and policy options. And so we've, in fact, just had a chance to meet with the MCOs a week or two ago and begin to kind of talk together about what are we seeing as we look across the system? Are there things that it makes sense to, consider different policies about? Are there things that are just outliers we need to address individually? So again, it's the right time, I think, as we think about a new program phased in over 3 years. It's the right time to do that. I'm also excited on the CCBHC side that we have other resources, federally and across the country. We joined the federal demonstration grant, and I wanted to join that grant because I wanted to have more direct access to what was happening in other states, what other lessons might be learned, and also to other kinds of technical assistance resources. We also recently, and Drew will talk about this more this afternoon, we were selected from the Balmer Foundation for some technical assistance, and we're one of 3 states related to CCBHCs. There's a lot of facets to that, but the one I'm probably the most excited about, because I like really always am focused on finances and those things, is really a whole piece about really looking at return on investment, looking at financial sustainability of the model, and looking at key performance indicators. So again, I think we're at the right time to be doing the deep dives that everyone's talking about. But I just want you to know that, we've already been doing a lot of work internally across both agencies, as have the MCOs, to really try to learn from that data. So again, those are just kind of the two things from this morning I wanted to at least reference in my testimony. So that's all I had, Mr. Chairman. I'm happy to take any questions before we move on to the team.
Very good. Thank you, Madam Secretary. I think there are a few questions here. Representative Sutton.
Thank you, Mr. Chair. Good afternoon. How are you?
I'm well. How are you, sir?
Fantastic. Fantastic. While we're on the subject of updates, I think it was a year ago, we were talking about CMS coming after us for the HCBS provider certification cap. Is that about right? About a year ago? HCBS.
Michelle, I think I'm going to, can I phone a friend here? I'm not sure. Honestly, I'm not sure I'm tracking the question. Michelle.
He's talking about case management, targeted case management.
Case management, or are you talking
Yeah.
about
The provider qualifications cap is what I was talking about.
Correct, yes, so we are working on that. We are working with the MCOs and KDHE to assure that all people that serve people with HCBS have had a background check and are qualified to do so.
Are working on it. That's where we were 3 months ago. What has changed? First off, my first thing is, has CMS contacted us with any sort of Damocles hanging over us with regard to the FMAP modification that they had threatened a year ago?
We have not heard anything from that, but we do have a plan for assuring that we get, that we make sure all people are appropriately background checked. We came to find out that the MCOs were using a system where they were just taking a sample of those individuals, and that isn't what we really need to do. We need to make sure it's 100%, that anybody that comes into the home of a person that gets HCBS services has had a background check and meets all the qualifications. That's for the people's safety. And,
sure.
So
I agree 100%. The previous method of a look back was never going to succeed in getting us off the cap. I agree with you on that.
Right.
3 months ago, we had a plan too. Has that plan moved anywhere?
So we have, and KDHE may want to, okay. So we have issued a notice of noncompliance to the MCOs to come into compliance with the mandate to make sure they are looking at every single person that is providing HCBS services and make sure they all have a background check and they meet any qualifications for that waiver.
Okay, so they've received, in the last 3 months, they've received a letter that said they were not in compliance.
Correct.
Okay, anything
A
else?
second friend, if you don't mind.
By all means, get everybody up here, by golly.
I thought I was done. Yvonne Case, Director of Operations. So I'm the one that sent, in conjunction with Michelle and her team, the notice, the official notice of non-compliance with their contract. It asked them, it gave them, one of the things they said is what can we do if a provider doesn't do this, right? We gave them the answer to that. Here are the steps you take. July is the beginning of the quarter, and we measure this in quarters, so July, August, September. We won't have that data because, Medicaid, till October, November, right? But that's the quarter they have to reach compliance or receive potential liquidated damages.
Okay, and how are we calculating liquidated damages on that?
We have, it's in the contract. It's under, there's a little bit of a clause in there about, if it's not an actual LD, there is an LD that's kind of generic, right? And we want to be careful how we use that, right? We're not trying to be punitive to our partners, the MCOs, but then we would work through that, depending on how many instances they miss, if they miss any. So I think we've got a much more concrete plan than when you spoke to Michelle 3 months ago.
Okay, I'm less concerned about being punitive, because if the FMAP gets reduced, that's punitive. all right?
Agreed.
That's going to hurt.
Agreed.
And so I'm really not concerned about whether our attempt to get them to comply is punitive or not. We need compliance, or we're never going to get off this cap.
Agreed.
So with compliance, what's kind of a time frame would we have at that point to get off the cap and not have that hanging over our
And
head?
I may have to phone Michelle back, but I believe it's 8 consecutive quarters. 8 consecutive quarters. So they have to meet it every time. And so what's been happening is they'll meet it and then they don't meet it. Like 1 month, so they're not fully compliant. Some of them have met it for a quarter, right? But then the next quarter, we're falling behind. And it's because there's only been a sampling done.
Right.
There's not really a lot of allowance that there. So.
But we have a plan. We're moving forward with a plan.
Yeah.
Okay.
We are. Yes, sir.
All right. Very good. Love to see the plan actually do something.
Well, you'll see that data soon, it sounds like, and firm action taken there. I'm sorry, Representative, I just did not understand which topic you were talking about there, so thank you for that question. Yeah.
Well, on that, I thought he was talking about a corrective plan that was about targeted case management. Is someone going to address that, Michelle? Are you going to address targeted case management and where we're at in that process?
Yeah, I think Michelle can talk just generally about where we're at on the corrective action plan, all the issues that were sort of parallel to be able to get the community support waiver going. We've made really, really great progress on those areas. And so I think CMS feels good about where we're at. There's some of those things where we still need a little bit more time. Because of having to meet 8 quarters and those things, but she can update you that as part of her presentation.
Okay.
We feel very good about that. We don't see a delay related to community support waiver because of any of that hanging out there now. Lots of great work done.
Okay, and then one other thing, you mentioned the shortfall, starting a wait list for the frail and elderly. So potentially, then those folks would not be on the frail and elderly and receive services, and they would go directly to nursing homes. Is that correct?
Thank you for the question. It's hard to know. The situations are always different. Some individuals may go to nursing homes. Some individuals may not. I mean, they may not get those services. Families may provide services. They may rely on, maybe they might try, for example, to get services from the Senior Care Act or things like that. So it's not one for one. Certainly we would be tracking that as we would put a wait list into place to see what that looks like. So
That would be my question. Would you be tracking that, because obviously the costs are a lot different. $60,000 a year for a nursing home versus the frail and elderly. So sometimes we may be penny wise and a pound foolish on that too.
Yeah,
so I think we should keep an eye on that, because future legislators may understand that we're saving $10 million, but we're spending $20 million in nursing home care.
Yeah, it's an important piece to look at, and it's really obviously because of the way we budget those differently, and the fact that waivers aren't an entitlement, whereas the nurse facilities are an entitlement. So, yeah.
Many further questions of Secretaries? Senator Erickson.
Thank you, Mr. Chair. Thank you, Secretary, for being here. Just a couple of quick questions. You may have said this, I apologize. Did you address the continuous eligibility waiver, 1115 waivers for the IDD community that was passed in House Sub for 2731 this year?
Yeah, thank you, Senator. I mentioned it in passing, actually, when I was talking about the issue of what Mr. Anderson had reported about, folks maybe on the waiting list not being eligible, and I was talking about how, the status of individuals doesn't really change. So we're aware, of course, of the passage of that. We in KDHE will be working together on what it takes to do that. We'll be talking about that in our governance committee in terms of what market looks like. I mean, I think we continue to, hear a lot of things across the country in terms of timelines and delays in terms of 1115 waivers. But we understand we have that there. We'll be talking to CMS about that. I just don't want folks to have maybe an expectation that it will happen in a timely manner, just based on what we're hearing across the country about 1115 waivers, what we're hearing from CMS. But we will definitely be proceeding with that and giving you updates as to where that's at. So, yeah.
Thank you. A couple more quick ones, Mr. Chair. Thank you. It's my understanding that KDAD's changed their monthly Family Advisory Council meetings. Is that accurate? And if so, how were those changed?
I think I'm going to ask Michelle again about this. Yeah, come on up, Michelle.
Yes, we were meeting with
Michelle,
families.
please state your name and all that for the record.
Sorry, Michelle Hayden, LTSS Commissioner. Senator, we were meeting monthly with our Family Advisory Council for IDD, and a lot of family members were involved with that because of we decided to go to quarterly for that because we were tending to hash over the same things over and over, and we're still working with them on that. But we weren't able to, with other obligations, to meet every month with them. So we did decide to go quarterly on that. We also have brought in one of our vendors to help us with that meeting and making sure that we cover all the things that the people are bringing up on that. And we do have a strong contingency from Wichita that's on that Family Advisory Council.
Yes, I hear from them frequently, which is why I'm asking. So going from the department facilitating those meetings to having a vendor do the quarterly meetings now instead of monthly, was there additional expense incurred in doing that?
No, no, there has not been, other than we have already contracted with UMKC to do a number of pieces of work for us, including helping us facilitate meetings. So they are paid for their work, but we just added that on to one as part of their duties. And they facilitate meetings with the MCOs for us, with other stakeholder meetings. So it's just part of the whole package.
So they didn't charge any extra for doing now these Family Advisory Councils?
It's all within the same contract.
Okay, thank you. And one other final quick question for the Secretary. You mentioned the Balmer Foundation grant. How much of the $72 million did Kansas receive?
Yeah, thank you, Senator. I think there's been a lot of confusion about that. There's not a direct amount of dollars that are going to states. What Balmer is doing is providing states technical assistance. And I could probably work with my team to try to figure out what do we think the value of that is. But for example, we have national resources through different, consulting entities like McKinsey to help us with different work. We'll also be able to, they'll also pay for us to hire a couple of staff, but it's not a grant of dollars. It's really more of a technical, it's really more technical assistance as opposed to, Kansas is getting, $30 million, Michigan is getting $40 million. It's really the value of what they're paying for in terms of like technical assistance pieces. So
kind of an in-kind but that would be valuable to the state because then we wouldn't have to pay for that technical assistance. So is there any way to kind of get a ballpark amount for?
Yeah, I think we could probably do that. And Drew might actually have a sense of that when he testifies on CCBHC's Commissioner Atkins later today. But I think we could do that. And you're right. I mean, the fact that it's not cash doesn't mean it's not valuable. It's incredibly valuable. I mean, they're investing a lot of resource in the 3 states that they have put those resources around. That's really all about, improving, CCBHCs, making sure that those are strong entities, that they're getting the value that they're supposed to get. It's a significant investment, and we feel really, really honored to be one of the states that they selected.
Thank you, Mr. Chair.
Committee, further questions? Seeing none, thank you, Madam Secretary.
Great. Thank you.
Next, we have no stranger to this committee whatsoever, Scott Bruner. Welcome, Scott.
Thank you, Mr. Chairman. Members of the committee, I've got two subjects for you today to update. Starting with our progress on the South Central Regional Mental Health Hospital construction. As you'll recall, you authorized funding for us to construct a 104-bed new state psychiatric hospital to serve adults in acute mental health crisis and criminal defendants needing their competency evaluated and restored. 3 years ago now. And so we've been in construction since last February. We've got about 7 months left to go, anticipating opening in January 2027 and admitting our first patient that month as well. Again, I'll show you a picture that'll explain the first couple of bullet points, but the exterior structure is up, the exterior finishes are going on. They're starting to work intensely on the inside to get the walls framed and more of the mechanical systems on the inside. We do have one patient room that's almost entirely mocked up in final finishes, so we can kind of see how things fit together and check for, make sure things are fitting well, and we like the way the finishes look. The other major activity is getting positions filled for that hospital so we can start building the staff, the team, the program as well. So we've got the superintendent hired, the chief nursing officer, our compliance officer, our facilities director, chief financial officer, human resources director, procurement officer. We're working on filling some of the clinical positions, chief medical officer. We are hiring a program administrator on the clinical side to help write the program that doesn't need the medical direction. But a lot of those people now indication that they're hiring in on the job. I do a lot less than I was before with having more people to help with the team, but it's definitely adding a lot of capacity. They're asking really great questions. We're excited about the team developing there. The biggest chunk of that is hiring the staff to actually work on the units, nurses, direct care staff, social workers, psychologists. That effort was, we thought, too large and too fast for us to handle on our own. So we're in the process of working through an RFP to hire a recruiting vendor to help kind of target recruitment for those bulk positions, the 40 or so nurses that we need to hire, 60 or so nurses we need to hire, a couple hundred MHGDs, other positions. Just work with a vendor that can get that posting out a little bit broader, look beyond Sedgwick County so we don't poach too much from people that already live and work in other places in the county and draw people in from out of state and just speed up the process. We're reviewing proposals. We've reviewed the technical proposals, we're getting the cost proposals, and then we'll hopefully have an award in place by the beginning of the fiscal year so they can be working through the fall to get positions filled so we can open in January. On the next slide, there's a couple of photographs side by side. The one on the left is where we were last year, about this time, maybe a couple weeks from here, but you can see the foundation is up, and the one on the right is kind of where we were at the beginning of April. The structure's up, both stories, the roof is on, the windows are in, doors are in as well. A lot of the finishes are going up on the exterior as well. As you can see, it's a couple of three different materials, but they're going on well. Anyway, it's a picture, it's a building. It looks like something. It's exciting to walk through and kind of see how the plan is becoming real with a lot of light. The patient units are going to be really exciting to see. But good progress, and again, we'll keep you updated as we keep moving towards that January start date. The other item I was asked to talk about is contract staffing. Again, as most of you are aware, at Larned and Osawatomie, to keep our units open and serving patients, we rely quite a bit on agency staff or contract nurses and direct care staff. You've been generous in appropriating additional funds as we've asked for that to kind of fill those needs so that we don't lose capacity either in the budget that you just approved. You added $32.2 million to Larned and $7 million for Osawatomie this fiscal year to meet those needs. I'll talk about the chart here in just a second. For fiscal 27, additional thank you. We have been kind of asking for funds as we get into the current fiscal year, and so and funding the need as we go. For next fiscal year, you added some funding to our base budgets so we don't have to ask for quite as much. I'm not going to say we're not going to ask for anything, but you added $10 million to Larned and $2 million to Osawatomie to get us a little bit further into the fiscal year, and again, we'll figure out what our estimate is as we go through the budget process, but very much appreciate that additional, I won't call it cushion, is all money we're going to spend, but it makes us a little less panicky as we get into the fiscal year and trying to figure out how things will work out. The chart on the left-hand side is just showing our total spending at Larned on the top and Osawatomie on the bottom over the last number of fiscal years. The 26 number there on the bottom is our current projection through the end of this fiscal year. At Larned, we're expecting it to spend somewhere around $39.6 million in total. That's down from, during the session, around 43 million was our projection, 42.9, I think. So we are seeing the trend drop a little bit. I'll talk a little bit more about that in just a second, but making progress. Osawatomie's kind of leveled off a bit, but close to the projection, and they're saying their trend is going in the right direction. I did want to, on the next slide, I did want to just highlight a couple of things just to show you the effort that's going into not just making that contract staffing number go down of what we're spending, but to hire more state employees so that we don't have the need for those contract staff in addition with overtime and things like that. So Superintendent Topps has provided this information a couple of different times about the vacancy rate and the head count on campus. So in the one number that we're all excited about is, so in December 23, our vacancy rate campus-wide was 44%. So 2 in every 5 positions were vacant. As of April, our vacancy rate's 27.6% campus-wide, and through May, it's down to 27.4. Not a lot, but we look at every one of those tenths of a point as progress along the way. That's a huge amount of change, just in percentages, but it's also a huge amount of change in number of people. So in the table there on the staffing activity overview shows you the head count, FTE head count in each year, and how that's changed from year over year. So between 24 and 25, we added 65 state employees to the Larned campus to go from 562 to 627. It's remarkable. I mean, we haven't seen numbers like that ever, and not in my career, but we have people that worked a lot longer and they've not seen that kind of growth. So things are going all right. We want to thank you for the authority to keep using bonuses for recruitment and retention. We think that's made a difference. A lot of things they're doing on the campus also to make the contract a little less attractive to people by reducing the rate we pay the contract agencies. We're looking at kind of their performance and the quality of people they provide, and then doing some things about coverage on the campus as well. So we, at Larned in particular, they have a lot of high levels of acuity that require patients to have one-on-one or two-on-one coverage. Every time you add, or that one-on-one coverage is one person who that's all they're doing, and if you go to two-on-one, it's just a lot of staffing need. And so Superintendent Topps talked with the clinical team and the nursing team to say, are we really using that very expensive and very time-intensive intervention appropriately every single time? And what are the criteria that we're following? How long is that patient going to be with one-on-one placement? And really thinking through that, making sure there's a clinical need for it. And we've seen some turn in that as well. Other information in there about hires, but they're doing a lot of recruiting as we have been throughout. But I think what's made the difference is, again, what we feel like is competitive pay rates, thanks to your help over time, the bonuses that we've been able to do. And I think just the quality of life and the working on campus seems like a more reasonable thing to do. There's a little less overtime that's mandated and things like that, all things we've talked to you about over time. But making progress, it's slow, it's a big hurdle to overcome, but I think we're definitely moving in the right direction. Mr. Chairman, I'm happy to stop there for questions or come back at a later time.
Any questions? Wow, great.
Okay.
I'll
stick around just in case.
I have one. I'm not done. So the one thing that I always want to make sure that people understand is we see this 39 million in contract labor, and I think that's a lot of money also, but I think what we have to realize is that well over half of that, probably 20 million of that, if we were fully staffed, would be what we would spend on state employees. So I think when we see 39 million, it's like we're spending that much extra. But in fact, if we did have all the employees that we needed, it would be significantly less. I'm not saying that, but it's not like we're going to save $39 million. And I just want people to realize that. Senator Petty.
I appreciate you bringing up that point, and I do think that looking at this, going from December of '23 and having that vacancy rate of 44%, and now April of '26, a vacancy rate of 27%, and we constantly talk about in whether it's on the House side or the Senate side about those costs and what you're doing, and I do think that some of the things you just mentioned, they don't make necessarily, sometimes it's slow and steady, it's going to have that impact. And this definitely shows that it is. So kudos.
And Osawatomie, I didn't put it on the slide, but they have, I would call it, converted some of the agency staff to come and be state employees, which we've talked about in Budget Committee over time as well. What would we need to do to make that happen? Some of it's the things around being able to select their own shifts and that self-scheduling initiative that they've started at Osawatomie. Some is we've reclassified some positions to hire where it's a CNA that's working for us as a direct care staff. We're hiring that person as a CNA to work for us. So it's a little more expensive of a position for direct care, but we're getting a little higher quality candidate, and that pay difference is less for that employee who would have otherwise stayed for the contractor. So again, I credit to the superintendents and their teams on the campuses to kind of take this challenge on, give them the resources to do some things that they want to try, and really that's been paying off, and it's incremental, but it's movement, and I appreciate the work that they're doing.
Committee, further questions? Senator Erickson.
No question. Thank you, Scott, for being here. Just another way of looking at this, not to beat a dead horse, but to beat a dead horse. The $713 million that the Inspector General identified, take 40% of that. That's $285 million. And we rightfully talk about how much contract nursing and the staffing issues, but think about 39 million versus 285 million. That seems like a drop in the bucket if we just make sure that we are not having such waste and abuse happen. We could easily pay for that. And what a boon to our recruiting and retention and bonuses we could give to our state employees. So thank you, Mr. Chair.
Senator Gossage.
Thank you, Mr. Chair. Thanks, Scott. I know you've shared this with us before, but we have more patients that are in the facility now. Can you give us a per patient cost for the facility in Larned? And then I know there's a different amount for the sexual predators. Do you have that for us?
I can get it for you. Our daily rate that we calculate for our Medicaid billing at Larned is, looked at it for Osawatomie yesterday. It's about $1,700 a day at Osawatomie, and I think Larned is around $1,100. But I'll get those for you for sure, and I'll do the math for the SPTP program, what that is.
Thank you, Scott. Thank you, Mr. Chair.
Welcome.
Committee, further questions? Seeing none, very good. Thank you, Scott.
Lacey Hunter, Commissioner for Survey Certification and Credentialing.
Thank you for doing my job there, Scott. Welcome, Lacey.
Hello. I'm Lacey Hunter. I'm the Commissioner of Survey Certification and Credentialing for KDADS. My topic was an update on the surveyor positions and surveyor vacancies. So I believe it's slide 10, but I kind of have it broken down for you. We have kind of the way we still look at our hiring, we still have it broken down into 4 regions for the what we would call the nursing facility surveyor positions or the federally certified surveyors. And then we have a 5th, which would be called our state licensed only, which is your assisted living, residential healthcare, home plus, adult daycare, those settings. So as you can kind of see here, here's where we're at in all of those regions. And then I have a little bit more information on where we kind of have gotten since January when we talked about this, as far as applications we've received, things we've done. And then I have a few other notes. So we did work with the D of A and we got at least a little bit more clarification. So the position description, as it sits with the exempt status, those positions can be physicians, physician assistants, nurse practitioner, physical speech or occupational therapists, registered professional nurses. And so then the other category, which would be not exempt, would be dietitians, sanitarians, engineers, licensed practical nurses, licensed nursing home administrators, or social workers. So little bit more into that. When you're looking at the composition of a survey team, while we want to have multidisciplinary teams, the one requirement for the team, regardless of its multidisciplinary or not, is that it has a registered nurse. So when we do a survey, CMS says the RN has to be a required component. If we had a survey team with that required component who is exempt, and then the other components of the team were not exempt, they would be held to that 40 hours a week, or they would be then overtime. So we would then maybe get to a point where our LPNs or our social workers were working overtime, and their take-home amount was getting more to be than the RNs, because the RNs are exempt. They wouldn't be receiving the overtime like the other staff would. So that's kind of where we're at with it, a little bit of an update on that. The other thing we have done, though, thank you to the Senate Ways and Means Committee for moving forward with House Bill 2237. There was some more opportunities in there for bonus for retention and recruitment. So the other part of the posting that is out there is that there is a $1,000 signing bonus for these positions to try and help with that recruitment effort. So questions?
Committee questions? Senator Gossage.
Thank you for that. So quick question, $1,000 signing bonus, that doesn't always lead to longevity. What have you seen?
So the allowance for it was just made, so we haven't actually offered this bonus to anyone. So more to come. Hopefully just that advertisement gets us maybe some more applications, some more people in the door, some more people to talk to, some more interest. But the other part to it was there was some retention bonus allowances in that bill. We haven't utilized any of those yet either, but those look more like, I think it's 5 to 15% of the employee's current salary. And then I'm not sure how we would decide between 5 and 15%, but we do have that if there are employees that were, hey, I'm thinking about leaving, I got a different opportunity, or things like that. I do think that we have the opportunity to have those conversations if and when they arise.
Mr. Chair.
Representative Bueller.
Thank you, Mr. Chair, and thank you, Lacey. So can you kind of rewind that description of the survey team? I realize you're kind of getting creative on what we can do to go out and execute differently. So do we have a model, or is you just kind of built the framework around it?
So the hard part about it is when you are completing the survey process for the federal survey process, it is very computerized, and it is a system built by CMS that is very much pathways. So you enter information and it sends you down another pathway. So the way the survey process on the federal side works is you have a team for the recertification survey. Part of that team is the team lead. The team lead assigns different areas to the team to go and do the survey. You do your parts of the survey, you come back, you discuss, you decide what citations are going to be written, you go through the rest of the process. The issue that I think we have is when you look at things like travel time that's included in there and off-site hours for survey prep, you get to 40 hours really, really quickly. We did some math actually earlier outside. For a recertification survey, the average amount of hours spent on the survey, we're talking travel, on-site, off-prep, is 24.8 hours. So a little over 3 working days.
So I'm not trying to be combative or anything like that. I'm trying to determine whether we're actually any closer to solving the problem. It seems like we have the tyranny of distance. I mean the geographic distance, and I don't know that with conventional staffing, we're ever going to get there. Anyway, just, and so what I guess maybe I would ask is, we meet again in August, and I don't know if this will be back on the agenda then in August, but just to see if we're making any further headway. And because at some point, if we're going to continue down the same path of the same results, I think we need to look at a different solution or other solutions. So I appreciate what you've done. I appreciate the update. And hopefully things will be manna from heaven in August or something like that. So, but thank you for your testimony. Thank you, Mr. Chair.
Any further questions? Representative Ballard.
Thank you, Mr. Chairman. I want to check on the bonus. When they have a bonus, do they have to sign something that they will stay a year? Or do they have to make a commitment on that?
I believe the structure that was approved was that you have to, if it's the sign-on bonus, you have to be employed for 6 months and not have any kind of bad marks on your employment record before you would receive the bonus.
So, wait, you're going to sign it, but then it's for 6 months?
In order to actually receive the sign-on bonus, you have to stay employed for 6 months.
Okay. That's why I was wondering, was there a time limit? Because, I mean, otherwise I get my bonus and I leave. And that's what, but I knew you had to have something in place. But have you found out they normally stay longer than that?
The allowances were just passed, so we haven't actually offered this. We literally just put this in the job posting this week.
Oh, gotcha.
Yeah.
Well, good luck on it. Thank you, Mr. Chair.
Any further questions? Just some clarification on, for instance, or hiring them. So there's no reason, I mean, you may pay overtime, but you're just going to pay overtime. Is there any reason to avoid paying that overtime?
I don't know that we have like an ever-ending budget to pay that.
So you have the budget to pay for a $60 an hour nurse.
So realistically, the positions they're budgeted up for all of them are technically budgeted. I think we could be up to that registered nurse level, which is 67,000, or those exempt professions, which is 67,000, and then once you're certified, you go up to 69,000. The non-exempt positions, that job posting is 60,000, and it goes up to 62 once you become certified. So realistically, I think we're budgeted that 7,000 difference for each position that's vacant that we could pay in overtime each year.
Wow, I guess I didn't realize dietitians would be making $60,000 a year, I guess.
I do suspect that the amount that we pay for both of those professions is part of the reason we have issues recruiting for them.
Thank you for that. Committee, further questions? Thank you again, Lacey, for being here. Okay. Michelle, welcome to committee. You've already answered a bunch of questions already, so.
Sure. Thank you. Again, I'm Michelle Hayden, the LTSS Commissioner for KDADS. And I'll just start out with our numbers. The HCBS waiver enrollment, we continue to serve about 30,000 Kansans across the state in our 7 HCBS waiver programs. Waiting list updates. I'm pleased to announce that we are ending our physical disability wait list. We were able to send out offers to the remaining people on the wait list for PD. We just started that last week, so we're getting responses back from people, and hopefully we will be able to get them started in services sooner than later. But we will continue to monitor that closely. And we're continuing to work with CMS to add waiting list amendments for the frail and elderly and the brain injury waivers. So we have some shortfall estimates for the FE, which is for SGF, as you'll see, is about close to 5 million. And for BI, it's $324,000. So if you'll look at the next slide is, make sure I got this right, yes. Those are our anticipated waiting list updates for FE. You'll see that there's a little dip there. That's just accounting for some corrections we've done internally as far as moving people off the lists that need to be moved off because they have passed away or are no longer eligible. But then we still think that our projections are correct, that it will continue to rise as the need for people for the FE waivers. I can say the same for the brain injury waiver on the next slide. We expect it will continue to rise, and again, we'll see a little bit of a dip there. That's where we've done some cleanup and trying to make sure that only people that are qualified are on the waiver, and cleaning up people that need to be removed off the rolls. The waiting list update for the TA waiver is, thank you. The legislature appropriated an additional $7 million, so we won't have a TA waiver waiting list. We're very happy about that. We'll continue to monitor that waiver closely, though. And that is the waiver that serves medically fragile children who have technology needs. And then, so let's come to go to the community supports waiver. As Secretary Howard said, we did submit that waiver to CMS on April 3rd. We expect to hear back from them anytime now with their list of questions and things that they want to know more about. And as we're waiting for those questions, we have been working diligently with the MCOs and CDDOs and community support or community service providers and TCMs to get ready for this waiver. Right now, we're working with the MCOs. We'll be starting with the TCMs in June and providing education to them as far as providing TCM services to people on this waiver. We're doing outreach to individuals on the wait list to get on the CSW. And then we're still targeting the enrollment to begin October 1st. So the operational part of this has been really working closely with all the different vendors in order to make sure everything's in place, like Gainwell, to make sure we have the coding right in the system. The MCOs, they have to get their systems ready. There's just a lot of back-end operational work that has to be done, and we're very pleased to do that. And we've been working hard with them, and we appreciate their cooperation in this. So it's been pretty exciting. It's a brand new waiver. Kansas hasn't had a new waiver in over 20 years. And we'll just continue to work to make sure that it is successful. A lot of IT stuff we've been doing, and we're meeting regularly with all of our vendors to make sure that this is all in place. This hasn't been a light lift, but we're very pleased to do it. And we keep our eyes on the prize of starting to serve some more individuals that have intellectual and developmental disabilities. With that, that is my presentation. I can stand for questions.
Representative Ballard.
Thank you, Mr. Chairman. I am delighted to hear about the PD waiver.
Me too.
Part of that, because the sooner you start, the sooner you are. And it's one of those waivers that people get off of.
Right.
Or some are not. Unhappy about the FE waiver. Why do we have an FE waiver at this point?
Frail and elderly waiver or wait list?
Well, the wait list for it.
Yeah, so we don't have a wait list quite yet. We're still working with CMS to develop that, but we're going to have to stay within appropriations. I think some of the reasons for that are, the boomers are all retiring, and they are, we have a greater population of people that need those services. Several years ago, the legislature raised the protected income level, so more people are eligible via that. So there's just a lot of things that have gone into seeing the need for a wait list, beyond the appropriations.
I hadn't thought about raising the level that we didn't have before that may have triggered that. But I was asked this last weekend, why would there be a waiting list? Number one, a lot of those people on that list may not have a whole lot of time. So if they're on a wait list, how long would that be? The other thing came up is something that we have to go way back for when Department of Aging was independent and did not combine with any other organization. And the question I was asked, is that because they haven't been getting the attention that they need or the funding? Can you answer that question for me?
I can't speak for aging services. I can only speak to the HCBS waivers, and FE is one of the HCBS waivers. I can't speak to the aging piece of that.
I couldn't speak to it either, so.
Maybe.
If you might, Mr. Chairman, I just might say, Representative, certainly as an agency, we've tried to keep focus on all the waivers where we had demand. And I think you've seen in our budget requests, requests for the additional funding for the FE waiver and a lot of advocacy around that. I think, unfortunately, just the level of the shortfall in the FE waiver, as we looked at budget requests for the last couple of years, I just wasn't funded at the level that we had estimated that we would need. You all put a lot of new resource into it, but weren't able to, sort of meet that full amount that we had estimated we'd need. And like I said, with our current estimates, it still shows us short about 12 million all funds. And so we really appreciate the resources put in. It's just been a waiver that's had some rapid growth for some of the reasons that Michelle talked about. So again, it just kind of is what it is, sort of that balance of just the funding that's needed to do that and the amount that kind of made it through the process.
Mr. Chairman, I'll say I appreciate that. I could better answer that question. I wondered that myself, that the funding level might be what was presenting that, but I didn't feel comfortable saying so last weekend when I was asked the question.
Yes, it is the funding level, absolutely.
That's something I think we, as the legislature, has to really address, because we're talking about a population of people, many that have worked and paid taxes and did everything else, and then they're at a time in their life when they need assistance. And it's a crucial time, and we don't have enough funding for them as well, even though we may be saving money, but I'm not sure that should be an area that we're choosing. Thank you, Mr. Chair.
Representative Bueller.
Thank you, Mr. Chair. And I don't know if this is for Secretary Howard or Michelle, so it might be a tag team. And when you mentioned the budget number, I kind of had a pretty painful flashback to about a few months ago, and I think we were talking somewhere between $29 and $35 million. Isn't that what the FE roughly? So it doesn't matter because it was a painful recollection. However, where I'm going with that is, if I look at some of the data that whether Leading Age Kansas and others, and probably your agency have projected, if you look at the rate of aging in Kansas by the year 2030, 2035, et cetera, can we get a little more predictive with what we think our budget needs are going to be? And I realize it's unique circumstances for people when they age, but if you just look at that macro data of the way the state is aging, it might help take some of the sticker shock off of a future budget request. So
Yeah, thank you for that. I think that's a great idea because you're right. I mean, as we look at that, just the trend line of the aging population, we know that these numbers aren't going to get any better. And so, yeah, certainly as we put budgets together, as we project out years, and as we do maybe future presentations, maybe we can look at maybe trying to project out a little bit further so you can kind of look beyond maybe just the moment of a session. So. Yeah.
I mean, just for the thought of it, it might get us a little more proactive maybe in terms of what we have to do with budget. So I'd appreciate it. Thank you. Thank you, Mr. Chair.
Senator Petty.
Thanks, Mr. Chairman. On the community support waiver, I know this came up when we were working during the session, but what kind of impact does the community support waiver that is now you're working with all the others to get in place have on other waivers?
I don't know that it does. It's specific for folks with IDD. It's a kind of the IDD waiver light. It doesn't provide a residential services. It has a cap of $20,000, so there's only so many services that you can get. So it won't fit everybody's needs, but it can fit some people's needs. And so while as we're getting information out to people, they're going to have to make some decisions about, yeah, this is going to meet my needs, or no, I need a lot more than what is happening. And we're going to be working closely with our CDDOs on that, because they'll be doing the options counseling, and they'll be talking to families about, this is the limitations of this waiver, but it might be a good fit for a number of folks, and then they can go ahead and start getting some services. And that was kind of the whole idea behind the community support waiver.
Just as a follow-up, so you will be then surveying the IDD population before, or I should say, or will you, before you are actually opening up to people that maybe that are not on the IDD waiver right now?
Yeah, we're going to look at our wait list first and get that information out. That you're correct.
Great, thank you.
Yeah.
Representative Sutton.
Thank you, Mr. Chair, and I will keep this brief. Michelle, I'm sorry you didn't run out of the room fast enough.
Okay.
Give my brain time to turn over some more stuff. With regards to the letter that was, and this is back to the same topic that I was beating on earlier. With regards to the letter of non-compliance that was sent to the MCOs.
Correct.
I get that we told them they weren't in compliance, and that's valid, that's accurate. Was there any suggestion or path forward explained, or is it just left in your hands, fix it, and we're going to wash our hands of it?
They've had opportunity to look at a number of different ways of what they can do to address this issue. We are not prescribing to them what they need to do.
Of course.
But I mean, I've had meetings with their workforce managers. We've looked at different platforms that might be something they want to look at, but we're not going to prescribe what they do.
No, I'm
but
not looking.
they're aware of some of the platforms out there. They know that there are other solutions, and whether they take advantage of those or not, they'll have to make that determination.
Very good. I just wanted to make sure we weren't issuing a blanket decree with no parameters or explanation of how that could be achieved. So
yeah, they're aware of there's different remedies for this.
okay, very good. Very good. Thank you. Thank you, Mr. Chair, and I'll leave this alone for the rest of the meeting.
Senator Gossage. I don't either.
Just real quickly, thank you. You know, we have been working on this community support waiver and thinking it was a good idea for many years now.
Yes.
And to see it finally be submitted, I just checked with my sources at CMS and they said they're working on it. So I'm glad to hear that. But I know when Missouri passed theirs a few years ago, they basically eliminated people off their waiting list. They just had a handful left. So I look forward to that. I hope that can happen here in Kansas. And I want to say thank you all for your work on this. Thank you very much.
Thank you.
Well, committee, further questions? I don't know how I'm going to do my spiel for the community support waiver once it's done. I have that. So, yeah, just invite me just to do my talking points for the, but I do think, and thank you for all the hard work. I do think that it is a game changer in our ID and DD community. Thank you for all the legislators that have bought into it. You know, we had many meetings 3 or 4 years ago. A lot of you were involved in that, and to Senator Petty's deal, we found that really there were 7 services that most folks needed, a majority of them. And it was a lot of respite care, for instance, just for caregivers that are taking care of their kids, but they want to go out to dinner on a Friday night, you know, or go get groceries without having to be concerned. I mean, there were very simple things. And so I think that, you know, it's going to meet not all the needs, not the 14 services of the others, but it's going to meet a lot of folks off of that wait list. And I've optimistically said from the get-go that it would take half the people off the wait list. And I still believe, until someone tells me that I don't know what I'm doing, I still believe that that's accurate, that we would. And then for folks that are cost conscious, it's a $20,000 waiver versus a $58,000 waiver. So there's some savings there, and as well as taking care of our folks. So like I said, I'm going to have a huge void of 10 or 15 minutes of lobbying the committee for the community support waiver when it gets done. So, but thanks everybody for all their help. It's going to be great. Michelle, I did have one other thing. We were talking about it at the end of the session, kind of about the IDD placements with the ID community and how long it takes to place folks, pull people off the waiver.
Right. So,
Remember,
I mean,
kind of-
it's a process.
It is a process,
You
but
know, and I wish it were faster, but, you know, we have to, when we take people off the waiver because we have an open slot, you know, they have to have another assessment to make sure that they still qualify, because we don't do assessments while they're on the waiting list. If they have Medicaid, that's helpful already, but if they don't, they need to apply for Medicaid, and their coding needs to change. And that's a KDHE responsibility. And then it goes to the MCO that they choose, and they work with the MCO to develop a service plan. And then the services are authorized through the MCO to the different service providers. So it isn't an emergency system. It's a long-term care system.
and I agree, and we've had this conversation how many times, and I'm still not buying that it can be just like before. I do think there are ways to speed that up. I've had numerous discussions with CDDOs. They know who those folks are. They can get in touch with those. They even can drive out there and deliver that application to them. I mean,
And they do that.
they do. And so they're all on board. Christine's not here, but I've had quite a bit of conversation with Christine about getting them pre-qualified through KDHE. So I'm not going to slack off on this. There are ways that you know, what concerned me the most, and some of us budget folks, so we have $24 million sitting there from 2024 that we could have been placing people off, taking people off the wait list. We have $24 million from not all of 2024, but we could have taken 800 people, I think roughly, I figured out, 800 people off the wait list with using money that's existing. And so to me, that is just unacceptable. And I know it's a lengthy process and we've been through it, but that's still very bothersome for me to have that many people sitting there. You know, we've all heard 8, 10 years, and we've got the money for 800 of those people that have been there for that long that we just can't get qualified. I'm just not buying it. So anyway, keep working on it, because I'm going to keep harping on it. You know it. So anyway, I'm off my soapbox, committee. So
No, he means it too.
Yeah, I appreciate, I don't like that it takes so much time, and we're always looking for ways to move forward more quickly.
good to hear. All right. Thank you, Michelle. Thank you again for being here. Andy? No stranger to this committee at all either.
Yeah. Thank you for having me again. My name's Andy Brown. I'm the Deputy Secretary for Programs at KDADS. So I'm going to cover a couple of topics. I'm going to do it kind of quickly so you guys can ask questions. The first one was I was asked to provide an update on the community care coordination timeline. And just as a reminder, the status hasn't changed since our last meeting. Back in January, the state agencies at the MCO's request granted a deferral on the community care coordination requirements of the contract. So that's in effect until June 30th. And then that is giving us time to continue to evaluate MCO readiness, system readiness, and whether or not we as state agencies are prepared to do that. So we're still working on that, and I'll have more updates at our next meeting. The next one is around the nursing facility program. So just to go over this slide quickly on page 21, Medicaid enrollment for the nursing facilities. So beginning in April 28th, 2026, so just the other day practically, NFs, NFMHs, ICFs are going to be using the Gainwell Provider Enrollment Wizard to complete their Medicaid enrollment. So that's a fairly massive modernization effort that we're excited about. The providers are going to need to revalidate their Medicaid enrollment. We got a reminder letter from CMS the other day that went out to all states that providers are going to need to make sure that, or states are going to need to make sure that those validations are happening with regularity. So this will help us in that process, and we'll begin to send out letters on how they can re-enroll. The state staff are going to continue to monitor documentation submissions and provide new providers with their Medicaid rate and cost report due dates. And then that wizard is going to, is basically built on what was implemented back in 2022. So for our 27 rating, rate setting, those have been posted on the Secretary of State Kansas Register, and public comments are open until May 2nd, which is also passed. And then the facility changes, we had no current facilities in state receivership, and we have one facility in Wyandotte County that closed on April 3rd. That was 96 beds. For our PACE program, we have a little update here just that shows the new enrollment numbers, and there's a shaded map that shows you the different service areas. And then for the Kansas Senior Resource Guide, I'm happy to say that that's going to be published and distributed beginning in the fourth quarter. The guide's going to include information about healthcare, housing, social services, and additional resources that are helpful to the elderly. And then we're going to work on making sure that that gets updated annually. So, and then I can pause for questions.
Many questions? Wow. Good job.
Thank you.
I told you I was going to ask about the one that I emailed you the other day about. You have any updates? You want to do that publicly or do you want to do that privately?
I'll do it privately if that's okay.
Okay.
All right.
All right.
I want to know what happened.
Yeah, we need to talk. It's a kind of a classic case of, a lot of us know this, there's two sides to each coin.
Yeah.
And so I got one side of the coin. The other side looks a lot different than.
I like to hear about it. I like those kind of.
That's accurate, isn't it, Andy? Okay. Committee, further questions? All right, we're going to take a quick break here to let folks get set up for the public testimony. So we'll be back at 2 o'clock sharp. Thank you, all of you, the conferees that have stayed and are going to speak here in a little bit. Committee, thank you for hanging in here for the last, we'll be out of here by 6, I think, today. So thank you for that. So we're going to start the in-person part of our testimony, and we're going to limit it to 3 minutes so everyone can have their time. Nothing personal about anybody. It's just everyone gets a chance to talk. So 3 minutes, you will be timed. And so let's go. Colin. Colin's no stranger to this committee. Thank you for being here, Colin. Can you get up there? Hang on, we got you.
Okay. Can you hear me now? Okay.
We can.
All right. As you and I just discussed moments ago, first of all, my name is Colin Ornick. I work for the Self-Advocate Coalition Kansas for 33 years. SAC has been the voice, the statewide advocacy organization run by and for people with intellectual and developmental disabilities. Today, we're talking about the community support waiver, which we believe the fixed $20,000 cap shouldn't be there. And so you did get rid of that. And so SAC, along with other partners, asked if this thing could be removed. It was. And the other issue, though, I'm really here to talk about is the self-directed rate on the IDD waiver, comprehensive one. I and SAC believe that when you raise agency-directed rates, that you should raise the self-directed rates as well. I can tell you from personal experience, I had my PCA move to Oklahoma to start her second half of life and have had difficulty in finding a permanent replacement for her because of the low rate and wage that is provided for self-direction as opposed to agency. I prefer self-direction. I'm able to get more stuff done on my own than having to be in an agency. I feel gives me more independence and freedom and allows me to be myself. So I will stand for questions at the appropriate time.
Thank you for that. And so what's the difference between the self-directed? I guess I've only paid
Okay, yes. Agency-directed services are when you go.
But I mean the difference in cost.
Oh,
what are we paying?
I'd say.
Scott, do you know that?
Agents, I wouldn't know the agency rate, but I can tell you Shelley, my last PCA before she left, was paid, what was it, $14 an hour for doing all that she does. And while I am not as complex as others, there are more complex people that receive the self-direction, and the people are paid about the same rate. The fiscal agent who does the actual billing of Medicaid and paying of the wage to the person takes a cutout.
Okay.
I don't know how much that would be, but it came out to about $14 an hour for Shelley, and I think these people, direct support workers, need more money as well as agency supported.
Okay.
Yeah.
Well, I think for the staff and Elizabeth, if you can just flag this, we'll see what the difference is.
Yes.
And check that out. And then I may have misspoke earlier.
Yes.
It's always been, and Colin brought to my attention that this year in the budget process, the $20,000 cap had been removed from the community support waiver. I did not know that, so I misspoke if I said that. That's always been what we
Yes, that's always been, but it has been removed, I believe, because one of us, or all of us, groups, requested that it be removed because we just don't think it's enough to have a having it hit that $20,000 cap. And then you were saying about you made it more flexible with
Right. The way I looked at it was that it was an aggregate, so
Yes.
if one person only spent $1,000 and the other guy needed $25,000, that it was like that, but I need to get clarification.
Right.
Stay tuned and we'll see what's going on from that. So the agency, Scott, you'll pass that on and get us back the correct information. Any more questions for Colin? Man, they let you off easy.
Right, Jim. All right, and happy retirement.
Yeah. Thank you. I'll be around till the end of the year to pester everyone, so don't count your chickens before they hatch. All right, thank you, Colin, again. Okay, Courtney Herron. Welcome to committee, Courtney. And you have 3 minutes.
Thank you. All right. Oh, starting now. It's good to see you all today. Nice to be back. I want to focus my testimony today on provider capacity, extraordinary funding, and the need to establish a consistent annual percentage increase as the state standard and long-term goal to ensure system stability. So this past legislative session, we were able to make meaningful progress with the 6% for this year and for this next year and the 4% for 28. Providers are deeply grateful for your commitment, and while these increases will help address staffing challenges, rising costs, we must work together to stabilize this as a consistent annual investment and build it into the budget as a long-term strategy, allowing us to address many other important issues. I recently spoke with a CEO of an InterHab member in Manhattan who described support to an individual with complex behavioral needs and the lengths that they went to support them in a home environment instead of an institution where they were headed. This man is an active participant in their community and lives in a home that allows for personal choice with skilled support from trained staff. Significant modifications were made to the home to ensure the safety of both the individual and the staff providing care, which come with substantial costs that are not accounted for when the investments are made into the IDD waiver. Despite the higher level of need, the individual doesn't receive specialized funding that reflects their support needs at the provider's bottom line expense. Without reliable access to tools like extraordinary funding, providers are often unable to financially invest in complex support needs, like the previous example, or sustain the staffing levels required. If extraordinary funding is granted, providers invest heavily in support that successfully stabilize an individual, only to see the funding reduced or removed once progress is made, creating a system where success is penalized. I also want to raise an important question as we look at the broader system. As a statewide association representing providers across Kansas, InterHab is interested in understanding how our HCBS system is demonstrating to CMS that services are being adequately funded. Federal requirements are clear that states must ensure provider networks are sufficient to meet the needs of individuals receiving services. When providers are unable to accept referrals, when staffing shortages limit service availability, and when funding does not align with the level of support required, it raises a fundamental question about whether our current system meets that standard. This is not about placing blame, it's about ensuring transparency. And we believe that this is a critical part of the conversation as Kansas continues its modernization efforts and works to reduce the waiting list. Your willingness to listen and engage has been critical, and it gives providers hope and meaningful solutions are possible, sorry. Thank you for your time, and I appreciate your commitment to all of us on the IDD service field. I will stand for questions, but also I'd like to say there was a question this morning about an 80% from the Inspector General. If you want, at the end, we could maybe give a little insight into that if you would like. So, thank you.
Very good. Thank you for that. Committee questions? Seeing none? All right, you're good. Thank you. Okay, next we have Jeffrey.
That's fine.
Jeff, welcome to committee.
Thank you. Chair Carpenter and fellow members of the committee, thank you for the opportunity to speak today. I'm going to be talking briefly about early impact of IDD modernization efforts by KDADs, especially as related to the targeted case management system in Kansas. Some of you have seen me before in other conference committees, but this is my first time with the Bethell committee, so thank you again for the opportunity. I assume you all are familiar with the TCM issue as far as conflict of interest, so I won't go through in any significant detail on that. You can refer to my written testimony for a little bit of background on that. But Cottonwood Incorporated, who I work for, is considered a conflicted case management agency. We currently provide services of with day, residential, supported employment, and case management. In early April, we were notified by 2 of our case managers that they were resigning their positions, partly due to the modernization efforts and the eventual separation of TCM services, so that they could have, a more consistent, predictable situation for the next couple of years. Totally understandable. At the time that occurred, we had 9 TCMs, so that represented about 20% of our case management capacity there, and we served about 309 individuals. In the process of this, we looked at the feasibility of rehiring those positions, and given the timeframes that we were looking at, which is just over 3 years away before separation is going to have to occur, it really didn't make sense to rehire those. A position like case management, to be really efficacious, in my opinion, requires a deep and long-term relationship with somebody. It's at least a year with competency of any real capacity for the position, and it takes much longer than that to know the true needs and wants of the individuals that you're working for. As such, we decided not to hire those positions. That created a capacity issue at Cottonwood. We had to make a choice between either cutting some individuals from our services or making caseload sizes that were incompatible with the service in a quality manner. We elected to go ahead and terminate some services, which is a huge step. We may be the first provider in Kansas to do that. In doing so, I kind of steered our management in a direction to look at folks that we felt were currently very stable and could weather such a change at this time, because any influx of need into the system is going to create some capacity crisis. There was a great deal of consternation in our catchment area about this influx of 48 individuals that we had to cut services to. There is currently capacity to serve them, and even as such, the other providers were worried about what was to come, and I don't blame them for that. KDADS, up to this point, has been very open in their communication with providers in terms of feedback on the modernization that they are trying to undergo, and I commend them for that. That's about the only commendation I can offer at the moment, though, because up to now we've been given no real guidance on how do we undertake these kind of changes, leaving providers like Cottonwood to make very difficult decisions, such as that I just described, cutting services to individuals or having ineffective service, potentially, for the remaining period of time. So again, we decided to go ahead and cut those individuals from our TCM roles. I sent out notices for that on April 6th. About 10 minutes after that, I started getting phone calls about it. And those were some eye-opening, heartbreaking, and therapeutic phone calls that I had with families, individuals, guardians. They were the overriding response was one of dismay, anger, frustration, not with Cottonwood, not with the IDD system as a whole, but with the idea that this is what it's going to happen over the next couple of years, and that those individuals really did not have good guidance from KDADS itself about what these changes were going to be, leaving that to providers to really articulate to the individuals that we're serving. One response, however, really did stand out, and it was from KDADS. And may I finish real quick?
Yeah,
Yes.
wrap it up very quickly.
So the one response that we got from KDADS that was fairly upsetting was that they suggested that by doing this, we were in violation of our licensing agreement, that we were in violation of our affiliation agreement, and that we were in violation of the final rule, which is the very statute that is driving these decisions. Providers need grace and opportunity to work on transition plans so that the individuals that are receiving services are not left in the lurch at the end of the day. Normally, we have to ask for a direct actionable thing. It's not really here, but if you guys can please encourage KDADS to come to the table with providers and talk about novel and unique approaches to solving this problem, I think as a group, we can help ensure that the individuals will not be without the services that they so desperately need.
Thank you.
And
Senator
I will
Gossett.
stand for questions.
Thank you. Jeff, you understand why we have to stick to our time limit.
100%.
Thank you for being here. And, Cottonwood has an exceptional reputation. I understand the frustration of we provide these amazing services. We haven't done anything wrong. Our patients, our clients are absolutely thrilled and happy with the services that we provide. But then you also understand that this is coming from the federal level as a requirement that's been going on now for several years. They've been giving states a little bit of leeway. We're going to give you a little time, work on this, how to change it. We heard today that they're not really prescribing how to do it. What you're saying is we understand they're not prescribing it, but we don't know where to go, how to go from here. Is that what I'm hearing you say?
Correct. And then receiving feedback suggesting that the actions that we are taking, which are in direct response to that, are somehow a violation of our licensing requirements and things like that, which they categorically are not.
Have you requested then a one-on-one meeting with our department, and where have you gone from there?
Not explicitly. This is fairly new, as I said. We kind of undertook this at the beginning of April, not anticipating that we would have to address this quite so early in the process of this. And so, we had to deal with it in a fairly time-limited capacity, and so we chose the direction we were going to head, and it's been instructive. I think it has been helpful in us understanding how the system is going to respond in general. I'm very heartened by my fellow providers in the Douglas County area that have stepped up and offered to increase their own capacity, non-conflicted providers. And again, I'm not here to say that we should change that trajectory. It's really just that I would hope that we could all be supportive of one another and understand that providers are going to have to make very difficult decisions, and that those are not personal. They are business-related decisions at the end of the day to comply with the requirements.
Well, thank you, and thank you for being here. And I hope that you can set up a meeting with them, and I'd be happy to assist with that in any way that I can.
Much appreciated. Thank you.
Thank you, Mr. Chair.
Representative Bueller.
Thank you, Mr. Chair, and thank you, Jeff, for being here. And this is a question about process, or maybe if you don't have the answer to it, maybe one of the subsequent conferees will. Seems to me last year that the only willing and qualified provider exemption was actually gaining traction and some legs. And I see some heads shaking. So I want to know more about that, because I thought in 2025 there was a path forward. We were going to be able to talk about targeted case management, and that the number of individuals that you're talking about, that there was going to be a solution for them. So are you saying there's something that's not true?
It's a very specific situation for each provider. Cottonwood provides two services that are unique in our catchment area. It is a day vocational program under our 14C program, and a supported employment program that no other provider in our area offers. And so when we look at that and start doing some data analysis, a good chunk of the folks that we would be able to provide TCM services to under the only willing and qualified provider exclusion, if we were to pursue that, we would still be losing people, generally speaking, because if we refer them to, if they wanted those particular services, we're the only provider that would offer them, and then we would have to cut them loose on TCM.
That is encouraging, because, I mean, the way, when I was reading and inferring from your written testimony, it's like, holy crap, we've gone backwards a year. But it doesn't sound like, pardon my language, there is an option with the only willing and qualified provider.
Potentially, yes, for specific providers, yes.
So as I'm looking out into some of my other friends in the crowd, if you can help me calm my angst on that, I'd appreciate it.
I will offer that the policy is thick with detail and is very difficult to parse to understand how the only willing and qualified provider exclusion will work. That is really going to be a good question for the folks at KDADS who are drafting that policy, but also for CDDOs, because they are really on the hook based on that policy for guiding and implementing the only willing and qualified provider exclusion. Providers ourselves would not be allowed to apply for that. We have to apply for that through the CDDO per policy. And so it's really going to come to them about what is their capacity to handle such requests. And I think as the original envision of that, it was sometimes referred to as the rural exemption. And I think it's really going to be utilized more significantly in our more rural areas of the state. Lawrence, obviously not really that same demographic. And so for us, you know, we did approach this from a purely business kind of perspective of what makes sense going forward and how do we limit any potential harm to the individuals that we serve. To us, it was better that we start doing some small influxes of need into the system rather than come 2029, here are 310-ish people who suddenly need case management with no system in place to support them.
Thank you, and thank you, Mr. Chair.
Committee, further questions? Thank you very much, Jeff.
Thank you. And yes, Representative Carpenter, congratulations on your retirement. I've very much appreciated working with you over the years. All of your support for the IDD system is greatly appreciated.
Thank you. Thank you very much. Megan, welcome to committee.
Thank you. Good afternoon, Chair, members of the committee. Thank you for the opportunity to be here. I just first want to thank you for your continued support. You know, we made a good amount of progress this last legislative session, and you have spent a lot of time with me and our providers, and that is greatly appreciated. You also heard me talk a lot about capacity, and I want to share what that means on the ground. Yesterday, I visited a provider in Southeast Kansas. I was in Pittsburgh in the Columbus area and heard firsthand what that looks like for them. Capacity is not just the waiting list, it's whether services are available when people need them. And right now, we're facing an invisible waiting list. Providers want to serve but can't because they don't have the staff or the financial stability to do so, leaving families waiting longer and communities without local options, especially in some of these more rural areas. The provider I visited yesterday shared that the same staff running day services, so they're working their day job, right, are also driving their bus routes in the morning and the afternoon. So I'd like you to think about any job that you've also been asked to do the transportation for as an addition to your day job. I think that level of flexibility and commitment is extraordinary, and it really reflects how hard providers are working to keep services available in their communities. They are doing more with less every single year. In addition, the recent 6% and 4% rate increases truly do matter. They're helping stabilize the system, and the providers I've spoken with are already planning to use these dollars to raise wages for direct support professionals and help offset the incredibly high rising costs of benefits like health insurance. But until we implement a sustainable annual increase, you're going to see me here every single year asking for more money because that's just the reality of how the system works. You are the sole funder of IDD systems. So I want to be clear also that providers can't solve this alone. The workforce shortages are significant, and licensing and system transition take time and often come without clear guidance. Funding structures, especially the current bridge rate, do not reflect the reality of supporting a higher needs Kansan. I got a text today related to licensing. There's 2 new TCM providers who want to come on board and provide TCM services, and they were told that it will take 6 to 12 months to become licensed as a TCM provider. That's a problem. If we want to build capacity and we want to move away from situations like Jeff is sharing, it can't take a year to license a new provider. Extraordinary funding can also be slow and unpredictable, and the administrative side of managed care, denials, recoupments, and excessive documentation pulls time and energy away from care and creating additional instability. We understand that the MCOs have a responsibility for accountability. We absolutely understand that. These processes tend to lack transparency and consistency, which adds administrative burden to the providers. And every hour spent navigating paperwork is another hour that they're not able to provide direct care. So I truly believe we are starting to get this right. We're working with KDADS, we're working with the MCOs, but there's a lot of work to go. And I think we need to continue that alignment so that we can make process on certain policies and different things within the system. And with that, I'm done.
Perfect. Elizabeth, will you flag the process for becoming a TCM? I think that the committee would enjoy, or at least we need to know that process. It doesn't seem like it should take a year to get licensed, at least from my point of view. Committee questions, Megan? Seeing none, thank you. Thank you for being here. Next, we have Erica. Erica, welcome to committee. You have sat patiently through this whole thing.
Oh, my pleasure.
Boy, you're good.
Well, thank you, Chairperson Carpenter and members of the committee. I appreciate the opportunity to be able to speak with you today. As you said, my name's Erica Bates. I'm the president of Minds Matter, and we're a provider serving individuals on the brain injury waiver in Kansas. So today I would like to highlight several critical concerns and priorities impacting Kansas with brain injuries, as well as providers that support them. So first off, we are deeply concerned about the loss of the Money Follows the Person program in Kansas. The elimination of MFP will significantly reduce opportunities for people to transition from institutions back into their communities. In addition to that, that human impact that's being felt, we're also going to see a change in the anticipated key funding that was going to offset some of the costs on the brain injury waiver. Utilizing MFP means that people would have been able to access enhanced funds for 1 year after they became eligible for the waiver. And now that those funds are gone, we're going to feel that financial pressure come back to the waiver, which, you know, we already have limited resources. Next, I want to talk about self-direction. Self-direction appears to be at an all-time low in Kansas. It needs to be a priority area for our state. The data is clear. People that have self-directed services have better outcomes. Research shows that they have fewer hospital stays, fewer emergency room visits, and also fewer skilled nursing admissions. In addition to that, they report less neglect, being more satisfied with their services, and they have less unmet needs than those who are not self-directing. Kansas should be actively finding ways to explore policy and strategy to enhance self-direction and increase that participation, not only on the brain injury waiver, but across all HCBS waivers. Third, I want to express my appreciation for the additional funding provided to avoid a wait list for the Kansas brain injury waiver. That investment is both meaningful and necessary. As our waitlist mitigation work group begins identifying that mitigation strategy, I want to strongly encourage robust oversight. We need that to ensure that equitable practices exist amongst MCOs and providers. That consistency and transparency will be essential to ensuring fair access to services and avoiding a waiting list in Kansas. And then finally, I will echo Colin, parity across waivers in the attendant care rates is essential. Disparity in rates create workforce challenges and inequities in service delivery, and aligning rates across waivers would support provider stability and improve access to care for the people who rely on those services. So thanks for your time and consideration, and also for your continued commitment to Kansas who rely on HCBS services. And I'm happy to stand for any questions.
Very good. Thank you, Erica. Questions? Seeing none.
Okay, thank you.
Okay, Kay. Kay, welcome to committee.
I'm Kate Kemp, and first I want to express my sincere gratitude to your investment in HCBS and the BI waiver. Because of your funding decisions, Kansas with TBIs have access to essential supports without being placed on a wait list. That access has made a life-changing difference for my family, and I am deeply thankful for these services. My testimony today is to share the impact of the TBI waiver on my mother, Brenda Cornwell, and on me as her daughter, primary support person and rep payee, and to respectfully urge you to protect and strengthen this program, including addressing the urgent need to rate parity for direct care workers. Before my mother received services, her condition had deteriorated significantly. She struggled with severe self-neglect, and which demanded constant supervision. Her injury had also caused intense emotional dysregulation. Her impaired judgment made her extremely vulnerable to exploitation. She could not reliably recognize when others were taking advantage of her, placing her safety and well-being at constant risk. With the HCBS supports in place, my mother has made substantial, meaningful progress. She's been able to transition from living with me to living independently. This is not possible without the structure, monitoring, and support the waiver provides. But because of HCBS, she can now safely live in the community rather than an institution. A full range of services has been essential to my mother's success. Cognitive therapy has helped her with her memory, attention, and problem solving, enabling safer decisions. Behavioral therapy has provided tools to manage agitation and regulate emotions. Physical therapy has improved her mobility, strength, and ability to complete daily tasks independently. Because of the brain injury waiver, my mother receives appropriate care without placing impossible physical, emotional, and cognitive demands on me. This support allows me to focus on maintaining stability, continuing my education, and preparing to re-enter the workforce, even while living with my own disability. The Kansas TBI waiver is not simply a line of item in a budget. It is a lifeline that prevents institutionalization, supports families, and protects both disabled individuals and their caregivers from preventable crises. Thank you for ensuring that Kansas with brain injuries are not placed on a waiting list for these essential services. Your decisions make it possible for families like mine to survive and to live with dignity. Thank you. And I'll stand for questions.
Very good, thank you. You did a great job. Questions for Kay?
No.
You must have done a great job because there were no questions.
Well, I don't have a question, but that's what this program was for, and you went through all the things that we wanted to do. I just want to say thank you.
Thank you. I appreciate it.
Representative Ruiz.
Sorry? I'm so nervous.
I don't have a question either. I just want to make a statement of thank you for supporting your mom. I know you said you have your own disability and having to kind of manage both, but just even being your mom's payee is huge.
Yeah, it is.
Huge, 'cause you know how complicated that can be. So
Yeah.
thank you for doing that for her.
Thank you.
Now you're done.
Thank you.
Thank you. Next, we have Tom Hastings. Is Tom WebEx? No? Tom? Okay, if he comes back in the room or whatever, we may move him up. Okay, no stranger to this committee whatsoever. Heather Braum, thank you, Heather, for being here.
Thank you, Mr. Chair and members of the committee, and thank you for the opportunity to speak today. Again, I'm Heather Braum, Senior Policy Advisor with Kansas Action for Children, and we want to thank you and the entire legislature for making sure Kansas kids continue to have access to the Children's Health Insurance Program, or CHIP, through 2 legislative actions this session. First, the legislature permanently fixed the error in the CHIP statute with the passage of Senate Bill 271 this session. I no longer have to say a certain phrase in front of you all. We are particularly grateful to multiple members of this committee for championing and pushing this issue across the finish line after several years of advocacy. We also want to thank you for the additional $15 million in state general funds and $56.5 million in all funds for the CHIP program, needed because of increased enrollment. At the end of 2025, nearly 58,000 Kansas kids benefited from CHIP health insurance coverage, and another 225,000 kids are enrolled in Medicaid. This provides them affordable access to timely health care, including doctor and dentist visits, medications, therapies, mental health appointments, and hospital stays. That said, the work to ensure all Kansas kids have access to health insurance is never over because we keep having kids born year after year. Last fall, we learned that for the first time in over a decade, more than 7% of Kansas kids are estimated to be uninsured. Let me say that again, 51,000 Kansas kids are estimated to be uninsured, and that is an increase over the last several years. Based on estimates of family income, many of those kids likely qualify for KanCare coverage, yet are not signed up. So we urge this committee to investigate why these eligible kids are not enrolled in KanCare, and then actively pursue legislative and administrative solutions to reverse this concerning data trend. Because again, that data is from 2024 and it's 2026. We're always on a data lag, so it's likely even higher, we're afraid. Some potential avenues of investigation include current outreach practices, parent and community education around insurance options, and the enrollment and renewal hurdles that families may face. While we celebrate the progress made this past session for the CHIP program, we have much more work to do to ensure fewer Kansas kids go uninsured. We must all work with parents and advocates, educators and providers, researchers and agency staff to get to the bottom of why so many children in our state are not connected to health insurance, no matter the type of coverage. Keeping Kansas kids covered through health insurance benefits all of us now and into the future and saves the state money long term. We invite you to build on the work of this legislative session to strengthen access to child health insurance in our state, and we stand ready to work with you to pursue this goal. Thank you again for the opportunity to speak, and I'll stand for questions at the appropriate time.
Very good. Thank you, Heather. Committee questions. Senator Petty.
Thank you, Mr. Chairman. And I know as others on this committee, but I appreciate the opportunity to have worked with Heather over the years to make sure that we got that chip fix. And the fact of, as we've talked and listened to our agencies all morning long, if we want to address the escalating cost of healthcare, and we have to look at how we can make sure that our youngest are insured and those health issues are addressed early, because if they are addressed early, they can be mitigated, and if not, they just become worse. So thanks for all your work, and I know we'll continue to see you.
Thank you, Senator.
Committee, further questions? Seeing none?
Thank you.
Thank you, Heather. Karen? Karen, welcome to committee.
Thank you, Mr. Chairman. Good afternoon, members of the committee. My name is Karen Brayman. I'm Senior Vice President of Clinical and Strategic Initiatives at the Kansas Hospital Association. And I'm here today on behalf of the Kansas Hospital Association to provide an update to you all on a pilot project that will be conducted as part of the Rural Health Transformation Program. It is a centralized credentialing verification pilot, or CCV. Credentialing is the process that's utilized to verify a provider's licensure, their credentials, their medical training or other specialized training, certifications, conduct background checks. You heard earlier from Megan with InterHab, sort of the licensure and credentialing process that her constituency group goes through. Well, today's credentialing system has become overly complex and incredibly duplicative and wasteful. Providers must first enroll with the state of Kansas Medicaid program before they can become credentialed with each Medicaid managed care organization. Each one of those health plans conducts the same primary source verification for every provider that must be credentialed. So they are contacting the primary sources, medical schools, residency programs, verifying licensure, background checks, and doing that over and over and over again for that same provider. We have heard from providers within our hospitals that they may be submitting the same exact information about their credentials 6, 12, up to 12.5 times. And then that process is repeated over and over again. And so the result is then that the timeline becomes very extended. So just to participate in Medicaid as a credentialed provider, it may take 60 to 90 days for the state enrollment process to take place, and then another 60 to 90 days for the managed care organizations to credential that provider. So at best, we're looking at a process where it may take 6 months for a new provider who's just been hired, maybe out of residency, ready to start practice at a rural hospital in Kansas, and yet it will be another 6 months before that physician can see patients and then bill for those services rendered to those patients. And that's best case scenario. I've heard timelines up to 18 months for a provider to become credentialed by a health plan and then be able to bill for those services rendered to the patients. So what happens then is a reduction in access to care. So patients, especially in our rural areas, are waiting longer and longer to be able to see that new provider. And in the meantime, those hospitals that have hired those providers are paying for that provider's time, It may be $6,000 to $8,000 per provider per month while they're waiting for that provider to become credentialed. So this pilot, the centralized credentialing verification pilot, offers a practical solution for this. What we're proposing for this pilot is one application to be submitted by the provider to be credentialed, one review that is conducted by an accredited centralized credentialing verification organization, and then each plan would have access to that information through a secure confidential portal to access that. It would preserve payer decision-making. It would preserve the hospital's ability to make determinations. The potential savings are significant. So happy to answer any questions. I know I'm
I get it.
at time, but happy to answer any questions that you may have.
Thank you for that. Senator Gossage.
Thank you so much for being here, Karen. As I read through your testimony, this is a pilot that you're recommending? Is that what I'm hearing you say?
This was a pilot. Thank you, Senator, for your question. This was a pilot that was written into the proposal for the Kansas Rural Health Transformation Program.
So part of the requirements of that proposal is that this not be a one-off. So it has to be something that could be sustained?
Yes.
Who will be sustaining this?
We believe that it could be sustainable through fees paid into the program. That sustainability has not.
Fees, the providers paying a fee to participate? Is that what you're saying?
No, actually, health plans and hospitals and healthcare organizations pay for this process already, and they're paying for the same process to happen across every health plan. We believe there are significant savings that are available through this. I mean, just with Medicaid alone, we are estimating, based on other states' experience.
You have other people, so I didn't mean,
Yes.
don't mean to rush it.
We do believe that it's sustainable just in the savings.
I get that.
Yes.
So then you think that this can be sustained, you said through fees, and I was just wondering who would pay the fee if we are going to keep this program in process. I 100% agree. What I'm finding difficulty to believe, though, is that there are only 3 MCOs in Medicaid. So at most, a provider to get certified would be filling out 3 applications. Am I right?
For the KanCare MCOs, that is correct.
Okay.
But this process applies to every commercial plan that they would participate in as well.
Okay, so using those dollars for them applying to be certified with commercial plans in addition to MCOs.
The plan would be sustained through savings that each health plan would save by not having to conduct the same process over and over again for
No,
providers.
I totally get that. I'm just trying to figure out who pays and is it sustainable and that we're using these dollars or we're asking to be able to use those dollars for that. Thank you for the clarification. Thank you, Mr. Chair.
Thank you for the question.
Representative Reeves.
Thank you, Karen, for the presentation. Knowing what this process is like, is this also discouraging for providers, for physicians, anybody that is trying to get credentialed, knowing how long it takes for the whole process?
Representative Ruiz, thank you for your question. And I understand it was our providers discouraged by this process. Yes, I believe so. We've heard from our hospitals, not only is it discouraging for the provider who, think that they get out of residency, they finish at the end of June, ready to start practicing July 1, and they can't because they're waiting for health plans to provide that, notice of credentialing approval. And, what are they to do in the meantime, and not see the patients that they've been trained to see?
Thank you.
Thank you.
Well, this committee is only charged with Medicaid and KanCare. So as far as the other hospitals and providers, we can't have any, we don't have anything to do with that. But I thought, and Elizabeth, you can flag that for me, but I thought we had made some significant improvements on credentialing. The MCOs have much the same provider credentialing. Didn't we have that, talk about that? And then I think KDHE has also made some significant improvements to improve, and that would only involve Medicaid, but maybe we could get a refresher on that at the next KanCare oversight. And while I'm thinking about that, every time KDHE comes before us, they should report on the status of the rural health transformation grant. We didn't hear a word about that earlier today when they were here, and that has nothing to do with you, but I'm just talking. Committee, further questions? Representative Bryce.
Thank you, Mr. Chairman. Thank you for your testimony. Just a quick question about your scenario you had where there's a provider that waits up to 18 months for credentialing before they see patients. Is there not anything in place where they could go ahead? That's just for reimbursement. Couldn't they go ahead and be seeing patients and then retroactively, after they meet approval, they bill for the patients they've seen up to that time? Or is that not possible?
You know, Representative Bryce, thank you for the question. I am not certain about the ability to retroactively bill and which plans allow that, but we could certainly take that back and get this information back to the committee.
Thank you, Mr. Chairman. I just know that when patients are admitted to the hospital, the beneficiaries, if they don't have, they're not on Medicaid, but they qualify for Medicaid, and retroactively you bill for things in the past. I just wondered if the credentialing could be something similar where these people would not just be twiddling their thumbs, soaking up money, and could be seeing patients, but
Sure, and a fair question, but because that provider wasn't credentialed at the time they saw the patient, whether or not that introduces additional liability or not would be something we'd have to research, but we can get that back to you.
Okay, thank you, Mr. Chairman.
Thank you.
Very good. Thank you. Committee, further questions? Seeing none, thank you very much for being.
Thank you, committee. Appreciate your time.
Kirsten? Welcome to committee.
Good afternoon, Mr. Chair and members of the committee. Thank you for the opportunity to present here today. I'm Kristen Atta, Executive Director of the Kansas Home Care and Hospice Association. We are a trade association of 64 in-home care providers that includes home health, home care, and hospice agencies throughout the state. First, I want to express our appreciation for the words of support for home and community-based services we heard during this past legislative session. There were several rate increases for HCBS waiver providers, so we are grateful for that. And that gives us some optimism as we continue our work for improved Medicaid home health rates. I want to reiterate that Medicaid home health is distinct from the HCBS waivers. The majority of home health services are mandatory components of the Medicaid state plan and have been for nearly 50 years. Home health provides medically necessary skilled services in the home, including skilled nursing, physical therapy, occupational therapy, speech therapy, and home health aides. Services are typically short-term in nature to primarily homebound patients. Services may be ordered by a physician following a new diagnosis or a change in condition, or can be ordered to support recovery from an illness, injury, or surgery post-hospitalization. So as you can imagine, with these types of services, home health has proven to decrease ER visits, hospital stays, and readmissions. So the current status of Medicaid home health in Kansas, rates have not been adjusted for many years. Some have an effective date of 2002 and sit at 20 to 25% of the Medicare rate. For example, KanCare, the OT rate is $39 a visit, while the Medicare rate is $194.74. As you can imagine, these outdated rates do not begin to cover agency costs. In order to minimize losses, I'm hearing from agencies that they are opting to limit the number of Medicaid patients they accept or have decided not to take them at all. Declining utilization is not just anecdotal. I recently received home health claims data from KDHE. When comparing data from 2021 to 2025, there was a 15% decline in the number of home health claims. Medicaid home health utilization is declining in Kansas. But the impact of inadequate rates goes beyond declining utilization. I mentioned at the beginning of my testimony that we have 64 provider members. As of this morning, it's actually 63, and it should be 68. Since January alone, 5 member agencies have closed their doors. One I heard of just this morning was in Girard. We also have Hiawatha, Parsons, Nest City, and Concordia, and they've all lost longstanding home health agencies and are now experiencing the consequences of costs exceeding reimbursement for far too long. So my request to this committee is that you examine home health utilization. Is there true network adequacy? There's a difference between agencies that can accept Medicaid home health patients and those who actually are. The other things beyond home health, we support efforts for rate parity, as you've heard from others, across the HCBS waivers, and we also support the development of a process for regular review of KanCare rates. And thank you for your consideration. I will stand for questions at the appropriate time.
Committee questions. Senator Gossage.
Thank you so much for being here, Kristen. I would take from your testimony that it's been kind of a stagnant rate, but yet it's based upon Medicare, and Medicare rates have gone up every year. So it has been an increasing amount, correct?
Medicaid rates for home health are not dependent on Medicare rates.
It says that it's based upon 2026 Medicare rates in your testimony. Did I miss that?
When I was comparing rates?
You said, yeah, let me get to this. Maybe we can talk about this offline.
Sure.
We're running short, Mr. Chair.
Just comparing what the current rate for Medicaid was. Medicare was $194.
Yeah, go ahead.
If I may, Mr. Chair, it says, in comparison, the current year 26 national Medicare per visit payment amount for OT is $194.74. Is that the line?
No, I was thinking of where it says 20 to 20 up here, and I think it's paragraph 4. Medicaid home health reimbursement rates in Kansas have been ignored for far too long. In fact, some code rates have an effective date of 2002 and sit at 20 to 25% of the 2026 Medicare per visit rate. So what you're saying, it's not based upon that rate?
No, I was just comparing the two.
Thank you. That was clarification.
Thank you for your question.
Very good. Committee questions. So are these billed under personal care, or how do you do that? I mean.
So home health is separate from the waiver program. So it includes skilled nursing, occupational therapy, physical therapy, and home health aides. It's a medically necessary, whereas personal care is what you would typically find under the waiver programs.
Okay.
And so there's two, where KDADS manages the HCBS, KDHE is responsible for the home health side of things.
I see. Okay.
Yeah, two different programs.
Representative Ballard.
There's a clarification.
Very
Yes.
quickly.
Quickly to you. Thank you. Looking at it in terms of the rates that you're paying is preventing services because it's so low.
Correct. The amount that providers are receiving in reimbursement for their home health visits are so low that they are choosing not to take home Medicaid patients.
Thank you. Just wanted that
Yes.
clarification because that's an important fact.
Yes.
All right.
All right. Thank you.
Seeing none, thank you very much for being here. I think we're going to skip over the next guy. Oh, no, Mike, welcome to committee.
Well, thank you, Mr. Chair, and as others have said, thank you for all your service over the years, and definitely going to miss you after the end of the year happens. So as the chair said, I'm Mike Burgess with the Disability Rights Center of Kansas, and I guess the first thing I just want to cover a little bit earlier today, when Mr. Anderson was here and talking about the 4% who were on the IDD waiting list who were deceased, he actually buried the lead. Because if you take that 4% and extrapolate that across the nearly 5,000 Kansans who are on that waiting list, that's 200 people who died while waiting to receive services. So let that sink in. Our waiting list, 200 people passed away while they were waiting for the needed services. So this leads to suicides, bankruptcies, divorces, individuals who are in crisis, who are more difficult to serve and more expensive to serve for providers. So that's what we're talking about with this. And so that's kind of reiterates the point or makes the point of how we need to eliminate the wait. And so you've heard me talk about that at previous meetings, during sessions and other times, and I think that's something that we need to revisit again later as we go. So, and I know you are a favorable crew who know the benefits of these HCBS programs, that you know the business case for it. We need effective HCBS programs because they do save money, because they get outcomes. And so just a couple of observations and recommendations in that respect. And you've heard from others, I do want to reiterate, if the as submitted, that 20,000 cap on the community support waiver makes its way into policy, it's going to be a big barrier to the effectiveness of that program. And as the chair said, if we look at it more as an aggregate, that some people will be under and some people will be over, you know, this, and just to say, this isn't waiver light. It's a family and community support waiver. It's different services than the comprehensive waiver and different needs. Same target population of individuals with IDD, but very different outcomes. And if we can get this community support waiver working and we get people employed in the community and provide the transportation and help them meet their needs, some of them may be able to off-ramp into the work and working healthy programs and work their way out of this. I mean, that's kind of the upside. That's the goal for some of the people. As people's needs changed, they need the ability to immediately transition to another waiver. And this, whether it's the CSW to the comprehensive waiver or other waivers. As needs change, we shouldn't make them go through a crisis. And that's unfortunately the current plan in the current off-road is somebody can move if they accept an offer on the community support waiver and find it's not meeting their needs, they have to be in crisis and go through this process. And just because it's not meeting your needs, that doesn't necessarily necessitate a crisis. So we've got to work on that. We have work to do on that policy to make that work, and it should really go across all those HCBS waivers because we want effective. So I don't have time to really go through that, eliminate the wait, and the benefits of funded waiver slots, because we do need to do both, work on rates and work on the waiting lists. We can't do one versus the other. We have to do both and really look at how we can do this, and it is solvable. It really is solvable. So with that, Mr. Chair, I'd happily stand for questions.
Thank you, Mike. Many questions? Seeing none. And so, Mike, just so you're not aware that the $20,000 cap was in your testimony? You're not aware that it was removed?
So it is my understanding, it absolutely, that proviso is not in the budget. So starting July 1, there is no legislative mandate for a $20,000 cap in the budget. But as I read what was submitted to CMS, they list the cap and list that it was a legislatively driven, why they included that. So I think, you know, as we look at this and look at the feedback from the community, from providers, from everyone, you know, they view that as a big barrier. So I think there is an opportunity to make this work. And I think your point about, you know, looking at this at kind of an aggregate level, you know, it is going to be much lower cost than the comprehensive waiver with that service array and the needs of those individuals. But we want to make sure it works.
Originally, that was the concept, was that it would be a per person deal, and if someone used only $5,000 and someone needed $25,000. So I think that the devil's in the detail there. Yeah. So we'll have to get with KDADS and find out what's going on there. So any more questions, committee? All right.
Thank you very much,
Mike. Okay, moving right on, moving over Sean and past Tanya. No, come on, Sean. I'm just joking.
Coming right here, Mr. Chairman. Thank you for allowing me to testify once again today. I just wanted to chat just a little bit about MFP. So the Money Falls the program. It's been mentioned a couple times today. What that is, it provides some funding to transition people to less restrictive settings, sort of out of a nursing home and into back into the community. I think that that's something most of us can support, just given that usually that less restrictive setting from a state's perspective is less costly as well. But the outcomes are better. It's better for that person to get them into the setting where they have more freedoms. That program, the MFP program itself, is coming to an end in Kansas. KDADS is winding that down right now, and it's just worth kind of keeping an eye on. They have a transition plan program available, but from the providers that I work with, some folks are sort of experiencing some difficulties. I'm just not quite sure if it's as robust as it needs to be, and I have a hard time kind of trying to figure out where the catches are in sort of trying to move folks out. Again, it's to kind of cover that upfront cost with moving people out. So you would need to find somebody a home or whatever else, and the supports that they need in a setting that's accessible to them, whether they be, you know, somebody with a brain injury coming out of a nursing home, or aging folks or whatever the situation is. And so it's just something I think that, in this transition process, it'd be a good idea for this committee to keep an eye on. And with that, I'll stand for questions at the appropriate time. Thank you, Mr. Chairman.
Any questions? Elizabeth, could you flag that so we can get some more details from KDADS on how that's going to end? And didn't the secretary say that the federal funding was ending for that program? Okay.
So the program on the federal level is approved through, I want to say like September of 27, but ours is ending sooner than that. I don't know if it is for sure slated to end on that 27, but it is that long. And I think the state of Wisconsin's was just reauthorized. So just more information.
We'll find out. Yes, Representative Bueller.
Thank you, Mr. Chair, and thank you, Sean. Hey, I'm reading through your testimony, and the comment, and I know it doesn't kind of follow with what I think the theme is, but it talks about the personal needs allowance that we're only, that state of Kansas, $62. Is there a specific request in here for that? Why? I guess I'm trying to figure out why that's included in your written testimony.
I got to tell you, I've slept since then.
Well, it threw me. I'm when this is okay. I know it was an issue in health the last 2 years, but it threw me at being in your written testimony.
It had been, and I don't know if I'm just lacking focus today or what, but I'm struggling to remember what the thought process. So I've got that included, to be honest with you.
It got me struggling too. So
all right. Yeah, I'll get back with you.
All right. Thank you, Mr.
Thank you.
I think they asked for $10.72, and it was what, $1.2 million or something like that, if I remember right, something like that. So that was kind of why it went by the wayside this year, if I remember correctly, but I won't swear to that either. Okay, no further questions. Thank you very much. Sir. The fastest speaker I know, so this gal can talk.
I was going to say,
Welcome,
I think I can keep it under. Thank you for not skipping over me, Mr. Chairman. My name is Tanya Dorfbruner. I'm the Executive Director at Oral Health Kansas, and we are the state's oral health consumer advocacy organization. I want to start by just thanking you for the rate increase you provided for Medicaid dental services this year. It's the one in a series of investments you've made over the last few years. It's making a difference. There was an editorial today in Kansas Reflector that said we need policy, financing, and political will to build a healthcare system that works for Kansans. And I think the steady investments you've been making are exactly that. I want to talk about the impact of the investments. As you know, about a year ago, we launched a Medicaid dental facilitator program. This is a program to provide supports for dental offices to help them be Medicaid providers. Pairing this with the rate increase is what is working. One long time Medicaid provider told me earlier this year that dentists are starting to notice the difference in the program, and that's a big deal. I've never heard dentists say that before until about February of this year. That's a big deal. From 2021, this is an important thing to note, and from 2021 to 24, there was a 20% decrease in the Medicaid provider network in the state. But last year, after the rate increase, we saw an 8% increase. So it's starting to work. We just got data from Q1 of this year, so since January, we're seeing the numbers continue to trend correctly. We've added just another 2, but we added more since January of this year. So it's clear that raising the rates to a level at which dental offices can maintain their status as providers or consider joining is a vital step to improving that sustainable Medicaid provider network. It's also clear that the work we're at Oral Health Kansas and our partners are doing to support providers is working, and I do want to shout out and say the partnerships we have with United, Sunflower, and now with Healthy Blue is a big part of the success. I want to talk about the next steps just briefly. We are partnering with the Kansas Dental Association to do a survey of providers about how best to allocate the funding so that it goes to the codes that are most impactful. That survey is actually being released today, and we, the Kansas Dental Association and Community Care Network, are all going to be distributing that. We'll share the results with KDHE as soon as those results are available, and they'll make the final determination about how those rates will be increased starting July 1st. I am very grateful to KDHE for valuing that stakeholder input. They actually came to us and said, are you going to do that survey again this year? So I'm grateful to them. Finally, I want to make a personal note to you all. I want to let you know that I am going to be leaving Oral Health Kansas after the last 17 years there. I'm actually transitioning to serve as Executive Director of our national organization, the American Network of Oral Health Coalitions. It's just been my honor to work with you all for so many years. To improve the dental system, we've done a lot of really great work together. I'm going to work to make sure my successor, who is not yet named, but whoever that is ready to pick up the reins and continue this great work. And I just thank you for your investment, and I thank you for your partnership. I'm also not going anywhere. I'm staying right here in Topeka, so I'm not going anywhere. But it's been my honor to work with you for all these years, so thank you.
Representative Ballard.
Well, that's good news. That's bad news, either way we look at it. But I will speak for myself, not my whole committee, and say it has been an absolute pleasure. I've learned a lot about oral health, and I'm so glad we were able to help in any way we could. So thank you.
Thank you and congratulations. Representative Reed.
I can understand why the national office snatched you away. You're so effective and you're such a strong advocate for oral health. And I just thank you for all of the work that you've done and all of our partnerships together. You're awesome. So, and you'll be awesome again.
Thank you. I will say I've been so impressed with everybody in this room at your ability to, in a committee with your peers, explain everything I've said for all these years. You don't need me. You can explain all this stuff so well. So bravo to you for learning all this stuff so well. Thank you.
Any further questions? Seeing none. Is this your last time before us?
We'll see.
Okay. Well,
it could be, but we'll see.
Okay, very good. All right, next we have Lola. Oh, I know you. How you
Hello
doing
there.
Hello, how are you?
Good. How are you?
Oh, doing good.
Good afternoon, Chair and members of the committee. I am short, I know that. My name is Lola Cornell, and I have Down syndrome. I am the advocacy coordinator for the Kansas Council on Developmental Disabilities, and I'm a college student currently. Thank you for the opportunity to testify today. On behalf of KCDD, thank you for your continued commitment and support to Kansans with disabilities. At the same time, the work is not finished, of course. Too many Kansans with intellectual and developmental disabilities, or IDD, are still waiting for years for the services they need. The waitlist is not just a number, as many of you know. It represents people trying to live safely, work, and participate in their communities without adequate support. We are encouraged by the development of the new Community Supports Waiver, or CSW. It has real potential and shows promise to expand access, provide earlier support, and offer greater flexibility through a more person-centered, community-based approach. But how it is implemented matters the most. I currently live with my parents, who support me with daily living and transportation, and I am on the IDD waiver wait list. Most of my needs are met today, but that may not always be the case. As my parents age, they will not be able to provide the same level of support. I also want to live more independently in the future, which will require additional services. I could benefit from the Community Supports Waiver now and from the Comprehensive Waiver later. However, I am concerned that accepting a spot on the CSW could mean losing my place on the IDD waiver wait list. That puts people like me in an impossible position. Accept limited support now or wait to preserve access to the services we will eventually need. We should not have to choose. One thing is for certain, the CSW, it should be a bridge, not a trade-off or a permanent exit from the comprehensive supports many of us will rely on. Without that protection, the risk is too high. My colleague Whit Downing, who will be testifying after me, will be talking a lot more about the waiver waitlist and the workforce. Kansas is at an important moment. We have the opportunity to build a system that supports people earlier, responds to needs in real time, and allows individuals with disabilities to live full and independent lives. To do that, We must ensure new programs like the CSW strengthens the system and not creates new barriers. So today, I ask you to do 3 things. Ensure that, that accepting a CSW slot does not affect a person's place on the IDD waiver waitlist. Continue expanding waiver capacity so fewer Kansans are left waiting, and invest in the direct support workforce that makes all of this possible. This is about people like me and what our futures looks like in Kansas. We want to live independently, follow our vocations, and know that when we need support, it will be there. Thank you for your leadership and for listening to self-advocates like me and Wit. I'll stand for questions at the appropriate time. Don't be scared of me. Thank you.
Very good, Lola. Thank you so much. Senator Gossage.
Hey there, and I'm not scared of you at all, Lola.
That's good.
Thank you for being here. You know, you and I know each other very well, and it's so hard for me not to say honey when I talk to you. First of all, you just brought up something I never thought about. We've been working so hard in this community support waiver to get it done. That's just like, wait a second, lose your spot on the waiting list for the services that are more substantial than are available on community support waiver. Never considered that. So I thank you so much for bringing that up, and we will definitely look into that. Thank you very much for being here.
Thank you.
Yeah, and I think in our original conversation, that was not the case. The case was that they could try the community support waiver, and if it didn't work out for them, they could go back. Somehow that's changed, and we need to find out what the deal is on that. I find that a lot of folks are going to be just like her. They're not going to take the community support waiver because they don't want to jeopardize the other one. So we need to look into that. Thank you so much for being here, young lady.
You're welcome. You're welcome.
All right, another no stranger, Whit. Come on up. Good to see you again.
Hello, Chair and members of the committee. My name is Whit Downing, and I work as Vice President of Policy and Programming for the Kansas Council on Developmental Disabilities. But today I'm not here as a professional. I'm here as someone who spent 8 years on the IDD waiver waitlist in Kansas. And I've talked in front of this committee on numerous occasions about my time on the waitlist. But today, I really want to just take some time to paint a clear picture on what my time on the waitlist was like. Because this year, 0 spots were funded, and our 4,000 person cap is exceeded, and that makes me really sad. When people hear waitlist, it sounds like waiting, like something temporary, like something manageable. But for me, it wasn't just waiting, it was surviving. I didn't get on the waitlist until I was 18 years old, and that's not because I didn't need help sooner, but it's because my family didn't even know the system existed. My mom had her own struggles and did the best she could, but she didn't have the support or tools to support me. My dad wasn't in my life at the time. He is now. He's out of prison as of January 1st and sober. So that's another story. So when I turned 18, I didn't step into adulthood with services. I stepped into it alone. At the same time, I was living with autism and severe mental illness. And without support, my life became a cycle of crisis while living in poverty because of asset and income limitations that were signed into law in the late 80s. During those 8 years of me on the IDD waiver waitlist, I was hospitalized in psychiatric facilities over 15 times. Law enforcement was called on me over and over again, and that's not because I was breaking the law, but because I was in crisis and there was no one else to call. I wasn't getting the services that I actually needed. Instead, I was cycling through systems that were never meant to support someone like me. Hospitals, crisis centers, police cars, and every time I left alive, but with more trauma than I had before. I spent my teenage years being abused, and then I spent my 20s unsupported. I'm 30 years old now, and I finally feel like I'm starting to live the life that I've always wanted. I have purpose, I have a career, and I'm contributing to something that's bigger than myself, but I cannot help but wonder, what would my life have looked like if I had gotten services when I needed them? Because even when, and then I want to talk about something else. Even when someone gets offered a waiver slot, there's this invisible wait list. A wait list for staff, for direct support workers, for job coaches, for personal care attendants. And so even when the system says you're in, people are still waiting, still without support, and still in limbo. And we cannot talk about reducing the wait list without also talking about the workforce that makes these services real. But we can't let that reality distract us from the urgency of the front-end wait list, because right now there are over 4,000 Kansans just waiting to get in, still living what I lived. I have friends on the IDD waiver wait list who are living lives like I lived, and it breaks my heart, and that's why I advocate so strongly for the people on the IDD waiver wait list, because it's not just a number. It's thousands of people living without support. And I work in policy, but this is not just policy. This is people's lives. When we delay services, we don't remove the need. We're just pushing people into hospitals, law enforcement, into crisis. So I'm asking you, please take this seriously. Please act urgently. Please think of these 4,000 people as your kids, as your grandkids, Representative Bueller, Carpenter, Ballard, Peck, Sutton, Rees, Senator Petty, Representative Bryce, and Senator Erickson. Please invest in reducing the wait list and invest in the workforce that makes those services possible. People shouldn't have to survive what I survived just to finally get the support that they needed all along. And I'm here today for myself, but I'm carrying the weight of thousands of Kansans who are still waiting. And they deserve more than survival. They deserve a chance to live the life they deserve, their best life.
Thank you, Whit. Good job. Good job. Questions? Senator Gossage.
Hey.
Hi.
We know each other from a long time, too.
Yeah.
Thank you so much. You did a fabulous job today.
Thank you.
And I hope when we get this approved by CMS and it starts in October that you can come and we'll get our picture taken together.
Absolutely.
Office. Thank you so much for being here.
Thank you.
Representative Ballard.
Thank you very much. Boy, that was from the heart.
Thank you.
And I thank you so much. I remember both of you, Lola, from Social Services budget, and I'm sure Representative Bueller does as well, and Representative Carter. Let me say to you, you were good then. You were extraordinary today.
Thank you.
Thank you very much.
Thank you.
Very good. Committee, further questions? Seeing none, thank you, Whit. Okay, committee, I'll bring your attention to written only all the way down through here. And so we're 50 minutes. The chair is not doing a very good job of running a committee on time. But we are ready now for committee CCBHC Health Clinics. Drew Atkins. Drew has gotten off of the list until now, and now he's up. So, all right, Drew.
Can you hear me? Good afternoon. Happy to be here. Thank you for having me. I do have a slide deck for you all. I think you all should have that as well. There are 30 slides or 31. So I'll try to go through these as quickly as I can. There's just a lot of information to cover, and we're happy to cover it. Drew Adkins, I work over at KDAS in the Behavioral Health Commission as the commissioner. So CCBHC is one of our programs. And if we can go to the next slide, please. There we go. Thank you. So there's a lot of stuff that we're going to discuss today. All of it pertains back to CCBHC. It just may branch out into some of the things that have already been talked about today, like the CCBHC Transformation Project that was brought up earlier with the secretary. We call that. That's funded through the Balmer Group. It's a philanthropic award, but I'll try to make sure that all those are pieced together. We're going to talk about have a overview for CCBHC and also the demonstration program that we're in specifically, which again is really the same as CCBHC, just with some other requirements from the federal government. Talk a little bit about the Sustainability Advisory Group and some information around there, and then talk about some positive outcomes and some data. We can go to the next slide. So just to level set, and as a refresher, I know a lot of you on this committee have probably heard a variation or iteration of this presentation before, but just to level set as to where we're at in Kansas. Currently, there are 25 CCBHCs in Kansas that serve all counties. We did used to have 26, so when we started the program back May 1st of 2022, onboarding our first 6 CCBHCs per the legislation that you all passed. We had 26, but we have had a consolidation here actually in Topeka between Vallejo Behavioral Health Care, Family Service and Guidance Center. They have merged now and they have turned into Astra Mental Health. So that's why you see that number go down there. Just as a reminder, being and I keep saying CCBHC, Certified Community Behavioral Health Clinic, does not mean that they are also a CMHC connected. The Community Mental Health Center is a licensure. CCBHC is a certification. So I think that's just important to designate for the group here. If we can go to the next slide. All right, so one of the questions that we get asked a lot throughout this process is, what does it take to meet CCBHC criteria? So as you'll see on the slide, to operate as a CCBHC, there are 6 categories that must be met. You have staffing, availability and accessibility of services, excuse me, care coordination, scope of services, quality reporting, and then some requirements around organizational authority and governance. Under access requirements and under the Protecting Access to Medicare Act that actually established, I think it's section 233 or 223 that established the CCBHC program back maybe in 2014, 2015. CCBHCs are required to provide services to any individual seeking care for a mental health or substance use condition. Services must be provided regardless of place of residence, ability to pay, or age. This requirement applies to a wide range of populations, including those with serious mental illness or SMI, individuals with substance use disorders or SUD. Mostly we see those as co-occurring with a mental health condition or a behavioral health condition. Children and adolescents with serious emotional disturbance or SED. Individuals that are experiencing a mental health or substance use related crisis. And the goal here is to ensure open access and no wrong door for the individuals seeking behavioral health services. If we can go to the next slide, please. So I talked about the 6 requirements on the previous slide. There are 9 core services that are required for CCBHCs to deliver. You'll have a chart there. I won't go through all of those, but some of the things that I wanted to point out is this program requirement outlines all the 9 services that must be provided by the CCBHCs. Although services may be delivered directly by the CCBHC or through what's called a DCO, or a designated collaborating organization. Those are enhanced, kind of how I categorize those are enhanced formal agreements and partnerships between the CCBHC and an entity to provide care on behalf of the CCBHC. They do have some enhanced requirements for like data reporting, organizational requirements, and also payment mechanism between the 2 entities. All services must be delivered in a way that reflects person-centered care and family-centered care, and the focus is on ensuring services are coordinated, accessible, and responsive to the needs of the individuals and their families. We can go to the next slide, please. So in Kansas, I know that we've talked a lot about evidence-based practices before. I know some of that work has come out of things like the Mental Health Modernization Reform Committee as well. We do require evidence-based practices for CCBHCs to become certified. So you'll see those listed here. We have ACT, Assertive Community Treatment, we have supported employment, and we really encourage and prefer for our centers to enact the Individual Placement and Supports Model, or the IPS model, which is an evidence-based program. We also have medication-assisted treatment, or MAT, and then cognitive behavioral therapy, which is CBT. Evidence-based thinking reflects an approach that attempts to ensure that treatment works. Chosen interventions utilize research that links the specific intervention with a desired outcome. In Kansas, our quality assurance team, we are a small but mighty team. We have about 4 individuals on that team that serve all of the clinics. They are on the road constantly, between 25 providers throughout the year. But they are looking for these evidence-based approaches in the work that the CCBHCs are doing, in addition to the required CCBHC core services that I just went over. If we can go to the next slide, please. Excuse me. So to get to the payment methodology and the reimbursement for the CCBHCs, all states, whenever you go through this process, have to pick a specific methodology. Kansas selected to do what's called a PPS-1. There is also, and so Prospective Payment System 1. There's also a methodology called PPS-2. The difference there is that instead of a daily reimbursement, there is a monthly reimbursement for allowable encounters that happen at the clinics. There are a few states that do that. A lot of the states that I've talked to are following in the same footsteps as Kansas, using the daily PPS-1 reimbursement system. There's also a couple more that are iterations that have carve-out options, and I can talk more about that if the committee would like. So the PPS is the method of reimbursement in which Medicaid payment is based on a predetermined fixed amount. This represents the average cost per encounter for all clients receiving CCBHC services from a particular clinic. I'm sorry. So you'll see at the bottom there, the calculation is the annual allowable costs that are divided by the annual daily visits, which equals the PPS rate. So this, just a couple of notes, some things that I've already mentioned, but this results in a standardized daily rate if there is an allowable service that is rendered to an individual that would trigger a reimbursement, and we call that triggering payment. And then we also have codes that are specific to a list that is published and is in our KMAP, but those would be triggerable codes. There are also codes that are a part of our services, or services that are not triggerable themselves. And this, one of the things to distinguish is that this only applies to CCBHC covered services. This does not apply to non-covered services, which I just mentioned, but it also, CCBHC is a Medicaid program, so if an individual that does not have Medicaid, but maybe uninsured, underinsured, covered by commercial insurance, TRICARE, et cetera, this would not trigger a reimbursement for that individual, if that makes sense. Okay, I think we can move to the next slide. So to talk a little bit about care coordination, we've listed, we have a list here. In the state of Kansas, we do require, per our certification and what we're looking at, care coordination agreements, either MOUs, MOAs, some sort of agreement that the providers must have in place with entities that they work with, and that other services need to be provided to the consumer that is crossing the threshold of a CCBHC. So I won't list all of those, but just a couple of notes about that is care coordination refers to activities conducted by CCBHCs to organize and manage care for each individual receiving services as required by PMO, which I mentioned earlier. This includes coordination of both behavioral health care and physical health care. Care may be delivered directly by the CCBHC or through referrals or partnerships with external providers and facilities. It's also important to note, that care coordination is considered an activity but not a billable service. So I talked about the service codes list earlier. You would not see care coordination as a billable service for a reimbursement, if that makes sense. The goal is to ensure individuals receive comprehensive, connected, and continuous care across systems. Some of the activities that you would see with this, the CCBHCs establish care coordination activities within their organization and with partners to support clear and timely communication, deliberate care, coordination of care, and seamless transitions across providers and settings. We can go to the next slide, please. Okay, I think we're going to go into the demonstration. Thank you. Update. So you'll see the timetable there, and I believe we've reported out on this before at the Bob Bethell Committee, but just to refresh those that have not been a part of that or are not aware, in March of 2023, we were awarded, Kansas KDOTS was awarded a one-year SAMHSA, Substance Abuse and Mental Health Services Administration, CCBHC planning grant. What that did for us is that gave us the ability to start gearing up for being a part of the demonstration. And I actually probably should explain, there are a few different ways for a state to become a CCBHC state or a program state. One is to do exactly what the state of Kansas did, which is to pass legislation directing the agencies to create a change or an addition to the Medicaid state plan, which would be through an amendment. Another way is through a Medicaid waiver, or the third way is to have gained an award and access into the CCBHC demonstration. And so we started out in the Medicaid state plan. We made an amendment there after legislation had passed. We created policies, procedures, and made changes and mechanisms for payment, created criteria, those types of things. And about 6 or 7 months after legislation was passed in the summer of 2021, we started in May 1st of 2022. A couple of years after that, we were approached to look at applying for the demonstration. So you'll see in 2023, we were heavily considering that with a SAMHSA planning grant. In 2024, we had the planning grant end, and then also in March 2024, we submitted our demonstration application. And then in July of 2024, we were accepted into the demonstration program. I think we were among 9 additional states. We started our demonstration program in January of 2025, so that is still going on. We're in demonstration year 2, and in 2026, we will submit the first set of quality measures to CMS to show, kind of demonstrate where we're at. So those are quality measures that I can talk about here in just a little bit as well. All right, if we can go to the next slide, please. So just a couple of benefits of why we were considering at the time applying for demonstration and ultimately did it. We do have an increase of the FMAP, the Federal Medical Assistance Percentage, and that equates, I believe, to about a 12% savings on what we would pay if we weren't in the demonstration versus what we're paying now in the demonstration. That will also run, I didn't mention this, but that will run until January 1st of 2029. So roughly another 2.5 years or so that we'll be in that. We also get 15 hours of personalized CCBHC technical assistance from the National Council. We've gotten way more than that through the Balmer Grant. I'll talk a little bit more about that, but that's been helpful. And we have a little bit more of a direct line, I would say, to CMS and SAMHSA to get answers to questions that we have or problem solve, which we do find usually helpful. One thing just to talk about, I won't go through all of my notes here, but one of the things to talk about is just data utilization and quality measures as to what's required for the demonstration. So a major aspect of this is the emphasis on data collection and analysis. So we will utilize standardized forms to gather data that will help measure the effectiveness of implementing the CCBHC model. The program requires a collection of 5 required CCBHC quality measures. Those are clinic-led, and then we have 12 state quality measures that we are working on and introducing into our CCBHC data warehouse that I can talk about here in a little bit as well. But those will be instrumental in understanding service delivery and outcomes. All right, I think we can go to the next slide, please. Thank you. So just to talk a little bit about where we're going, I have slides on the CCBHCT project. I won't talk about that. We're working right now on a few different things. One is to have a CCBHC dashboard. The idea here, God willing, that we can do this with our IT as well, is to have something that would actually be public-facing, to have a domain to look at areas within the state, across the state, but also look at areas where we have CCBHCs, the services that are being provided, individuals being served. So that's something we're looking on as well as a KPI, some sort of indicator for that in the program. One of the things that we have done is increased our quality improvement. I talked a little bit about that earlier. When we started the program, we didn't have the ability, because of the lack of staff, to be able to be out on the road reviewing the providers each and every day, even once a month. Essentially, we would go out for recertification or certification reviews as we were bringing the CCBHCs on board throughout those 3 years. Now, I can say, even with 4 staff, we've actually got a schedule now that we can be in the CCBHCs once a month. We're actually considering doing this in partnership with the managed care organizations as they do some of their audits or some of the things that they're seeing, so we can have a kind of trifecta approach there. So I think that we're hoping, we just started that last month, I believe, or the month before. So we're hoping that we can gain some more insights on some of the pain points of the program and kind of course correct or autocorrect some of those things that we're seeing, or at least learn more information about that. All right, I think we can go to the next slide. All right, so just to talk a little bit about the Balmer Group, full disclosure also, I think we have somebody online from the National Council who's administering the program. If there's a question that I don't know the answer to, as far as, in general, I think they might be able to help, so I might pivot to them if I need to. So I won't go through all of this, but I do want to just talk about, we are one of 3 states that were accepted into this program. We are very, very thankful for that. It was kind of born out of just general interest from our team at a National Association meeting last year, and I think that we kind of lucked into the program, and now I think that we are really hitting our stride with it, and we're excited to be there and helping both Illinois and Michigan too. The Transformation Program, or the Transformation Initiative, is a 3-year national project designed to help states strengthen and expand their CCBHCs. The effort is led by the National Council for Mental Wellbeing with support from the Balmer Group, and also in partnership with the National Association of State Mental Health Program Directors, as well as McKinsey & Company. I think we can go to the next slide, please. I think we'll talk. So this initiative, just to talk a little bit about direct technical assistant beneficiaries, we have the state, obviously, so that includes KDHE and KDADS as joint venture in this program. But we also have the clinics that are receiving technical assistance. We also have some other individuals as far as stakeholders that are involved, the community mental health centers, as well as some of the clinics there. But we also have individuals with lived experience that are part of our group, kind of our steering committee as well, but also giving us insight into, hey, how are the services working? What could we improve on there? Kind of tackle that from all angles. Some of the indirect TA beneficiaries could be other state agencies and non-clinical care environments. We're looking at some of the downstream impacts from that and benefits from the expanded partnerships and increased access to CCBHCs. This initiative will help Kansas strengthen the behavioral health systems by expanding access, growing the workforce, and improving service quality throughout the CCBHC model. CCBHCs are expected to deliver rapid access to care, coordinate with community partners, use data to drive improvement, and offer a broad range of services rather than traditional clinics. And this project provides hands-on support to address barriers in implementing and sustaining the model. And I'll talk a little bit about this on the next slide, but I know that there were some questions about when this came out and the total award. So Kansas right now, it's estimated that we will see an indirect impact of in-kind or in technical assistance from these 3 organizations for our program, totaling around 10 to 20 million of Taylor in-kind support over the next 3 years that the grant has, that we will have the grant. It essentially will end in the summer of 2028. We will also have 2 full-time staff extenders or fellows that are placed in Kansas to assist with project management, policy development, and implementation. very helpful. They'll work with the clinics, they'll work with the state on some of our initiatives. We'll also have some expert coaching and training for both our state executives, but our state staff, and then also the clinic staff as well for the initiatives that we, and strategies that we publish for this. One of the really cool things is something that's called the Workforce Accelerator Program. This is something that actually is money going straight into workforce from a philanthropic grant, which I think is very neat. So the Workforce Investment Funds, roughly $2 million per year. How that works is that we have sites that are a part of this program. Right now, those are the CCBHCs that we have, might be expanded to non-CCBHCs after this. But they have a certain amount of slots for individuals to get stipends for the program. And the purpose of the stipend is to help individuals that are currently working at the clinics, or at least have an offer letter to increase their licensure, or at least obtain licensure to create more of a workforce pipeline for individuals that are licensed in the state of Kansas. I believe that we have 600 slots for this, but I think that that number could go up if we demonstrate that we're able to have expenditures that would go towards this. And those stipends, I believe, are around $8,500. And I can double check on that, but I believe each stipend is worth about that for the licensure, pays for the fees and other things. One thing that we are going to try to look at, we haven't gotten approval yet, is to see if that could be used as a recruitment technique, that stipend would be available. And so we haven't heard back on that, but I'm hoping if we could do that, that would help with recruitment for, at least for the CCBHCs, unless we expand the program. All right, I think we can go to the next slide. And actually, I think I just explained all of this before getting to the slides, so my apologies on that. If we can go to the next one, please. So as part of the project, we actually put together, when we started this back in October, a 3-year roadmap. These are the things that we want to focus on as a state. This is not gospel. This is a living document. So there are things that can change, but for the most part, we feel like this is something that we really want to work towards. This group now includes, we do have, as far as the state team goes, we do have our Medicaid folks involved. We have KDOT staff involved. We have our MCO behavioral health directors involved in this as well, and our leadership too, and then some of our stakeholders. And so we've gotten to this point. I'm not going to go through each and every one of those initiatives, but I did want to show that because I do think it's important to see kind of where we're going, what we want to focus on. There's things on here talking about quality metrics and trying to make sure that we have a threshold for where we want our quality reviews to be, expanding the reach of telehealth solutions, expanding our crisis continuum, evaluating the wait list, if we have wait lists at centers and what that means and how we can eradicate that, all the way through, you know, some things that we'd like to do as far as see what is our return on investment and assessing that return on investment, and also having a cross-system impact study. Two of the things that McKinsey is on board for in their work is they're actually studying all 3 states to do a value analysis on the states to see what has been the impact of implementing the CCBHC model. And I don't know if you all will remember this. It's something that's on our website. Back in 2024, we did something very similar to this that showed about that since the inception of CCBHC, at that point, 2 years, we had about a 75% increase in access to services. So they're going to try to build on that report with the data that we have, but they're also going to look at a cross-system impact study just to show what has the cross-system impact been on things like the justice involvement or the corrections and jail settings, hospital settings, as well as inpatient settings or education. So we're hoping to have that this summer, early fall, and we're happy to present that to the committee when we do have it. I think we can move to the next slide. All right, I think we had a request from the committee to talk about the CCBHC Sustainability Advisory Group. And I think there's been a little bit of conversation on this today already, so I won't belabor the point, but just to talk a little bit about the purpose in the proviso was review and discuss the codes that trigger a prospective payment system reimbursement and allowable costs in the cost report, identify and discuss cost offsets of CCBHCs and outcomes achieved from the PPS system, and then we'll have a report due back to the legislature next year in June. We can go to the next slide. Excuse me. So here's a list of the membership. I won't list this out. You all are maybe already familiar with this as it came out of the legislature. Where kind of we're at in this process right now is just building this up. I think there are different appointments that have to be made. So looking into the new fiscal year to look how that's going to come together. I do think that we're excited at the agency to be able to look at this. I think I referenced a couple of different reports earlier, particularly the cross-system impact report, and some of the data that we have found from KDHE that we're trying to build on is that we have seen a reduction in inpatient and hospitalization as far as acute care over the time span of 2023 to 2025. And one of the reasons I highlight that is that I think all of these pieces between the Sustainability Advisory Group, the Balmer work that we're doing, and CCBHC in general can come together to get us really good information at our fingertips that might not have come for a little while longer if we didn't have this opportunity with this philanthropic grant. We can go to the next page, please. All right. Apologies. So just want to talk a little bit about positive outcomes from the CCBHC model. What's on this slide is the criteria that we have the ability to collect data from the CCBHCs, driving continuous improvement from across the behavioral services, supports transparency and oversight, has accountability for the outcomes, and improves the quality of care. Some of that data we have today here for you. But I just wanted to show, kind of going back to the criteria as part of CCBHC 101. If you haven't read the criteria, it's very long. There's some interesting stuff in there, but this is some of the stuff we wanted to pull out to make sure that you all were aware of. We can go to the next slide. All right, so just have some notes on this. So as I mentioned before, we do have a enterprise data warehouse project that's ongoing. This is a NetSmart solution that we have created. We actually copied, kind of stole the idea from Missouri, as they have been a little bit earlier than us in the Medicaid demonstration for CCBHC program. But our Association for Community Mental Health Centers have partnered and contracted with NetSmart to get this data specifically from all of the electronic health records and EMRs of the CCBHCs. We do have that mixed in with Medicaid data and some other data that we have to report out. And if you'll mention, not too long ago, we had about 17 quality measures that we have to submit to the feds to be a part of the demonstration. We're going to be getting that data from this data warehouse. So that's the relevance of why I wanted to make sure that we reported out on this. Just on CCBHC, and I know these are small, so I apologize, but we can get some notes on this too if it's easier for the committee. But CCBHC utilization and access in 2025, CCBHC served 78,000 unique individuals with at least one billable service. This represents an increase of about 6% over 2024. And a 33% increase from 2023. Not surprising, just from where we're at in implementing the model. I'm not going to say in our infancy, but we're definitely a toddler in the sense of other states that we compare to. If you look at states like Oklahoma, Missouri, they're a few years ahead of us when we have tried to look to them for some of the things that we have wanted to do. So access and timeliness, just a few more data points. Access and timeliness, a core goal of the CCBHC model is improving timely access to care, including both routine and crisis services. In 2025, clients waited an average of 4 days for an initial evaluation, about 5 days to receive a clinical service after first contact. For crisis response, average response time was 1 hour for in-person. And more recently, from July to February of fiscal year 26, so this past year, response time has improved for crisis services to approximately 37 minutes. Some of our outcomes and improvement among clients who completed follow-up assessments for the depression screening, that's one of the measures that we have. 52.8% showed overall improvement. Of those, roughly 52% showed significant improvement, defined as a decrease in depression scores by more than 4 points. And also, regarding employment and education, I spoke about the IPS model before. CCBHCs provide IPS services focused on employment and education for individuals with serious mental illness. The model emphasizes individualized support, ongoing assistance before, during, and after placement. Across 2024 and 2025, nearly 45% of individuals receiving IPS services secured employment or educational placement. The remaining individuals may still be actively receiving services or were already employed and receiving ongoing support to maintain success. All right, if we can go to the next slide. I think we just have some additional data. I won't go through these line by line, but some of the things I talked about, increase in services, increase in number of clients served, those will be here. As you can see, I think this one starts out for 2025 there on the slide 26. And the client count is based on clients who received at least one HCPCS code, Medicaid billable code, or CPT code over intervention over the past 2 years. Okay, if we can go to the next slide. This just talks a little bit about the services that were provided, and I mentioned this before. We had about a 7.9% increase from 2024 to 2025 on services provided. And if you go to the next slide, we have a breakdown per the HCPCS or CPT codes. So these are the codes that I mentioned before that would be billed for individuals that have an encounter at the CCBHC. Just a little bit more elaboration there. The codes listed here, H0036 is community psychiatric support and treatment. We also have T1017, which is targeted case management, H2017, which is psychosocial rehabilitation individual. Those represent community-based rehabilitation services. Primary goal of these services is to support individuals in remaining in their communities and prevent the need for higher levels of care, such as hospitalization or residential treatment. If we go to the next slide, please. So these slides, I think we did really try to get these a little bit more blown up, so I apologize. We can provide something and follow up to the committee if you need. I know they're small, but these slides actually represent just the client reach, and this is actually a snapshot into the data warehouse. This is what we would be looking at as far as data management and looking at the trends. So we just wanted you all to see the snapshots, that there's visuals and data points that are being captured there. We have a breakdown, I believe it's on slide 29 and 30, of where people reside, their ethnicity, and their client count. And I think we also break this down by age, sex, race, and employment status. These are just a few of the demographics that the data warehouse can capture when it's fully integrated into all of our 25 CCBHCs. And I think that's actually all I have, Mr. Chair, members of the committee. I'm happy to stand for questions at the appropriate time.
Good. Senator Erickson first.
Thank you, Mr. Chair, and I do have several. I'll go quickly. In a previous meeting, it was discovered that CCBHCs were not providing services for the IDD community.
Mm-hmm.
Is there an update on that? I have made a couple of inquiries and just haven't heard anything lately.
Yeah, it's, thank you for the question, Mr. Chair and Senator. That's definitely something that we're trying to look into. We're trying to also make sure, just as far as not other populations, but other programs, that we're cross-hatching that with the SED waiver community, because they have their own set of specific services too that are required. We don't want to jeopardize the waiver availability for those individuals. So it's something that we're looking into, particularly around crisis services, to make sure that If it's something where the state needs to look into as far as like training or applicability of the workforce that would need to be there at the clinics, that we can try to support that or provide that technical assistance. But it is something that we're trying to also do in our quality reviews when we're on site with the clinics as well. So I know that's not 100% an answer. It's just something we've been made aware of more increasingly and more frequently. And so we're trying to make sure we're getting ahead of that.
Mr. Chair, will you tout that you serve all populations regardless of ability and so on? Do we have a timeline as to when you will have a definitive answer as to how what you guys do fit in with the crisis management, et cetera?
Yeah, thank you, Mr. Chair, Senator, thank you for the question. So if you look at the criteria, primarily CCBHCs, you know, they're obviously not supposed to turn anyone away for any reason, essentially. What I don't think that comports to is that they're going to have IDD-specific services unless they're maybe dually diagnosed with a mental health or behavioral health diagnosis. That doesn't mean that if Drew was to walk into a CCBHC, they couldn't get at least some sort of coordinated care with an individual like a CDDO or something else. And so that's what we're trying to make sure of, is that when somebody walks into the CCBHC, they're not being turned away. As far as timeline goes, I would say that we could have definitely a report back to you all by the next time that we meet. I'm happy to do that. We're just digging our teeth into it right now.
Okay, thank you. Now, as far as your outcomes, I appreciate the information, and you qualified that by saying, you know, we have a lot of information on access and timeliness. So you're serving more people quickly. Where is the data that shows the effectiveness of that?
Yeah. I think that we are happy to pull that together. I think it's going to come, I'm sorry, Mr. Chair, Senator, thank you for the question. I think that it's going to come from a myriad of sources. Certainly, I think that we talked a little bit about there that the services that are rendered, when you talk about depression remission and we talk about are the services actually doing what they're supposed to do, if somebody's actually going down in their depression remission, that's an indicator that the services are working. That's definitely one marker. The other thing that I would say is point to things that the committee likes to know, usually quarterly, which is a PRTF wait list. I think that's been up to about 150 since I've been here the last 5 years, and we have that down to maybe 24, 23, 24. So although not a direct correlation, definitely a correlation to increased outpatient behavioral health services. Excuse me. The other data that I spoke about earlier is relatively recent data that we have gotten, and I think that we do need to get with the MCOs to check on methodologies, but we're pretty certain when we look at Medicaid claims data that individuals in 2023 that were showing up to the inpatient level of care, that level of acuity, so a private psych hospital, nursing facility, et cetera, state hospital, and a hospital admission as far as acute critical hospitals, those are going down. I believe in the inpatient realm, we're seeing a 42% reduction and then a 55% reduction in hospital care. And right now, what we're trying to do is equate that to pre-CCBHC when we had CMHCs to where we're at now. And I think that we could have that prepared for you all by the next time that we meet.
That would be helpful. A couple of quick things. I did ask the MCOs about that, and they said they're not seeing that because they're not seeing reduction in acuity of care. So it'd be interesting for you and them to get together and find that out. But as far as the depression statistics, so I was curious because not being a practitioner, I'm like 53% without knowing any different sounds really good. What is the national average, though, for treatment according to the National Institute of Health for the percent of patient improvement we should see?
Mr. Chair, Senator, wonderful question. Not a practitioner or clinician myself. I'll do a quick look back. I don't know that we're going to have that answer. I'm happy to provide that in follow-up. I don't have that off the top of my head. I'm sorry. But I agree with you. I think I understand your question on gauging either national trends or national threshold versus where we're at. I would agree with you that we can get that information.
Thank you, because I thought, well, boy, that sounds good. I looked it up. According to the National Institute of Health, National Library of Medicine, for someone who's received 6 months of the assessment and treatment, 70 to 80% of patients, 70 to 80% should see improvement with a score of at least a drop in 5 points. And I know you referenced 4. So I would just like, when we see that data to have some comparisons, because I don't know in context what that means.
Absolutely.
Thank you, Mr. Chair.
Mr. Chair, we'd be happy to provide some follow-up with that.
Senator Gossage.
Thank you so much for being here and for the thorough presentation. My question actually has to do with billing.
Okay.
So if someone comes in to see a provider and they meet with this person for 15 minutes, do they bill them for the day? Do they bill them for an hour? How are they billed?
So it would depend on what the service is and what the client would need. There are some things that we're looking at as far as our billing code structure and the services allowable that that could trigger a payment, I think is essentially what you're asking. So it really would depend on what the service is or what the client would need after they've had that initial consult and evaluation with the licensed provider and for the appointment, if that makes sense.
So much like a medical visit, they could put down a code of an office visit. And the office visit may take 5 minutes, it may take an hour, but it's still coded as an office visit. Is it similar in this case?
It is not.
Based upon a code?
I'm sorry, go ahead.
No, I'm just saying, is it based upon a code then?
Mr. Chair, Senator, thank you for the question. So essentially, the requirement and what we want to see at the state is that there are services that are supporting what the triggerable rate would be. So if you take something like, I mentioned community psychiatric support and treatment, we would hope to be seeing when the individual is in front of the practitioner, there would be some other supportive services that are also on a claim or a claim submission when they're billing that. That would be the intent. I think, I don't know how that is for hospitals or for primary care. I'm just not an expert in that, but that's what we would want to be seeing. We're looking for an average code. I'm trying not to get too technical, but we're looking for an average CPT or HCPCS code of about 1.3 for where these individuals are billing and also the supplemental services that they're getting. That would mean on average they're receiving 1.3 or 1.5 services whenever they're going into a CCBHC.
Thank you. Thank you, Mr. Chair.
Committee, further questions? Very good. Drew, thank you. Representative Bryce.
Thank you, Mr. Chairman. Thank you, Drew. I want to emphasize what Senator Erickson said. She had to step out, but I think Representative Ballard this morning was mentioning a little discussion we had about the difficulties of measuring outcomes with mental health or measuring quality with mental health as compared with physical therapy or something where you have an endpoint and you reach it, or a cure. With mental health, a lot of times it's a maintenance process over time. But it still can be measured against doing nothing, or it can be measured against doing something else. And what Senator Erickson was bringing up is a lot of these quality measures we're talking about, we spend a whole lot of money with CCBHC models, and we would expect to have more services. We would expect lower waiting times. We would expect to see more patients. To me, that's not an outcome measurement. Outcome measurement would be what's happening to the patients. In other words, like she mentioned, a depression score improving 52%, but we need to compare that to something. We need to compare that to having done nothing or having done another model. How does the 52% compare to that? An outcome measurement of if someone has a schizophrenia, is there a lower suicide rate than if we did nothing? I guess the frustrating thing for me and in previous meetings is there's no real outcome measurement. We spend a whole lot of money and we say we have, when we do have, improved services, but we don't measure what's really happening to people compared to doing nothing or doing something else. And I think that really is what I need as a legislator, to know we're getting a bang for the buck, so to speak, and is what we're doing really effective compared to a control group, basically, if you get down into scientific method. And so I would encourage having outcome measurements not in waiting times and so forth, but having outcome measurements and actual metrics of patient outcomes. And so we can see that we're really making an effect, having an effect on patients' lives. So that's just my input for what I would really like to see as a legislator. Thank you, Mr. Chairman.
I think you echo the majority of this committee, and that's why we're here, is to make sure and measure those outcomes. So I think you're right on track, Representative. Committee, further questions? Okay, very good. Seeing none. Thank you, Drew. Next, we have Kyle Kessler. Kyle? No stranger to this committee. Welcome. It was told me, and 5 seconds later, I forgot. So, okay. And which one is this? Steve, okay, very good. Welcome to committee, Steve.
Points and see if you have any questions. We were involved in the model going all the way back to May of 2020. I think it's really important for us to reconnect and remember the reasons why we pursued this model to begin with. At that time, our system was in a state of crisis. We had multiple challenges, one of them being the Osawatomie census crisis, which I have lots of stories about if you ever want to hear some someday. But the reality was our system was under tremendous threat due to that, due to workforce challenges. At our organization in particular, our neighbors from Oklahoma were ahead of us on the model. We're hiring our employees at entry level, sometimes double or triple what we were able to pay at the time, so our workforce was suffering. We were entering into the COVID era. Accessibility was a serious challenge at that time, particularly given the strain on our system. Our law enforcement partners were frustrated, our schools, we were just really in survival mode, and we were dealing with a payment model that was based on volume versus quality and outcomes, which we've been talking about here today. My predecessor, Greg Hinnom, was involved in the Mental Health Modernization Task Force. That was a bipartisan group, multidisciplinary group that heavily focused on what can we do to improve our system and modernize our system. The CCBHC model was identified. So in 2020, I think we were the first grantee to be awarded the SAMHSA CCBHC expansion grant. There were 6 of us originally. It was a pilot program that has transformed into a system of care. The services that Drew referenced and that I list in my testimony, they have kind of 2 purposes. One is they allow us to examine the needs of our community and deliver services based on what is needed in each community. What we need to do in Coffeyville and Independence and Caney and Sedan looks different than Wichita or Kansas City. And one of the first things we did, he referenced the Assertive Community Treatment Program, which is ACT, that before it was a required EBP, we identified that as a target area from the begin with, because what we were seeing is individuals going into the state hospital, returning, going back, lots of involvement with the legal system, lots of involvement with emergency rooms. So we developed the program and pulled an evidence-based practice that targets that population. One of the outcomes you'll see reference is that in any given quarter, and we have about 60 to 70 individuals served by our ACT program, 90% of those individuals are staying in the community. They are not going to higher levels of care. And the MCOs will not see that data some of the time because a lot of these individuals do not have insurance. They do not have payers, so they're not going to show up on the MCO claims. These other models, other services that we're able to target focus on accessibility. So yes, we are seeing improvement in wait times to get into care. We're also seeing accessibility to certain populations. We serve about 140 veterans on any given quarter, 2,000 new clients served annually. I'm actually going to be going to Chautauqua County in a week and talking about services in that area, which is one of our smallest rural counties. What we've seen is increase of individuals served, but we're seeing a decrease in crisis services, those more expensive services, because we're improving access and meeting people where they're at. Another thing that it does is it really allows us to focus on what does each specific community need regarding crisis. In Independence, we have a 23-hour crisis stabilization unit. We've been able to boost our staff. We average about 20 to 30 admissions per month. Right now, we're showing that 78% of those individuals who discharge are going back to the community. So they're not going to the hospital, they're not going to the emergency room. Once again, lower level cost of care. Drew also mentioned the Supported Employment Program, or IPS, that focuses on individuals with the highest level of needs in our community, schizophrenia, bipolar, those more severe conditions. And we help people get jobs. That's really what that program is. That was my very first internship experience back in Wyandotte County, was a supported employment provider. In Cowley County alone in 2025, we had 29 individuals have successful starts of jobs. Those are outcomes that are positive for the community, improve wellness, improve quality of life. The other thing it's done is really to stabilize our workforce. In this new model, the Prospective Payment System, or PPS, it allows us to deliver services based on costs. And yes, costs have gone up, especially during the implementation phase of this model, but they had to in order for us to keep pace and to survive at that time. I believe they'll level off, and we're starting to see that internally. But ultimately, what that allows us to do is have flexibility in how we provide treatment in the community. It allows us to have much better improved care coordination. We have agreements with emergency rooms, schools, law enforcement. We have special programs in each of those communities to meet the needs where the client is at. I believe in this model. I wouldn't be up here if I didn't. I've seen it change and radically improve the quality of services we're delivering. We're still learning the depression remission measure. Quite honestly, one of the biggest gaps with that is the way we are directed to measure it. We're required to do 6-month reviews of that, and a lot of times people come in, just like in primary care, they get better, they don't come back to complete that 6-month follow-up report, which is really how we track that. So that's one of the reasons why those measures may not compare with maybe other averages, because a lot of times those people are leaving care because they're feeling better, just like they do in primary care sometimes. So we have to track them down. Like I said, the second C in CCBHC is community. It allows us to serve our communities in a purposeful way. The vast majority of our cost goes to our employees who are out there living and working and delivering care. And I believe in the model. I'm thankful for the opportunity to speak to you about it today. I'll entertain any questions at the appropriate time.
Committee questions? Very good. Thank you, Steve, for your testimony. Next, we'll have Kyle Kessler.
Thank you, Mr. Chairman, members of the committee. I'm happy to be here today. I'm Kyle Kessler, Executive Director at the Association of Community Mental Health Centers. We represent all 25 licensed community mental health centers, which are also now all CCBHCs, or Certified Community Behavioral Health Clinics. I clearly didn't coordinate with Commissioner Adkins because he had about 2/3 of my testimony, so I've been feverishly rewriting it over the last 5 to 10 minutes. And so I just want to hit on a few things, and you have our written comments in front of you, and I have 2 additional experts behind us. And Steve talks about being new, but he also testified before Congress a couple years ago at the request of Senator Marshall, and is generally seen as not just a state expert, but a national expert on the CCBHC model. And they were, again, our first CCBHC through the door 4 or 5 years ago now. So our testimony really serves as a primer on the distinction between the community mental health center system and the CCBHC model. Because, and I've seen documents before where there's one column that says CMHC and another one that says FQHC and one that says CCBHC, and I think, let's just put a dash between CMHC and CCBHC, and that would clarify it quite a bit. I think that the tie that really binds the CMHC and CCBHC systems or models is the consistency of services. It's one of the things, and Steve alluded to it as well, some of those Medicaid spends are not going to be reflective of the additional services that are required, because you don't, if I go through the doors of Four County Mental Health or Wyandotte Center, they're not going to first ask me what my payer source is. They're going to connect me with services, and then we get to the payer source. So someone who's fully uninsured or maybe unhoused, homeless, they may not have any insurance, but needs specific and significant psychological or mental health services and treatment. So that's one of the things that I really wanted to underscore. And then in page 2 and page 3 of our testimony, we get into the statutory responsibilities of the community mental health centers, and then the new model of the CCBHC, which again, Commissioner Atkins did a fine job going over, and you all have heard about. And it does get into the specific services and the service array. But even on pages 6 and 7, the data that we're seeing so far, and I want to get back to a question that Representative Bryce and Senator Erickson asked, specific to data and comparative data. I mean, we can be mission-driven and still be data-oriented. I'm clearly a back of the baseball card kind of guy. I want to see what the statistics are and what the data looks like. And for us, there are a couple pieces of that. One, we have to have baselines. And so this first batch of data that we're getting through the data warehouse is going to be extremely important. But then we also do have some other data, comparative data, that we can use to show already early wins with the CCBHC model. A couple of those include data from KDADS on the waiting list for psychiatric residential treatment for youths awaiting admission to those higher levels of care. 3 or 4 years ago, that waiting list was well over 200. 2 weeks ago, it was 25. That is in the same time frame as the CCBHC model and the crisis services that are used. So those are clearly connected levels of success or data. Another one is, according to KDHE, we have 2 years of successive data showing a reduction in loss of death by suicide. And we have 2 years of data that show a reduction in the number of people visiting emergency rooms with suicidal thoughts or ideation. That's down by 13%. So again, these are not necessarily Medicaid-specific individuals or cases, but they are proof that this model, an enhanced model of care, as being the public mental health safety net for the state of Kansas, is working and pretty exciting. I think one other point I'd like to make in terms of the improvement in care, we're looking at a specific software. I don't know that I would necessarily call it a predictive or AI, but it's got some exciting pieces to it. You don't want, to your point, I think, Representative, you don't want people being seen for 2 years when either they're showing no improvement or just showing up to feel, you know, this is what I do. And you don't want therapists or treatment professionals in that situation where, okay, this is a good client to have on here. They'll be fine. We'll get paid. We don't want that either. We want people getting access to care and improving. And then the difference, I think, in some of these new measurements and databases or platforms are that they can track levels of care through the assessments and things like that and clinical notes, and then give kind of almost a runway, so to speak, or an off-ramp to, okay, maybe in two weeks you'll be done with your last session, and then we'll see how you're doing. Because there will clearly some people will need to, if they suffer from severe and persistent mental illness or severe mental illness, they may need to be in treatment or care that long. But you still want to evaluate them and assess them and see if they're making any improvement. The last comment I'll make before turning it over to others behind me is that in response to the conversation about the dual diagnosis group, the people who have both mental health issues as well as intellectual and developmental disabilities, that's been a conversation we've been having for several months. I've met with the CEO of Interhab. We've decided on some general ideas for a specific work group and who would be involved in that. I think it's the right conversation to have at the right time. You know, I think that we had, you know, and certainly and I appreciated the commissioner's comments on this as well, but I think for us, and in fact, I was talking with one of our recently retired executives, and, you know, we don't necessarily, for someone whose primary diagnosis is an intellectual or developmental disability, we also have to be able to work with people who are able to participate in their treatment. And so we may very well be, and I was talking to this executive director, he said, well, absolutely, we work and serve people with intellectual and developmental disabilities, and we also serve, but it doesn't mean we're an expert in that, just like we work with people who have heart conditions, but it doesn't mean we're experts in cardiology. I thought that was a really strong analogy in terms of the comparative piece of treatment. So with that, Mr. Chairman, or Vice Chair, or whoever's next in line of succession here, I would say, I would say yes. Thank you, Ranking Ballard. That concludes my comments for the moment, and I would stand for questions at the appropriate time.
Seeing none.
All right.
Say, but you're off the hook.
Yeah, I'll stay local. Thank you.
Next person, if I'm going down the list, would be Randy Carlstrom.
Thank you, Representative Ballard, members of the committee. Again, my name is Randy Carlstrom. I'm the CEO for Wyandotte Behavioral Health Network. It's my pleasure to be here this afternoon. We've been CCBHC since May of 2022. In that time, I really have seen a transformation of how we are providing services, and most importantly, a transformation of how we're impacting the community of Wyandotte. I think the questions around outcomes is a very valid and important question, and I want to draw just one distinction, that some of the data that we maybe are still working towards is addressing your more typical outpatient mental health clients with mood disorders, like depression, remission, things of that nature. But we're serving a large number of children with severe emotional disorders and adults with severe and persistent mental illness. And some of those outcomes I will address in terms of Wyandotte in my testimony here this afternoon. One of the hallmarks of the CCBHC model is care coordination. And what we know with our SPMI, or severe persistent mental illness population, is that they die 20 to 25% years earlier than the average citizen, largely because they have comorbid health conditions that, as a CMHC, we weren't all that focused on. As a CCBHC, it's one of the primary focuses that we have. In less than about 18 months, in our partnership that we created with the FQHC in Wyandotte County, we have connected over 1,500 of our SPMI clients to a primary care physician, many of whom this is the first time they're getting primary care in many, many years. We've also connected over 829 individuals to other community services in the, as well. In terms of working with IDD population, I just do want to mention that they are part of the service array that we provide in terms of crisis services and in terms of case management for those individuals that have comorbid mental health and IDD diagnosis. ABA, or Applied Behavioral Analysis, is not a CCBHC service, but we provide anybody the crisis services that they come in, services that they meet medical necessity for the services that we're able to provide. And if we're not able to help them, our care coordination team is helping them connect them up to the community development organizations or other services. And we stay with them until they're getting the services that they are needing. Mobile crisis response is also a CCBHC service that did not exist prior to May of 2022 in Wyandotte County. In the last 8 months, we have responded to nearly 450 individuals who are in crisis in the community. 76% of those crises were resolved in the community, preventing them from going into the hospital emergency department, the state hospital, or going into jail. We have a long-lasting partnership with the juvenile justice and the adult justice system in Wyandotte County. In 2025, we responded through our co-responders with a CIT officer to over 1,600 mental health calls in in Wyandotte County. Those calls all came through the 911 system. And our Crisis Stabilization Center, RSI, in 2025 served over 2,200 individuals. 20% are brought by law enforcement. These are 2,200 individuals that, if the state hospital were able to take voluntary patients more frequently, back in the day, without these services, these are individuals that more than likely would have gone to Osawatomie State Hospital. We're also the 988 call center in Wyandotte County. This last year, we responded or answered over 5,100 calls. And our vocational program that Steve mentioned, IPS, which is a CCABHC evidence-based practice. This last quarter, we helped 40 of our adult SPMI clients started new jobs. Prior to May of 2022, we were reimbursed at really 2,000 levels, which is the Medicaid fee-for-service rates still today. Since then, the Consumer Price Index has gone up 75%. Our salaries for a starting therapist in 2021 was $46,000. We had therapist positions that went vacant for literally for years because a brand new master's level clinician coming out of college or graduate school was asking for $60,000 to $65,000 at the time. We were not even close. When we did one time, and when we did our first cost report, we were able to do one anticipated cost enhancement. Most of that, all of that almost, was for salaries. And when we looked at like organizations, including schools, child welfare providers, et cetera, what we found is that our staff were underpaid by the market by 20 to 40%. We're now able to keep and retain those employees, which has completely diminished the calls that I would get from parents or from individual clients that were on their 4th or 5th therapist or case manager that year. Those things don't happen now. Our turnover rate in 2021 was 50%. Last year, our case management and therapist turnover rate was 18%. We have more experienced staff. We have staff who know their clients. Clients are having continuity of care. All of those are really, maybe they're not behavioral outcomes, but those are very important process outcomes. And again, as Steve Denny mentioned, we provide these services to everybody. Only 46% of our clients have Medicaid, but everybody gets every CCBHC service that we provide. 36% of our clients have no resources whatsoever. Last year, we provided over $5.2 million in uncompensated care. That's at the fee-for-service rates. If we took the number of uncompensated care that we provided by our PPS rate, it would have been over $10 million of uncompensated care. I will conclude my testimony for the day, but happy to answer any questions at the appropriate time.
Very good, Steve. Thank you. Representative Reeves.
Thank you, Randy, for your presentation. The data that you've given is perfect. I mean, because this is what we had always envisioned, that there would be more stability, especially in the workforce, because salaries were going up. And I know that the therapists were very, very underpaid. Yeah, I mean, I think this is really good news. And again, it's exactly what I know that I had hoped to see, converting now to the CCBHC system. So thank you.
Committee, further questions? Representative Ballard.
Thank you. Just one briefly.
Briefly.
I think the question would be, it's the additional money that's making a difference, but it might also be the additional training. Would you comment on that?
Yes, thank you, Representative Ballard. I would completely agree. And I think the training goes into the cost of turnover, when we had a 50% turnover rate, our case managers come in, they go through our internal training, they go through statewide training, and then they were leaving. So the continuity of care that I mentioned, I think, is such a critical piece of that, because we're getting folks trained and then they're getting continued learning. I've learned so much in my career from our clients. But if I've only, and I've been there for 33 years, but if I'd been there for 6 months, that's only 6 months of learning. With our therapist, the continuity of there, this is not easy work. It really is difficult work, and there is not a standard operating procedure for each individual that comes into a mental health center. They bring their own complexities, they bring a unique history of trauma, poverty, et cetera. So the life experience or the clinical experience of working with clients is invaluable beyond graduate school, beyond a PhD study. And you don't get that experience when you're staying in a job for less than a year.
I want to thank you very much. And what you reported is, you know, the calls that you have had, but in terms of the turnover rate, that's really amazing, you know, to go from 50% to 18%. And part of that is satisfaction in job, but it's additional money and it's everything else. So thank you for your presentation today.
Thank you.
Committee, further questions? Seeing none, thank you, Randy, for being here.
Thank you, Mr. Chair.
Okay, next we have Steve. And Steve, you're the last person for the day, so
Ain't in the way, right?
don't expect a lot of questions.
That's all right with me. Good afternoon, committee. My name is Stevie Durkin. I'm the Chief Executive Officer of the Guidance Center, CMHC and CCBHC that serves Atchison, Leavenworth, and Jefferson County. Benefit of being last is like these gentlemen have said a whole bunch of information that would really be repeating what I put in my written testimony. But specific to the Guidance Center, I just wanted to share a few things that's unique about our path. So in previous other committees, I have presented that my career started at the Guidance Center. I was a student in grad school, and I was able to come back as an employee and serve my hometown community of Atchison. At that time, it was 2008. I left the organization in 2017 to become the CEO of a federally qualified health center, also 2.5 miles up the street in Atchison, Kansas. I had the opportunity to rejoin the Guidance Center in August of 2024. And like I've said before, and I know Representative Bueller knows this, I came back to a vastly different organization. And part of what I learned when I came back to the organization is that pre-CCBHC, there was a time where the Leavenworth office had one clinician. Our biggest office had one therapist, which was just heartbreaking to me. But it was reflective of the need to address the workforce, right? So at this point, we received provisional status as a CCBHC in 2023, full certification in 2024. While we're still growing in our workforce, I can proudly report that we've got 20 clinicians serving Leavenworth County. Our Atchison office has always been a relatively stable group, but they are even adding on additional staff. So there's 2 more, and we've done some partnerships with juvenile justice in the community to offer services over there. But I think that's a really important thing to hone in on, that in our biggest office, we were at 1 clinician at one point. Specific to the Guidance Center, you know, one of the biggest things that we've had to address since I've returned to the organization is really investing in making sure that our electronic health record is set up in a way that can collect all of the data that you all are asking for and that we need internally to make sure that the services that we are delivering are efficient, appropriate, and cost-effective. And ultimately, so that we can evaluate that patients are getting better as a result of the care that we're getting. 2 weeks ago, I would love to tell you we're there. 2 weeks ago, we kind of flipped over to a new EHR, and so we are excited to really dive into the world of data. As I mentioned, I was in an FQHC for 7 or 8 years, very familiar with the data scene. This is a new life that we are living specifically at the Guidance Center when it comes to data, and I look forward to that. A couple things that I just wanted to highlight in my written testimony. When it comes to making sure that these outcomes are here, where I feel like we're getting a lot of the positive feedback is from collaborative relationships with our community partners. So I will kind of hone in on our co-responder model and our mobile crisis response that we've got going in all 3 counties. Those teams are achieving an 88% diversion rate. So they're making sure that individuals that can stay in the community, that we can wrap services around. Oftentimes it's the first time we engage with them, but we're preventing unnecessary incarcerations, unnecessary ER admissions, and things like that. So ultimately, we're able to engage with those individuals and provide the appropriate level of care. I know that you all expected me to come up here and talk about how great a work that we're doing at the Guidance Center. I'm so proud of the team, so that remains true. But I do want to share one quote on the same kind of level of the care coordination. One thing that I've really appreciated is our interactions, not only with the KDADS team, and I applaud their effort to really come out and meet with us once a month. I look forward to that process, but also with the MCOs. So we go through quality calls, right? At least every other month, where we're talking about what data are you seeing, what positive benefits are you seeing, and what areas of concern are you seeing. I did tell this individual that I wouldn't specify which MCO. I didn't get permission to share which one. I don't know that it'd be an issue. But one of the things that she shared in feedback is that only 5% of our patients that are attributed to that MCO had inpatient hospitalizations, and only 4% of that 5% had readmissions within 30 days. So she goes on to say that this is obviously, it reflects something truly important. Your patients are gaining stability and sustaining it. These numbers are not just metrics. They represent individuals whose care plans are working, whose crises are being prevented rather than escalated, and whose lives are being meaningfully supported by the care that you provide. I think that's important to have those relationships and have that dialogue. The CCBHC program is allowing us to do that. The CCBHC, from the Guidance Center's perspective, has allowed us to invest in the technology to support and gather data so that we can report it back to you all. I look forward to, in the future, telling you that we've got that all ironed out, but we're on board with that data and making sure that the return on investment is there. So with that, I probably went a little bit long, but I stand for any questions that you may have.
Very good. Thank you for that. Committee questions? All right.
He intimidated us.
Well, I didn't mean to, but I'm already 40 minutes over the scheduled time, so I figured I was. So anyway, and I agree, that was an excellent overview, but I think some of us want some real data. You know, I get it that you're, and I hope I'm speaking for the committee, I get it that you're serving more people, but we want to know how those people are doing. You know, just serving more people, that's great, but I'm looking for data about how effective you guys are. And so what I expect is in August, we will have our next meeting in August. And that's when I want real data, meat and potatoes, you know, data that shows how you're serving these people and how much better they are. And I think maybe the other committee members might agree with me on that. Representative Reeves.
I think it'd be helpful if we can come up with something more concrete than that. It's because I'm trying to envision being, you know, within the mental health system, trying to envision what data that you are specifically wanting to see. There's a lot. As you can see, the CCBHC system is extensive. So, do we want data attached to each of the 9 requirements? Or is it about if people are getting better, then we've already talked about it's hard to find that base, you know, to find out whether people are getting better. People a lot of the folks that are being served have chronic mental illnesses. It's not going to go away. And so there's going to be ups and downs that come along with that. So I'm not sure what data it is that you're specifically wanting them to bring back.
I'm certainly open for suggestions about that data. Representative Bueller?
Yeah, and I might just make a suggestion, and I will just play this out. And if you go back and look at the way the budget process evolved in the most recently concluded session, there were starting to be questions about how much money in the Kansas budget how much funding towards mental health has increased over the last 3 or 4 years relative to the CCBHC model. So there is a clear data point of, okay, the state is making this investment. The flip side of that is help us defend what that investment is delivering. So, and make it as subjective as possible. Stevie, I believe everything you're saying because I live in the community and I've been, and Randy, I have seen you, my first time 4 years ago in Health and Human Services Commission, or pardon me, Health and Human Services Committee, you were telling the story of how terrible it was. It was before the investment, essentially. So we're now 4 years past that. So think of it in those terms and help us build the case, because when we come back here in January or February and we look at whether it's through KDADS or whatever, here is the budget that we're looking for. We need to be able to say this is what it brought to the state of Kansas. And that's, to me, perhaps the easiest way to look at it. And if there are other comments beyond that.
Representative Bryce.
Yeah, I just echo what Representative Bueller said, and the kind of data that I'm looking for, my instinct is you have to compare. You have to compare what we're doing to either having done nothing like before, or there's got to be a control group. So the data that we have now compared to MCHC model or what have you, but it's a comparison basically against a control group or another group. So if that helps explain anything, Representative Ruiz, I'm sorry.
Representative Ballard.
Mr. I'll comment on it. I guess when I was a doctoral student, it was interesting, and I was doing my practicum, it was interesting. When they said, we're going to evaluate you, and I said, on what? And the person said, you're the therapist. You are going to have to figure out what it is your client needs. And then how are you going to help them? And I want you to bring it back to me how you did that and from where they started to where they are. I heard you make the comment, you are collecting data and you're very excited about the data that you are collecting. For me, I would like to hear what you have and what all the others have and how you have seen it and presented. And if I have questions or need clarification, I would ask. But for me to say, I need to see this, 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 and this, well, you're going to have so many different kinds of people that you're treating that you're going to have to adjust your model to fit those needs for us to get the information. So I would say bring it back the way you saw it in terms of improvement, and we can take it from there as to, was this what we were looking for? Did it answer our questions? Did it alleviate any anxiety I might have? And if I think there's something missing, we'll ask about that. But I've always believed, let the people do it and the experts tell me what they were doing, and we'll take it from there. So I'm pretty simple in that respect.
Well, I realize there are chronic folks that are never going to, improve or whatever, and you're going to continue. But there seems to me like there should be some measurements that are, we've seen these people 5 times or we've not ever seen them again after a certain period of time. But measurements of improvement, it just seems to me like they're, You know, I'm certainly not a mental health expert, but it just seems to me like there are some data that could prove the value, not just anecdotal, you know, about suicide prevention or PRTFs, but some actual data about visits and, you know, that kind of stuff. So why don't you guys, as you think about stuff, email me some stuff that you're looking for, and we'll get that. But in August, we will take another look. And I appreciate the overall nuts and bolts of how the CCBHC, I think that was good. Drew, you did a great job. You guys did a good job of explaining to us how it works. And now we're kind of looking at where the rubber meets the road type of information. So,
It was good. It was very good.
yeah, I appreciate it. So committee, anything else? Oh, approval of minutes. Do I have a motion to approve the minutes? I have a motion. I have a second by Representative Ballard.
Yeah, I said it.
All in favor, say aye. Motion approved. Minutes are approved. Anything else, committee, before we go? Thank you for staying here. I apologize for running over. I knew it was going to kind of be a long afternoon, but I did want to, we got there. And so until August, I have no idea. What? Yeah. Yeah. August, what? 11th? August 11th. Yep. We're adjourned.